innovation, intelligence, outcomes, and real impact. We are delighted to see many of you bright and early for what promises to be a powerful day of learning and collaboration. On behalf of the organizing partners, Apollo Hospitals and Apollo Foundation thanks you for being here and for being part of the growing global movement to transform healthcare through technology. Let's begin day 2. Moving forward, for our opening session focuses on evolving digital health, real-time implementation in India. Our chairperson, Dr. Krishna Chaitanya Kandala. To set the tone for the morning, we begin with real stories from the field, where digital health is not a concept, but a working reality. It is my privilege to invite our chairperson for the session, Dr. Krishna Chaitanya Kandala, Chief Medical Information Officer, Apollo Hospitals. Please put your hands together while he addresses the stage, please. Dr. Kandala brings deep clinical and digital leadership and has been at the forefront of translating innovation, the patient outcome across the Apollo ecosystem. Sir, we are honored to have you here on the stage. May I also invite the speakers for the session. Kindly join us, Dr. Deepika Pamarti, Director, Strategic Research and Partnerships, Cardion Bio. Dr. Vishal Kumar Jani, Practo Technologies Private Limited, India. Please put your hands together while they come on the stage. May I also invite Colonel Suma Subbarao, General Manager Nursing, Apollo Hospitals, Banargata. Please put your hands together. Ms. Himangi Santosh Sawant, ML Engineer, General AI and LLMS, Apollo Clinical AI Labs. Please put your hands together. And lastly, Ms. K.N. Chetna, Clinical Resource Coordinator, Clinical AI Lab.
Hi, a very good morning to you all, the attendees, ladies and gentlemen, innovators, healthcare professionals, technologists and tech entrepreneurs and doc entrepreneurs. Very briefly, I come from a clinical background, but have waded my way deep into the tech spaces. And I find that interesting with the advent of AI coming into the scene, or rather exploding into the scene. It has given a lot of tools for healthcare professionals to kind of work on these, come up with their own algorithms to implement them within the technology space. And what we see is going to amplify much more as we go forward. While the technologies would be collaboratively working, supporting, as the domain specialists wade deeper and deeper into these lake shores, so to say, and come up with more innovative solutions and products. So this particular session is reflective of that thought and that idea, where we have Dr. Deepika, who is a healthcare professional herself, who is actively working on AI-generated liver disease tracking and also pattern recognition. And then we have Colonel Suma out here, who's heading the nursing department. And she has her own take on how to manage patients from a nursing perspective, taking care of their emotional needs, their physiological needs while the pathology is progressing, and also going beyond the hospital, ensuring how they can take care beyond the hospital premises of the patient. And we are ably supported by another doctor, Dr. Vishal Jani, from the Practo, and of course, two young ladies out here who give us the tech support and coordination clinically. So let's set the stage. First, Dr. Deepika.
Good morning all. Thank you for joining in. My name is Dr. Deepika Pamarthi and I work for Carry On Bio. We are an AI-first startup company based in California. And today I'm here to discuss a few highlights of our currently ongoing research projects involving agentic AI. So the title is AI-assisted decision support for comprehensive liver health assessment. As you can see, our motto and vision is to democratize liver health assessment across all healthcare settings. By this, we mean we want to take our solutions all the way where minimal data sets can also be analyzed, especially in those rural settings or low resource areas where advanced technology or advanced blood-based testing may not be available, and access to things like ultrasound or MRI or advanced imaging modalities may also be not available. So we want to take our solutions to those areas as well as tailor platforms for corporate settings where every of these comprehensive tests are available and accessible. So coming to the focus of our problem, we are working on metabolic associated liver disease, and this is mainly a problem now due to the current lifestyle, obesity, and other comorbidities like diabetes and cardiovascular and metabolic syndrome type of symptoms and disorders. So this disease is treatable if managed and caught early and detected early. So our goal is to also screen patients early enough and also be able to give them access to advanced AI tools which will help them be triaged and notified to the hepatologists early enough, and this will enable treatment at a much early stage, and the disease can also be reversed. So other problems that we commonly encounter are low awareness, delayed diagnosis, and data variability. So even with the currently available traditional methods of analysis or even basic AI tools, there is issues with specific types of data and data fragmentation and problems with the IT infrastructure in certain regions. So we have come up with a unified solution which can analyze all types of data and bring about useful solutions for patients, for insurers, as well as the hepatologists and specialized doctors who treat liver diseases. So our goal is to make models as accurate as possible, and we can also scale them and to the level that we can even analyze the lowest form in like demographics and population survey type of data, and also offer solutions for imaging, MRI, and other technologies which are coming up. And since AI is changing at a very fast rate, we are trying to build solutions and evolve from the scratch. So our hierarchy is adaptive, and we start off with a hepatosteatosis risk engine, where we have 4 or 3 tiers mainly. At the basic level, we accept questionnaire-based or population kind of survey data, which can also give some useful insights to the doctors. And we then also have an anthropometry-based models, which includes the body measures, BMI, and other parameters that are very generic. And then we add on more data sets like vitals and metabolic markers, and then at tier 3, we have additional liver function tests, which are mostly available in corporate and urban setting hospitals. So besides these, as you can see the workflow in the hepatosteatosis risk engine, this is a very flexible platform, and AI will choose whatever subtype of data it is ingesting and come up with a quick output, and this will really help the doctors get insight to immediately take the next steps or plan a treatment. Separately, we also have a fibrosis risk engine, and this is for staging and also detecting fibrosis, especially even in advanced countries like the United States. Fibrosis staging is very important because statistics already say that more than 70 or 80% of the patients have F2 plus fibrosis, which is going undiagnosed. So if we are able to capture those patients and triage them and put them back in the care pathway, we'll be helping reverse their condition. And lastly, we have an advanced liver image analysis platform. This will analyze all types of data sets, starting from ultrasound and CT, MRI, and so on. It's not moving. Sorry about that, it's not moving. Can you help? Sorry about that.
I think it's changing.
It's not going back or forward. Oh,
I think you have to point out here, maybe.
yeah, so I probably can look over here. Yeah, so this one platform is useful for 4 critical use cases. Number 1 is for patient education, where we can empower the patients with their health condition through LLM generated explainable insights. And this is the basic model that we have. And then moving on to population screening, where awareness campaigns with limited data sets can also use basic data like lifestyle or demography and anthropometry. And as you see, our hepatosteatosis risk engine at tier 0 and 1 is enabling this type of population survey analysis. And then for insurance companies, these stakeholders also are very important in the medical system, because patients can get the appropriate insurance coverage, and claims processing can be done seamlessly if we are able to risk stratify the patients and give accurate outputs. And this is at our tier 2. And lastly, for clinical practitioners, including the hepatologists, this is very important to identify stages of disease that is progressed far enough, and precise diagnosis is very important at this stage, and because the treatment planning will depend on the exact stage of fibrosis or steatosis. And also the models at tier 3, 4, and 5 are enabling this as we accrue more and more data sets comprehensively. So we have a strong validation with the fibrosis and steatosis risk engines. At 77% accuracy for fibrosis, this is a very clinically significant number, and we want to accrue more data sets and analyze better and come up with more refinement and robust models. And as you see, for the steatosis progression, we have achieved 73, 75, and 81% as we incorporate more and more data comprehensively at the last stage or tier 5. So our main strength now with these initial studies and research platforms that we have built is that everything is adaptable, and the same platform can scale screening data. It can also handle advanced clinical imaging data, and the single system is using the same AI logic and appropriately making intelligent decisions in the back end to access its particular data subtype as the data gets ingested. And then the LLM feature is also helping build the patient and doctor trust or clinician trust, where the tool nudges the patient to understand their disease and seek the appropriate medical intervention. And then for clinical validation, since we have completed preliminary studies with whatever the data we have right now, strong fibrosis results make us think that we are ready to deploy in the real clinic, and significant steatosis results are also ready for deployment. And there is need for prospective validation, and currently we are seeking partnerships and collaboration to go forth with the prospective cohorts and build some networks within India and multiple geographies. And the future directions, we are looking to measure the time to elastography so that immediate attention from the hepatologist can help the patients go to the necessary care pathway. And then for F2 plus flagging, we are also building software as medical device modality, which will help triage and notify in real world workflows. And multimodal integration is also of our interest lately. We have been looking into advanced modalities like imaging and including multiomics from genomics, metabolomics, proteomics, and so on and so forth. And since the blueprint or the base model and platform for the liver disease is ready with us, we plan to expand to other comorbidities like diabetes, cardiovascular, obesity, and metabolic syndrome. And lastly, I would end this conversation on a positive note that AI-assisted decision support system can help us, all of us, in fact, clinicians, insurers, and patients, right where they are with the exact amount of data they come with. Even the minimal data can give us some insights, and as we add advanced data, there will be a lot more clarity and breadth of understanding for the physician as well as the patient. And we want to provide this liver health insight for all strata of patients, whether it is in the rural setting or whether it's in the urban. But we are refining our models and working on strategies to build connections within India, Saudi Arabia, and Hong Kong. And thank you for your attention, and please feel free to connect with us and contact me or the company. You can browse the website, and I'm on LinkedIn as well, so we can take these conversations further and do something together. Thank you.
Thank you, Dr. Deepika. It's a very expansive space that which you have tried to capture, because recent articles again within the Indian context, especially within the IT workforce. In fact, we were just now discussing prior to coming on the stage about the prevalence of steatohepatitis, fatty liver related conditions that needs to be addressed, identified. And I believe these interventions from your side are a step in the right direction that we can reach out to the population. So I'll ask the next speaker, Colonel Suma, to please take on the stage and explain to us about her vision of how nursing care plan should be. Madam, thank you.
Namaste and a very warm good morning to all of you. I'm here to speak about how AI has helped us to provide clinical support to the nurses when it comes to decision making. As you all know, that the doctors basically do the assessment for patient and derive at a diagnosis, whereas the nurses understand the patient's reaction to illness, like it could be a physical, the emotional, the social, and the spiritual needs that the patient require while they are ill. So the nursing care plans are based on the patient's reaction to illness. So what the nurse has to do to provide a holistic care to the patient. Like if the patient has a physical condition and the patient is in pain, the patient is having a cardiac illness, or the patient is having respiratory issues. So what the nurse has to do to take care of that? Apart from that, how the nurse has to deal with the emotional needs of the patient as well as the family, and what health education she is supposed to provide them so that they are able to understand how to take care of themselves at home. So this AI is helping the nurse to develop a care plan, so which will help her when she needs to escalate the patient's conditions to the physicians, and when she is able to provide emotional support in case of anxiety, in case of problems. So that is how this AI has helped us, and so we have developed the AI generated nursing care plan application. Can I go? Okay, so this is based, it assists the nurses by generating patient-specific care plans. Like, it is tailor-made for each patient. It is not applicable to only one patient and then. So it is based on the diagnosis, the vitals, the history, signs and symptoms and complaints. And the system retrieves the relevant informations. So these plans are validated against the ICNP as well as the NANDANA, this North American Nurses Diagnostic Association standards, and it ensures accuracy, interoperability and global applicability. So the final output that the care plan provides is generating a nursing diagnosis, then the assessments, the goals, the intervention and the rationale. Why this particular thing has to happen, the scientific rationale behind it is also used in this. So this definitely, this care plan has the approval by MDA's SAP, the ISO as well as the UDI. So that is how it is, and we also have patent for this. So this care plan is developed along with our AI, Apollo AI team. So why this particular care plan is required? What was the current problem? Because it is very time consuming and definitely there is no standard. So each one writes their own way. So we wanted to standardize the care plan, and the primary objective was to generate accurate, standardized and clinically appropriate nursing care plans using the AI. And the secondary objective was to ensure alignment with expert nursing practice and evidence-based guidelines, and to improve nursing workflow efficiency by reducing the time and the manual effort, and to maintain clinical safety and reliability with minimal omissions or errors. So you will also have to understand that the final clinical judgment is done by the nurse, but definitely the AI supports the nurse in taking a clinical judgment. So what is the impact of this NCP application? It has definitely reduced the documentation time, because it is very not possible for the nurse to sit and write the care plan every shift, and it has also standardized the practice, and it has supported for the clinical judgment, and it has improved prioritization. So the AI is also telling that which priority is required, which the nurse has to take the first priority, and it has enhanced clinical decision support, and it has improved continuity of care. So where have we implemented? We have rolled out in Apollo Bangalore and Delhi, Chennai as well as in Navi Mumbai. So we will be rolling out Pan Apollo very soon, and it is now, we found that it is 60 to 70% faster care plans are generated, and more than 95% care plans have been implemented, and there is reduced documentation on fatigue across the nursing units. These are the outcomes that we have generated after the use of the AI, and there are quicker post-handover readiness is there, and of course we have achieved standardized care plans across units. And my team, I should tell you, because since we initially started with our unit, my nurses are super happy now using this, because it has definitely helped them. So with the methodology and evaluation, I asked Ms. Himangi to take over.
We have Dr. Himangi coming in to explain the methodology of this process.
Good morning. I'll just briefly walk us through the methodology of this NCP GenAI. So we begin with the patient data collection, that care plans will be based on. So before we begin any processing, we apply PII anonymization. So what it basically does is removes any personally identifiable information like patient names or UHIDs. Once that is done, further clinical entity recognizer takes place. So it extracts key medical terms or entities like symptoms, diagnosis, or if any procedure names are mentioned in the patient data. Now this anonymized patient data along with the clinical entities are used to retrieve some relevant information from trusted resources using RAG, that is Retrieval Augmented Generation. Now whatever the context that we have got till here, that is further provided to the large language model. Now the task of LLM here is just to structure the information that is provided into the format of nursing care plans, while ensuring that output that is being generated is entirely patient specific, along with it is evidence based. So the care plans that we got, to measure the reliability and the integrity of the outputs, we performed some performance evaluations. We subjected the model to multidimensional evaluation. First, we started with the groundness, where we saw how relevant the output generated are to the retrieved information. We also assessed the hallucination rate, where we observed that whatever the care plans are being generated are strictly adherent to the patient scenario that is being retrieved, along with the contextual relevance, where we saw that there is no extra information is being generated than the provided. Finally, on the grounds of safety and alignment, the careful prompt engineering prevents any generation of harmful or inappropriate content. Now, with this context in place, I'll invite Ms. Chetna to show the end-to-end demonstration of this NCP.
Welcome to Nursing Care Plan portal. After login, users are redirected to the home page where they can click Take Me to App to enter the dashboard. From the dashboard, they can select New Patient and enter patient details. By clicking Generate Care Plan, the portal initiates the creation of a comprehensive nursing care plan. The system draws on trusted medical resources. It analyzes the provided inputs, prioritizes critical elements, and generates a patient-specific care plan. Each nursing diagnosis is organized into key sections: assessments, goals, interventions, and rationale. And each of these components can be unticked and user can save the care plan and print them, helping streamline and improve the efficiency of the nursing care plan workflow. The portal supports priority-based organization, allowing users to select a specific nursing diagnosis and view its components in a structured priority order, supporting informed decision-making and personalized patient care. Nurses can also submit feedback to share insights and suggestions, helping refine and enhance future updates. Users can click Back to Patient to view previous records, add a new patient, or proceed to log out. Thank you.
There's a small technical
Welcome
glitch.
So hello everyone. What makes this product different than the technology is the access to the nursing ecosystem that we have in Apollo hospitals. The first scale of nursing expertise that we have in Apollo hospitals and end-to-end nurse core creation. We have the nursing team support from ideation stage to deployment and the real-world clinical evaluation and embeddings of clinical governance and operational proof. As Suma ma'am said, we have rolled out the tool in different Apollo centers like BG Road and Chennai. We have got good feedback from nurses and the adoption rate is high. And implementation, we have proved that we have implemented the tool in scale in different Apollo hospitals. And if anyone want to see the live demo, please visit us at Apollo Hospital's stall. Thank you, everyone.
Thank you, Ms. Chetna. I have a few questions to the team. While I understand it's a RAG-based approach that has been taken, is it open to interpretation? Do you have any guardrails in place while you are generating these care plans. And you can take the mic out there. Yeah. Interestingly, also what I observed was you used a form field for generating your care plans that restricts the type of information that is sent out to your LLM. So would you like to elaborate on that?
So this is a standalone application where we have kept the input form-like structure, but we are working on EMR integration within the Apollo hospital. So once we are integrated with any EMR technologies, any EMR systems, we can directly take the patient data with just one hit, and all the nurses have to do is just click on one button that will be there to generate the care plans. So this is just a standalone application for the demo purposes, but we can directly take the patient data from EMR systems.
Okay. And my second question is to Ms. Chetana. How do you see the feedback? Are you tracking on the feedback of how the nurses are
Yes, sir.
actually, is it a quantitative or a qualitative feedback?
We have actually both, sir. We have in-app feedback form in the app where nurses can give the feedback for each nursing care plan that is generated. And we also conduct weekly interviews and weekly feedback sessions from each region. So that, and even we collect feedback from multiple specialities so that we can see gaps in multiple specialities. If any gap is there, we are even addressing, and we improved the tool a lot after deployment.
So we'd love to see the metrics going forward for these feedback that which you've got. And any plans to further explore this or expand the scope of this?
Yes, sir, we want to take it up globally.
You want to take it up globally. How about expanding the domain as such? I believe currently, yes, ma'am.
So we wanted to, based on this, we want to generate this one patient and family education based on this. It's a printed format which we can give it to the patient, as well as it will help the nurse to even educate the patient better. So that is our, expansion plans now.
So,
based on this.
Essentially, it is to continue the care continuum beyond the hospital so that they can plan on the interventions and how to take care of the patient, educate them. Okay. Thank you. Now, I'd like to invite Dr. Vishal Jani from Practo to give his talk.
Good morning, all. Thank you to THIT, IHD, Apollo Group to give this opportunity to present what we are doing at Practo. I'm Dr. Vishal Jani. I head the research efforts at Practo. And we are in the process of building AI-based clinical decision support system, consumer-facing AI, doctor-facing AI, and whatever I'm going to present is like a data that, or the intelligence that we have from our telemedicine platform that we are using to strengthen our tools. So let me give you some background. Practo being the largest digital healthcare player and one of the largest non-providers, so non-hospital telemedicine player in India, we do close to 1 lakh teleconsultations a month. So that's a very heavy data. So what we wanted to do is looking at that data, analyzing what's happening between patient and doctor, can we really come up with how to improve quality? And can we, in real time, reduce the error and improve quality? So we can give prompts to doctor. We can kind of avoid any error that's happening at a primary care or the consultation level. That's the purpose. For that, we created a 22 parameter based audit framework which came from consultations and meeting different experts. Delphi method was adopted. And then we adopted this 22 parameter based audit framework. We have an internal medical team of doctors which look at each and every not each and every teleconsultation, but the sample of teleconsultations, look at the video, the chat, the conversation that's happening between doctor and patient, and assess the consultation based on these 22 parameters. So just to give you what are these 22 parameters, it's very basic. It starts with history taking. So what should be the basics of history taking? What should be asked, should not be asked for differential diagnosis, what should have been covered, not covered. doctor missed something, so those kind of parameters. Then it goes into prescription based on the differential diagnosis or whatever is the provisional diagnosis. Was the prescription accurate? Was there any over-prescription of drugs or over-prescription of diagnostic tests? All those things are covered. Then the communication part of it. Was doctor attentive, empathetic? So essentially the audit team, the medical doctors team which do the audit, looks at the consultation based on these 22 parameters and give 1 0 against each parameter. So essentially we get a binary over 22 variables. And then the outcome measures are customer satisfaction and something that we call patient-reported medical efficacy. It's nothing but a recovery rate that is measured on the 21st day on the, after the consultation. And customer satisfaction is just after the consultation, within 5 or 10 minutes, and customer rates us. So to avoid all the statistics and everything and with paucity of time, based on those 22 parameters, we ran a factor analysis to figure out what are the main dimensions which are independent of each other but still have important impact on the CSAT and the PRME. So these are the main 3 dimensions that really help improving quality in telemedicine: communication quality, clinical thoroughness, and rational care. So when I meant communication quality, it's clarity of instruction, summarization of the entire consultation, telling the patient what has to be done, etc. Empathy, clinical thoroughness is your history elicitation, differential diagnosis, you did not miss any red flag questions, and rational care practice is avoiding unnecessary medical interventions. So then we applied, using those factors, we applied it onto outcome variables in a logistic regression framework, and this is what came out. So all 3 are important, but most important comes out to be communication quality and the clinical thoroughness. So the key driver is communication, and we all already know that in a teleconsultation, when it's not physically meeting the patient, it's how actually doctor elicit different symptoms, how doctor can actually understand what's happening with the patient. That is really the important or the main pillar of the quality. And then what drives recovery? So when we move to recovery, the important thing here is the rationality of the care, the over-prescription and all those things are not really playing a role. So it essentially boils down to, did patient felt trust on the doctor, which comes through communication quality and the clinical thoroughness, whether all the questions were answered, enough questions were asked, all those things, whether patient felt heard in the consultation. So it develops trust, and that trust results in better patient adherence or the treatment adherence, which results in recovery. Somehow rational care is not playing any role there. But the important thing is, the moment I add customer satisfaction as an independent variable, along with those 3 dimensions, most of the variation in the recovery rate is explained by CSAT. What does it mean? It means that this framework is really important, and it has 2 impacts. One is it impacts CSAT, trust, and hence the recovery rate. And other is, because there is this clinical thoroughness and all those things, it really directly also impacts the recovery rate. And these are some of the actionable recommendations. So communication training, clinical protocols should be developed, specialty, specific support, and audit framework. So this is the base study on which we are developing our newer products. So we are developing products on the consumer side. We are developing products on the doctor side as well, where there is a real-time decision support system where I'm doing a teleconsultation, and on my screen, as I'm speaking with the patient, I get prompts that you missed this, or you should have asked this. Even it gives prompts like, if I missed the question from the patient, I did not answer that. It would give me that prompt that you missed this question. Patient asked, but you haven't yet answered. So that's how we want to reduce the error rate and customer satisfaction at the real-time consultation. And so that's where we are thinking of improving health outcomes in the system. Yeah, thank you. And I also want to take this opportunity to thank my academic collaborator, Dr. Nafisa Awaz. She is also here. Yeah, thanks. Thank you.
Thank you, Dr. Jani. Have an interesting question, and it's a very interesting work that which you're doing. Now, with a lot of modalities of consultation coming out to be through the online platforms, and that helps us to kind of penetrate deeper into the underserved areas too. Where you also, do you have any plans to see how these visual cues, identify specific visual cues through all the videos that which you have of the consultation, and then compare that vis-a-vis with what are the patient satisfaction scores? The purpose being to identify what visual cues would generate the best level of patient satisfaction scores. I'm not saying that entirely dependent only on the visual cues, but they do play a certain part, and maybe that might help tomorrow to train the doctors or the healthcare professionals when they are trying to interact and create a kind of a online video etiquette to follow to ensure that there is more alignment between the patient and the doctor. Your thoughts on that?
Yeah. So we already have an internal tool, because one of the important variable here was communication quality. And as of now, whatever data I showed is based on medical doctors doing those audits. But those audits are based on some sample teleconsultation. So we created an AI tool which actually looks at video etiquette of doctors. That tool is already in place at Preventive, but we are still working on the specificity and accuracy of that. We still at a stage where the tool is in place, it looks at each and every video consultation, it generates a summary, it also gives us action points that a doctor should think about in a consultation. But still it's not at the stage where we are comfortable sharing a report of each and every consultation with the doctor, because we are still assessing ourselves internally. We have a separate team doing that. We have communication experts working on it. So we have already created it. So then once that tool is also online, so it will again help. So it covers everything: verbal clue, non-verbal clue, the tonality of the communication, everything. So it's work in progress at Preventive, yes.
Great. I mean, I think this is the need of the hour as we proceed, because through the online medium, a lot of the cues are missing.
Yeah, we are doing this as of now for teleconsultation. We are also thinking of coming out with a product that a doctor can have in a physical clinic. It's just there, like an Alexa. But it gives you prompt on your screen, on your laptop or something. But yeah, it's still a far goal, yeah.
And any synergy that which we see with integrating some of the protocols and AI-based assessments that either Dr. Deepika is doing? Do you see how the scope would evolve when you're trying to go into these spaces of online consultation and including assessments both from the nursing side or the other clinical protocols?
Yeah, definitely. For, let's say in online consultations, as of now, in our experience, most of the consultations are at a primary care or a secondary care. It's mainly done for convenience or at an odd time. It ends up going to a physical clinic. So we are thinking in a way that can we connect all the technologies in a way that when a patient is in the physical consultation room, we are there to support doctor in each and every way possible. And that's where integration with, let's say, liver diagnosis or let's say eye, dental, we are in talks with different academic institutes, different startups. We are doing different things. Preventive being the horizontal player and not a vertical player, let's say they are focusing only on liver. Somebody at an IISc is focusing only on oral cancer. We being a horizontal player, we think we are best suited to integrate all these things and deliver in a customized package to a clinician or a hospital. That's what our thinking internally.
So in a very similar vein, I would like to pose the same question to Colonel Suma out here. How do you see the same online space helping, how the nurses or the nursing community can put in their plans or their patient management healthcare processes through the online medium?
Yeah, definitely, it will definitely help nurses because right now, in all the rural setups, we do not have that many, like how the telemedicine has advanced. I think the telenursing is the way forward, and then definitely that will help nurses to take care of the patients also and provide, holistic care. And now that, the hospitals are also shrinking, so it will be, the future of the hospitals only will be ICUs and definitely OTs, because the other care will be extending to home-based care. So I think, the nurse specialists will be able to guide the home care nurses better through the form of telehealth. I think that will be helping.
Very interesting, ma'am. Exciting times ahead. Thank you in the paucity of time. Thank you all the panelists for coming in here and explaining. So with this, we conclude the session. Thank you all once again.
Thank you so much. May I request everyone to kindly join for the group photo? We now move on to a special segment, the joint plenary with IPSC. This reflects what THIT stands for, collaboration beyond silos and across invited. Ladies and gentlemen, may I request you to kindly take your seats while the joint plenary will be streamed live.
We are here for innovation. We are here to make a difference. We are not alone in this mission. We have partners and allies.
Ladies and gentlemen, welcome to our joint plenary session, which brings together 4 powerful platforms: International Patient Safety Conference, Healthcare Operations and Patient Experience, which is HOPE, and THIT, Transforming Healthcare with IT, and Clinovate, our new addition, each playing a unique role in advancing healthcare excellence. To lead the conversation on collaboration and shared impact, it's my privilege to invite Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospitals Enterprise Limited, on the stage. Ma'am, may I please request you to join the stage?
We are here to make a difference. We are the International Health Dialogue. Technology is our power. We commit to improve safety across.
Ladies and
Over to you,
gentlemen,
ma'am, to address
request
the
you all to be seated here as the joint
and good
plenary
morning. We finished
would be
an
streamed
exciting
live.
day
Thank you.
yesterday, and we're looking forward to progression of the thought process that we had yesterday on how we come together to advance healthcare, to create new solutions to save more lives. Yesterday, as I was talking to many people, they kept saying, you're telling us at a conceptual level, but please go down deeper and tell us what you do. So I'm going to share some more of those thoughts. This morning I told the team, please, pull out some different slides. But let's begin with first thanking, welcoming, and addressing our many, many dignitaries who are here from various countries, CEOs and leaders from various hospitals, partners from the Joint Commission, ISQA, and others, other excellencies, and most importantly, healthcare leaders, our doctors, our nurses, our technologists, who are all coming together to make the world a better place. I also want to do a special mention of one of our doctors, Dr. Vijayanand Reddy, who was recently awarded one of our Indian civilian honors, Dr. Padma Shri. So let's happily begin by welcoming him and saying, congratulations, doctor. We're going to have you on stage later. Thank you. So, can I have slides, please? So we'll talk about how we can scale performance using technology, focusing on outcomes and saving lives, and embedding empathy into everything that we do. And that brings us to International Health Dialogues, a confluence of patient safety, transforming healthcare with IT, healthcare operations and patient experience, and Clinovate, the latest in clinical. So that's how this has all come together. But I just want to say that this is your conference. You are the ones who are making this happen. Yesterday in the award ceremony, there were people who have received this award. Someone said, I've been attending 13 years in a row. I've got this award 11 years in a row. And I see speakers who yesterday were unwell, but today have found a way to make it here. Hi, Neelam. So this is a community. We are now becoming a tribe who comes together with the same idea, with the same vision, with the same purpose of transforming healthcare. And in this mission of shared purpose, yesterday, Gauranga Das, one of our spiritual leaders, he said, don't worry about the noise. You have social media, you have your telephones, you have your pagers, you have 100 people calling you. If you have a purpose, then everything combines towards your purpose. And I think our purpose, and truly we're all here for that, to bring healthcare within the reach of everyone. This purpose of higher quality, greater access, sustainable cost, and also finding a way not just to treat people when they're sick, but find them early, focus on preventive care, and keep them healthy. This is our unified mission. A minute about India. I do want to say we're a young nation, but we will soon have one of the oldest populations as well. But 43% of our population is under 24 years of age. We produce over 118,000 doctors annually and 120,000 nurses. So this goes with what I was saying yesterday to some people. The heal in India, the heal from India, and the heal by India. Our AI skills in terms of penetration are in the #1 category, because while you may look at the development, the platform layer, the energy layer, the chip layer, in terms of the dispersion layer, India's adoption of AI is incredibly high. And of course, 600,000 talent pool of the AI technology. So these are the pillars of the foundation. And because of our high out-of-pocket expenditure, we've learned how to keep our costs low and evolve a new healthcare system of high quality but low cost. The journey for Apollo began with our mission, our chairman, Dr. Reddy, who returned from the US in '83. This is his story. May I have volume, please? Because nothing tells the story as good as some pictures. And starting from, a difficult beginning of groundbreaking when it was, people didn't conceive world-class healthcare at that point, to the inauguration by Ziani Zail Singh.
Apollo began as an idea. Today, it's a movement, an institution, a commitment. Apollo isn't just a hospital. It's India's healthcare backbone. From one hospital to 79 hospitals. From one doctor to 13,000. From one bed to 10,400 beds. 6,800 pharmacies. 2,200 diagnostic centers. 165 dialysis clinics. 252 dental centers. 275 clinics, 800 telemedicine hubs. From serving one nation to earning the trust of patients across 150 nations. 200 million lives touched. Because at Apollo, care isn't delivered. It's orchestrated with precision, pace, and presence. Exceptional outcomes, Not just excellence, but repeatable, scalable, evidence-based mastery. This story of lives saved, futures rebuilt, behind every milestone, a mind that wouldn't give up. At Apollo, with AI-powered videos in 30+ languages, live webinars with doctors, millions engaged on our website and social media platforms. Our doctors now inform, influence, and inspire across borders, across languages, across lives. They work inside India's most powerful healthcare engine, backed by data, driven by research, and elevated by technology. With systems that support, with platforms that scale, with tools built around clinical thinking, from drone-powered medicine deliveries navigating the toughest terrains of Arunachal to teleclinics connecting patients, from caring for the elderly in our senior living homes to screening school children in the remotest districts. Apollo's care doesn't end at the hospital gate. It crosses borders, breaks barriers, and reaches wherever healing is needed. Because for us, healthcare isn't a location, it's a promise. Here's to the future.
Thank you all. This cheer belongs to 100,000 Apollo family members and the vision of our chairman, who you will hear speaking later. But I think coming together, what we know is that this is just a step. We're not even halfway in the race, and we need to work towards creating a new framework for healthcare. A framework which is backed on building additional infrastructure, on scaling our preventive healthcare focus, on enhancing and creating a digital data backbone, of reducing the skill gaps and enhancing the number of healthcare workers who are AI-enabled and technology savvy, but also who have embedded the empathy, in reducing regulatory drag so that we can think as one world and take healthcare workers across the world to serve wherever they are needed. This flywheel, which will continue to serve each other with a base of innovation and new solutioning. Finding ways to do that, one of the core processes that I want to bring, many of us here today are engaged most of our time in curing the very sick, in healing those who come into our emergency rooms, our theaters. We must look at this new era of preventive healthcare. And here, this platform that we have created is something that we are ready to share with the world in terms of the AI-enabled health risk scoring, a comprehensive reporting, appropriate testing, and then a guided path to wellness. I also believe that being close to the customer is critical, and therefore Apollo 24/7, India's largest omni-channel healthcare platform, which is serving over 40 million people, connects this ecosystem to every customer on their mobile phone with various features and capabilities. Our clinics bring healthcare closer to individuals and find a way to ensure that they're not denying themselves care because they're scared of going to a large hospital or the hospital is too far away. We need to bring care closer to the individual so that keeping themselves healthy is an automatic. Also, over the last 4 decades, one of the most important things we've done is advanced clinical care, whether it's high-end diagnostics, which helped our doctors find more and heal more. It's oncology with the best treatment capabilities. It's robotics and minimal access surgery and genomic testing. So the latest in terms of pioneering, and of course Asia's first proton machine, each one of these were steps towards bringing high-end clinical care closer to the customer. But ultimately, you are only as good as your outcomes, your benchmarking, and your validations. So we're proud to have been the first JCI-accredited hospital in India, among the largest number of JCI-accredited, thank you, and privileged to have this with the Joint Commission team here. And we will continue our journey in this area. but also the clinical outcome scoring methodology, where the parameter, the benchmark, and the outcome is tracked continuously across the ecosystem. Today, this is a digital dashboard. We auto-capture these outcomes, and we've added prompts or the patient-reported outcomes as well, because it is the most important thing to stay close to the customer, to work with the clinicians, and to ensure these high-quality outcomes. And finally, while you do all these wonderful things, people need to be able to afford them. So clinical care at an affordable cost, which is the magic mantra in enabling access. We have found ways to innovate in terms of the supply chain, the ecosystem, the methodology, and bring costs to 1/10 of global prices. And it is because of these outcomes and the cost that we are able to have patients from 140 countries come to us. And this is not just Apollo. There are many other hospitals in the audience who are doing this. All of us are together in this concept of Heal from India. We're very, very thankful. Many of you are here today. Thankful for your trust. I see patients from Tonga who come in, and I hope they're feeling at home. I see patients from Zambia. We've learned how to cook like the Tanzanians like to eat ugali. We are trying to be close to our customers, but give them this high-end care with a sense of being away from home. But it's also important to continue to build the innovation ecosystem, to push on research, to guide with knowledge, and to partner extensively. And these are some of the things that we're doing in that area. And ultimately, one of the things that our teams always remember, that whatever work we do, each one is a personal story. So whether it was sending the conjoined twins back home on Christmas Day so they could celebrate with their family, or this young boy with Nebelen-Rod's disease who saw the world for 11 years upside down. And because of this surgery, which was a complex and difficult surgery, he now sees the world from the right. So I thank our doctors for the great work that they do, and I believe that our people are our greatest strength. So our nurses, pharmacists, technicians, every single one of you whose heart is beating for Apollo and for the healthcare of the world, congratulate yourselves, feel proud of what you're doing, and find the energy to keep going. We are only halfway in this race or this marathon. And we have lots of new tools to help you, and technology is going to be one of the greatest tools to enable. Yesterday I said this, I repeat it again. Our challenge cannot be handled by linear growth. We need to look at exponential growth in our solutions and our access to be able to bring healthcare to the world. That's how we have to achieve the affordability, the scale, and the quality simultaneously, embracing technology as our engine. Some quick things into the work. One is teleradiology, so that advanced, super specialized opinions can be given on reads, given fast, given across the world, so that the entire aspect of using artificial intelligence appropriately with algorithms that make a difference. Whether it's our antibiotic prediction program, whether it's our pre-diabetes or risk screening program, to date we've had 3 million API calls across the various streams, and I believe we've just touched the very edge. We're just beginning in this journey. So I think that across, if we partner extensively, let 1,000 flowers bloom in terms of the AI algorithms that you embed, so that nurses are more aware, so that we never have a drug-drug interaction. There's so many things that we can fix by embedding AI into our workflows, and then putting agentic AI, so we remove mundane work. Our call centers must be manned by agents first before human beings. Our clinician co-pilot that we've done with Microsoft, we may share that a bit, and the patient co-pilot. Each one of these are bringing agentic AI into the forefront with the human in the loop, and re-engineering care pathways with AI embedded in them, so that we're a safer environment, a smarter environment, a more proactive environment, and an environment that can reach out to more people. In this one, we've had over 200,000 patients monitored, but the beauty is that today in the wards that are being covered, I'm happy to say we've had 0 code blue, because when the parameters begin to change, the med team can go in, decide whether they're changing medication or moving the patient to ICU. We don't want to have an emergency crash or a code blue in the wards when they're in the hospital. These are things where the pathways are changing. And over 100+ clinical protocols have been built, embedded, and therefore we're creating safer environments. And these are solutions that we're very happy to share with other hospitals across the world, other health systems, other governments, so that you can leapfrog your development stage and bring these safer environments within the reach of your people. I must say that this journey began for us in the year 2000 when we started our first telemedicine, when President Bill Clinton was visiting India, and our chairman, Dr. Reddy, my sister Shobna, who will be here later, were right there when he pressed the button connecting our village with the place where my father was born. Just 7,000 people live there. He connected that to our high-end hospital, and this was in the year 2000, so 26 years ago. It's been a great journey, and I really believe that we can do so much more, and we're very happy to share these. Now, some of these are things which are in the maze of the activity which is happening in their hospitals. Deciphering our health systems into moving from retrospective quality analysis to real-time intelligence and reports is another very, very important thing, so that you can proactively go in there and make a difference. Our CEO from Sheba yesterday was telling us some of that. Health Access is our technology company. The teams are around here. They're very happy to share anything that you need to know across the spectrum in terms of building solutions, AI platforms, and workflows across the care continuum that you can embed, that you can put on top of your existing IT systems, that you can use in a modular manner in any aspect. In the new hospital that we're opening, we'll share a little bit more about that. We're actually connecting the ICUs. The emergency room is connected with a 5G ambulance. So many of these are modular solutions that you can pick up and share. I hadn't intended to go through each one of these, but yesterday many people said, get into details, tell us what all of you are doing. So this is some of those being shared. I think one of the most powerful things is the AI-enabled command station. So you do a connected ward, you look at the EICU, you look at the home, you add the ambulance connectivity to it. This is 2 validations from just partners who are already using. I'm not going to go into this because we're running out of time. But this is the CEO of Mayapada Hospital talking about how he's using the APIs.
And advanced digitalization, including collaboration in AI and health technologies. Today, AI-based risk prediction has been applied to more than 40,000 individuals, supporting early identification of cardiovascular risk, pre-diabetes, and type 2 diabetes. We have also established Mayapada Apollo Batam International Hospital as a key milestone in our partnership. This collaboration reflects our shared commitment to advancing healthcare standards in Indonesia, and we look forward to deepening this partnership in the years ahead.
Through the collaboration with Apollo Health Access and Arkansas Heart Hospital, we are so proud to have started our efforts together in the customer call center, where we have together dropped patient average hold time between 7.5 minutes to 9 minutes on average. We're so thankful for the efforts of the teams thus far. We have so much coming here in the next few months. Things like business analytics, things like longevity, and what we're very excited about in the imminent future is our coding collaboration. So we're very thankful for the collaboration between our 2 health systems, between our cultures, and we're excited about the future.
I actually wanted to spend more time also talking about the work we do in rural healthcare, in primary care, but I think we're really running out of time. So I want to end with sharing a concept or a vision that we were working on building. There's a new hospital coming up in Financial District. We're due to open this week. We called it the Hospital of the Future. We looked at connected environments, AI-assisted diagnostics, smart laboratories, the 5G ambulance I spoke about. We haven't yet finished, but a digital twin is coming up, the electronic health record, a paperless hospital, immersed learning so that in 15-minute modules, your nurses can do quick learning about things while they're in between patients. Each one of these, drones for pickup and delivery of ambulance, of medication, various aspects, whatever technology can give us, can we embed it into healthcare to make healthcare better? Besides, of course, the digital facility management, command centers. So this was a very hospital-centric view. And then I said a hospital of the future is not enough. If we're thinking proactive, predictive, personalized, preventive, we need to go to the next level, which is the health system of the future. So the hospital buildings are then connected to the clinics. The command centers can talk to small emergency rooms or urgent care centers. The data can be used with partners for research across to accelerate discoveries, biomarkers, novel new cures. The digital front door connects the customer into the home, and each one of these are connected through your mobile phone with your customer. So many of these. So I think now we've expanded our thought process to say, how do we build health systems of the future? And again, I see collaboration and partnership from technology companies, from hospitals who want to do this, from individual doctor practices who want to get connected into this ecosystem. Let's find a way to make healthcare smarter, safer, more equitable, and think about working together. Because at the end of the day, the seamless connection surrounding the customer, surrounding the healthy individual and keeping him healthy is really what the world is all about. That's the responsibility that we have taken upon ourselves, and the world is looking to us. So let's find ways to do it together. Once again, I want to thank every single one of you for being a partner, for being a friend, for being a well-wisher in this journey of building a healthier world together. God bless you all. And let's find the strength and the courage to do what the world is looking at us to do. Let's co-create the future of healthcare. Namaste.
Thank you, ma'am, for your address. May I please request you, ma'am, to stay on the stage? Okay. Ladies and gentlemen, to continue this conversation about working together to create meaningful, sustainable impact for caregivers, institutions, and most importantly, for our patients, we are honored to welcome our guest of honor. Ladies and gentlemen, please join me in welcoming our guest of honor to the stage, Shri Konda Vishweshwar Reddy ji, my Honorable Member of Parliament, Government of India. Please join me in welcoming our guest of honor, Shri Konda Vishweshwar Reddy ji, to the stage. May I now invite Dr. Jonathan Perlin, President and CEO, Joint Commission, to kindly join us on stage. Ma'am, may I please invite you to join us on the stage? It's my honor to now welcome our Honorable International Ministers of Health coming from different countries here to the stage. To start with, may I request Professor Jean Rosaire Ibarra, Honorable Minister of Health and Population, the Republic of Congo, to be here on the stage with us, please. May I invite Dr. Grace Nzu Danka, Honorable Minister of Health, Ghana, to join us here on the stage. May I invite Mr. Huaka Vemeliko, Honorable Minister of Health, Tonga, to join us here on the stage. And we invite Dr. Sarah Cleto Rial, Honorable Minister of Health, South Sudan, to join us here. I also take the privilege to invite Ms. Shobna Kamnini, Executive Chairperson, Apollo Health Co. Limited and Apollo Pharmacies Limited, here to the stage.
We are the champions of today. We are the ones who shape the future.
Thank you all the dignitaries for joining us on the stage. May I request you to take the seats, please? To give us an overview of IHT 2026, Now, I request the AV team to quickly play a video for us. Thank you. Now we start with our felicitations. May I invite Mr. Subramaniam, CEO International, to felicitate our guest of honor, Shri Konda Vishweshwar Reddy ji. Ladies and gentlemen, Mr. Subramaniam, honoring our guest of honor here, Shri Konda Vishweshwar Reddy ji, Member of Parliament, Government of India. Thank you so much. A true pioneer of Indian healthcare, whose vision placed quality, compassion, and patient safety at the core of care delivery. We now invite you to witness a virtual address by Dr. Pratap C. Reddy, Chairman, Apollo Hospitals. May I request the video to be played, please?
A warm welcome to all the delegates gathered at the International Health Dialogue 2026. We have come together not merely as representatives of healthcare sector, but as stewards of a common vision, a vision that makes healthcare safer, more innovative, and centered around the patient. I think this is very much. Continuously must think of what can we innovate. Now, in the present day, once again, healthcare stands at a defining moment. Around the world, we're witnessing extraordinary advances in science, technology, and clinical capability. At the same time, healthcare systems are facing increased pressure and rising expectations from patients and communities. These realities may look different across the countries and healthcare systems, but the underlying challenge is shared. So, how do we translate progress into care that is safe, more equitable, and truly centered on the people? That shared challenge brings us together under the theme Global Voices, One Vision, Patient First. It reflects our belief that while few patients may differ, our responsibility to shape the future of healthcare collectively. At Apollo Hospitals, we've always believed that meaningful progress in healthcare is shared through a dialogue. Over the last 43 years, since the inception of Apollo Hospital, we have brought several incentives to make a significant impact on patient care. First, of course, the establishment of the first multi-specialty hospital in the country, which today is over 74 hospitals, and in almost every single field, we have reached global standards and global value. I'm a cardiologist. I started because I lost a patient who couldn't go to abroad for cardiac surgery. Today, we have done over 300,000 cardiac surgeries with over 99% stake, first in the world. So I think this is because we continuously said, whatever we will do, patient as our first priority. I think patient priority, and now we are talking about saying health first, and health should be prioritized for every individual. And over 12 years ago, Sangeeta worked together to create this International Health Dialogue to be a platform where global voices come together. I think I'm very happy that today we are all here, several places in the nation. Health leaders, clinicians, innovators, policy makers, practitioners, and practitioners who share their insights and learning. The International Health Dialogue brings together multiple conferences that address healthcare through interconnected perspective. Though ISPC, we focus on strengthening patient safety and quality as foundation of care. That explores the responsibility of using technology and digital innovation in healthcare delivery. HOPE examines healthcare operations and patient experience scale. This year, a new edition is Innovate, a focused platform for clinical dialogue and innovation across oncology, cardiac sciences, women's healthcare, longevity, lab medicine, and diagnostics. The total focus should be around the patients. IHD stands for collaboration over silos, learning over assumption, and action over intention. So, as the next decade unfolds, the direction healthcare must take is becoming increasingly clear. Patient safety must remain non-negotiable foundation of every system. Technology must enable better decisions and better outcomes while keeping higher at the scope. Healthcare system must evolve a delivery quality, access and trust, and scale across geographies and generations. My intention is that we should continuously innovate. As I said, in the 40 years, we brought the multi-specialty hospital, but there are many, many good hospitals in the country and around the world. We are continuously improving and innovating to give better scale. As I said, we are beginning to, in the 40 years, now we are not saying, we are now, the healthcare today, around the world is progressing very fast. But the involvement of the entire healthcare system should be equalized and continuously innovate. The newest innovation, I won't say innovation, the newest thing that we are going to announce is going to start with the whole world. Everything works. The hotels work, the airlines work, the coffee shops work, all of this work 365 days. Why hospitals don't work on Saturdays, Sundays? Are we safe on Saturdays, Sundays? I think that this is where Apollo is going to break this big news, announcing we have already prepared. All of our hospitals, all of our clinics, all of our systems will be available for people throughout the year, 365 days. Already we brought the first time in the nation emergency, 24/7. And now, today I make an announcement before you, and I think the world must wake up and say why we are not working on Saturdays, Sundays. Because healthcare is most important and doesn't save them on weekends. So this is where new thought-breaking incentive, which should have been done earlier, now we are announcing to the world that Apollo hospitals and Apollo system will be worked 24/7, 365 days every year. Every Sunday and Saturday, there's no sickness, there's no holiday for Apollo never sleeps. So I think all should adopt the system so that we will be able to give good care all the time to all people and continuously innovate. Above all, healthcare as a moral responsibility, and this calls upon us. This is why I realize it's a moral responsibility to have brought in the best healthcare systems in the country and best technology. And now I realize that the world is sleeping on weekends when healthcare is required 365/24/7 to build the economic system that are resilient, transparent, and prepared for the needs of tomorrow. Therefore, we shape through this dialogue, will influence the lives far beyond these halls. Whatever we are discussing here, we are taking it to the world. It will shape the futures of families and nations who count upon us with hope in their hearts. So let's move forward together and with some humility and compassion. The time is now for us to herald a paradigm shift in the way we look at healthcare and in the health of individuals, families, and communities must be protected and nurtured, not within the hospital walls, but in everyday life. And this is where that belief is the heart of my vision for the future of health at health, happiness at home. So please take to that we are all here to bring health, happiness at home. And remember that Apollo will launch Apollo Never Sleep. We will be open on Sundays. And hope all of you will follow this so that healthcare is available for people when they require. Because nobody knows when they're going to fall sick. So health should be priority for everybody. And remember, health, happiness at home. God bless. On this important conference, I'm announcing a major announcement which I've made, that Apollo never sleeps and it will work 365 days. There's no holiday, Saturdays, Sundays. So all of our Apollo services will be open for people because health should be a priority for everybody, and for hospitals it should be a priority to give it to them when they're sick, because nobody knows when they're going to fall sick.
Thank you, sir, for your insightful address and for continuing to inspire us with your vision and leadership. May I request Mr. Russ Brenzel, Shine CEO, to join us here on the stage, please. Thank you. May I request Dr. Jonathan Perlin. May I now request Dr. Jonathan Perlin to share his insights with us, please.
Welcome back, ladies and gentlemen. With that, we now enter one of the most exciting frontiers in healthcare, AI-powered care pathways tailored to every specialty. To chair this session, we invite Professor Ravi Prakash Mahajan, Director, Apollo Research Academy. Please put your hands together. A leader in academic medicine and translational research, Professor Mahajan represents the bridge between science and scalable care. Thank you, sir. May I also invite the panelists? Professor Sir Nilesh J. Samani, kindly come to the stage. Request all the guests to kindly give a round of applause. Ms. Heidi Chapman, Ms. Devi Kongot, please give a round of applause while they head towards the stage, please. Mr. Matthew Prime, and lastly, Dr. Aarti Gokhale. Ladies and gentlemen, join one in giving our panelists a warm round of applause.
Thank you very much for a very kind introduction. Without further ado, can I invite Professor Nilesh Samani. Professor Nilesh is Professor of Cardiology at University of Leicester. He's also Honorary Consultant Cardiologist at University Hospitals of Leicester NHS Trust and Co-Director of Center for Digital Health and Precision Medicine. I will not, steal his thunder about the center, and I'll invite Professor Samani to come and let us know about the center and its vision and how it's going to take the digital health and precision medicine forward. Professor Samani.
Thank you very much, Professor Mahajan. Good morning, everybody. It's a pleasure to be here and to describe a new and exciting initiative between Apollo and the University of Leicester around the Center for Digital Health and Precision Medicine. The chairman, Pratap Reddy, just now discussed this issue, which has been discussed many times at this meeting, around the healthcare becoming an increasingly unaffordable issue. What I've shown on this slide is the spend in the United Kingdom over the last 40 years in terms of the increasing spend. It now occupies 13% of the GDP of India, or of England. In India, I heard yesterday that 4% is spent on healthcare in terms of GDP, in the States, 17%. So this is an increasing problem, really caused by a number of issues. The first is an aging population in many countries. Multimorbidity plays an important part in increasing the cost of health. Innovation obviously comes at a cost, and most importantly, patients rightly have expectation, the public rightly has expectation that they will be able to access treatments. And of course, when health becomes more unaffordable, then health inequity starts to increase. So these are important challenges which has been the theme of this particular conference. And the questions are, how do we try and solve this? And urgent new solutions are needed. And there are a number of different ways that we can tackle this. And the topic here is about, of course, around artificial intelligence, digital health, and Apollo has been a pioneer in this area for many years, and the promise that genomic medicine might provide in terms of giving precision medicine to patients. And with this background, with the new partnership has been developed between the University of Leicester, where I'm based, in the UK, the Apollo University, which many of you know is based in Chittoor, and Apollo Healthcare, to create this new Center for Digital Health and Precision Medicine, building on the several years of experience that Apollo already has in terms of developing new tools for digital health. The center has two hubs, physical hubs, one at the Apollo University in Chittoor and one at the University of Leicester. But the structure of the center is very much federated, so you can be a faculty member or take part in the center wherever you are based. So you don't need to be physically based in one of the two hubs, but you can be based anywhere. And the unique selling point of the center is really the enormous data sets accumulated within Apollo over the last 30 years, which really provide a foundation for creating new approaches, new tools of helping patient care. You are all familiar with the extensive data that Apollo collects across its 73 hospitals and growing number of hospitals, plus all the other treatment protocols that Apollo provides to patients through various mechanisms, including total health and the 24/7 practice. And this all is curated within a single electronic health record, which really, if you want to do digital health or AI, provides a really strong foundation for doing this. So the vision of this new center, the vision of the new center is to become a globally recognized research center that advances healthcare and its delivery through the development and deployment of novel digital health and precision medicine solutions. That's the new mission for the center, building on what's already been done both in Apollo and Leicester. And as I mentioned, the mission is to harness the extensive patient database of Apollo Hospitals Group, and the data is available at the University of Leicester and our partner hospitals, as well as through other partners that we are affiliated to the center. And then to use the research and clinical expertise of investigators at the University of Leicester and Apollo Healthcare and our partners to deliver better patient care. So the vision and the mission are fairly straightforward. The center was established a year ago today, and we are building up a core team now for the center based primarily in Chittoor, but also in Hyderabad under Dr. Sujoy Kar. So I wanted to particularly point out Dr. Kar, who will be familiar to many of you here. So he's the co-director of the center with me, and of course an expert in deploying new digital and AI-based solutions. We just launched a PhD program in the center, which will become active this year to try and build up a new generation of students and practitioners in this field. But the key part of the center is not the core team, but it's the faculty, which is spread across the University of Leicester, across the Apollo Healthcare ecosystem, and of course across our partners. And you see a few of these people. So we've currently got a faculty of 42 people, clinicians mainly, but other scientists as well across the the partner institutions. And one of the reasons for wanting to speak today here was to say, particularly to people from Apollo, but also other people who are in this audience, to say, come in, if you have bright ideas, come and talk to us about becoming a faculty member within the center. The center is geared towards really the whole innovation pathway, from ideation around new ideas around AI or digital health solutions, all the way through to doing the initial analysis and modeling of a new product, to perhaps validating it internally, but then going on to getting external validation, and then creating the tool that will be used by the clinician or the healthcare professional in terms of deploying it for patient benefit. And of course, ultimately hoping to partner with external organizations to make this tool become available more broadly. So the center is already set up in a way that allows us to take that idea right at the beginning all the way through to something that benefits patients. And Dr. Carr and other colleagues at Apollo already have experience in taking the thing all the way through these various stages. And that's important because sometimes you find with AI solutions and with digital health solutions that the idea is great. There is often the first validation is carried out, but getting it to the patient can be the challenge. Getting it through the regulatory bodies can be a challenge, and the center is set up to help people do this. The other foundation of the center, which is very important nowadays in the world where data, of course, patient data is very important, but it needs to be regulated, confidentiality needs to be maintained regarding patient data, is how do you allow access to this data to researchers to carry out some of the modeling that needs to be done. And so the center is set up what's called a trusted research environment, which allows data from the Apollo's healthcare system, anonymized data from patient care after having ethics approval, to be able to put into this secure environment where researchers can access that data to allow them to do the modeling and the validation, if required, of a particular algorithm. The data never, therefore, leaves the Apollo healthcare system in any way. The only thing that leaves, potentially, is the outputs of the analysis. And this allows researchers to access this, it allows people to bring in other data into the trusted research environment to allow validation to take place. And of course, once the data is in the TRE, it can be reused, redesigned for other purposes. And this is an important way of allowing data access without breaking patient confidentiality or without allowing data to leave the primary healthcare provider. As I say, the center's been up for just about a year, and we already have a number of different projects that are underway. So one of the important things, particularly in urgent care, is around emerging early warning systems for patient deterioration. So there are a number of projects going on around this area, which is clearly important for inpatient care. We have projects around polygenic risk scores. This is a particular interest of mine, and this is about precision medicine, and particularly polygenic risk scores for prediction, future events in a number of areas, cardiovascular disease, but also oncology and cancers, as to whether we can identify those people at higher risk using these new approaches over and above what we do currently. So that's an area that we want to explore around precision medicine. As I said, oncology is an important area for AI, and you'll hear an example of this in a few minutes. We have work on liver disease, and again, there'll be a presentation later on in this session from colleagues who are affiliated to the center presenting this work. Renal disease, gynecology and women's health is an important and emerging topic for the center, as well as orthopedics and bone and musculoskeletal health. Ambient listening in a number of clinical settings, and particularly in OR, can help make procedures more efficient. So there's a whole range of projects that are currently underway within the center. And as I said earlier, we are very keen to hear from colleagues who have bright ideas, who want to come forward and work with us in the center to advance other areas. So let's just hear, what I've got is two colleagues who are faculty members of the center who will just describe in a few minutes their project. So I'll go to the first, that's by Professor Dean Fennell from the University of Leicester, who will talk now. So I'll just press and hopefully it'll play. Can we have the sound up? Can we have the sound up?
Precision medicine, an alliance between my University of Leicester and Apollo University. I'll be talking about the leveraging of artificial intelligence for next generation precision medicine in cancer. Now, currently, we think of precision medicine as an approach in which we can select patients with a unique biology and give them an appropriate drug which works. And this is because patients differ, even with the same cancer, in their biology in such a way that using a single drug simply won't benefit all patients. Currently, the state-of-the-art precision medicine depends on single gene mutations. And if we look here on this pie chart, we can see that this really only affects a minority of patients. By far, the majority of patients have what we would describe as much more complex biology. For example, we recently published that inflammation, the pattern of inflammation, or epithelial mesenchymal transition, which is a form of plasticity in the tumor, can predict outcomes to immunotherapy. Also, genomic instability predicting PARP inhibitors, as we've recently published. So the question is, how can we leverage this greater degree of information present in complex biology for precision medicine? Well, the answer, we believe, is to use the power of AI to map biology to histology. And the way in which we can do that is using a platform called a pathology foundation model, very similar to ChatGPT, if you've ever used that, but really for pathology. We have an incredible knowledge base of cancer in which encoded images can be linked to biological information. And that information can then be used to predict biology from the images alone. And we can do that very accurately using fine-tuning of these advanced models. We want to now leverage this technology in an international consortium called MIRA. This will be led by CBHPM with US, Australian and French colleagues. And the aim here is really to aggregate our scans from a particular disease known as mesothelioma, which is an asbestos-caused cancer, along with multi-omic data, proteomic, genetic, transcriptomic, in order to be able to build this predictor from H&E, the goal being to utilize this within clinical trials. So in summary, pathology foundation models may enable drug response prediction from routine slides, which is a remarkable possibility. And the MIRA consortium will be spearheading this development with the aim of delivering a new approach to next generation precision medicine clinical trials. Thank you very much.
And the other example I wanted to give you is from my colleague, Dr. Jit Mangwani, who is an orthopedic surgeon. And I'll now see if I can play his presentation.
Hi, I'm Jit Mangwani, one of the orthopedic consultants at the University Hospitals of Leicester. I'm absolutely delighted to be a faculty in the Centre for Digital Health and Precision Medicine, a joint venture of University of Leicester and Apollo Hospitals in India. I have been working with Professor Raju Vaishya, who's a professor in Apollo Hospitals in Delhi, on an exciting project using artificial intelligence in orthopedics, particularly ankle fractures. Missed fractures in emergency care can be a really frequent and expensive clinical issue. Ankle fractures are common. 1 in 10 of the orthopedic injuries are ankle fractures. The diagnostic accuracy varies with clinicians' experience, and also some of these fractures are not clear whether they're stable or unstable when we see them. These fractures can be missed and can lead to patients suffering as a result of that, having higher clinical risk and also compromising their outcomes. This also has a medical legal implication as a result of that. The system we're working on, it applies deep learning-based computer vision using convolutional neural networks to analyze radiographs in orthogonal planes. Using supervised learning on expert annotated radiographs, the model performs automated fracture detection, anatomical localization, and classification, which is really clever. On top of that, what we have is a wealth of data, one of the largest databases available through Apollo Hospitals of 30,000 X-rays that we will be analyzing. Not surprisingly, if we look at what's published, not a lot. So far, we have done a systematic review of what's published out there in this field, applied for a grant application, And now we are at a stage of recruiting a PhD student. So the progress has been really good so far. The next stage will be to expand this project to the entire lower limb, including fracture of the neck of femur, which is another very common orthopedic injury, and it's devastating if it's missed, unfortunately, because it's in the elderly folk. So a big thank you for the opportunity, and I can't thank you enough for having me here. I wish you all have a great conference and a fantastic year ahead, and we'll keep you updated on the progress from now on.
Okay. So as I said, the center, whilst being a partnership between the University of Leicester and Apollo Healthcare and the Apollo University, we obviously wanted to expand beyond the three founding partners, and we have already got academic partners based at the University of Cambridge, at the Gates Foundation, and at the University of Pennsylvania, and you'll hear at least one of these presentations after me about the work that the Gates Foundation are funding through CDHPM. And we're also interested in industry partners, and again you'll hear today a number of presentations from industry partners who are going to be working through CDHPM. So I wanted to end by saying that the center is now open. We're hoping to make a real leap in the coming year or two in terms of contributing new tools for patient benefit. And we are very happy to partner with both colleagues within the Apollo system, within the university, but also external colleagues. And you can contact us through the web page that you see on this slide, or also directly to myself or Dr. Carr. So I'll stop there, Dr. Mahajan, and very happy to take questions afterwards. Thank you.
Thank you very much, Sir Nilesh. So as you see how Leicester University and Apollo University have come together for this center, and I must congratulate you as one of the co-directors, and also Sujoy, who is in the audience as one of the co-directors, for taking this program forward. And it's made huge progress in the last 12 months, and huge progress to be seen in the coming months. And your cooperation, your collaboration is very much required for its success. I see on the monitor that we got few minutes for one or two questions from audience for Sir Nilesh, if there are burning questions. Sir Nilesh, since I don't see any hand going up, so I'll take chairman's privilege to just put it across. In terms of, I hear on the grapevine that we're going to be having PhD students in the university, and also the collaborations that you mentioned. Where do you see in 12 months' time or 24 months' time, what should center be looking like in terms of getting into the future?
Thank you, Ravi. So we hope, as I said, part of the structure of such a center should include training for new people. And so the PhD program, which currently is being funded through the University of Leicester, hopes to appoint 9 students within the next 2 or 3 years to work on different projects. They're all going to be competitive studentships that we establish. And we hope that we'll have a vibrant postgraduate program within the center for training purposes. We hope that that will expand into fellowships, for people who are postdoctoral in that sense. The ultimate aim of, as I said, of the center is around developing things that work for patients. So while an academic center like this has metrics that you can measure, such as how much money do you bring in terms of grant funding, how many publications you put out, but the main thing we want to do is, of course, get things to patients as quickly as we can. So the ambition for the center is more focused around patient benefit, and the types of tools and things that we can get out to the public early. So if you ask me about what I would look as a metric in the next 2 to 3 years, of course I would want students, I want publications, but what I want more is around tools that can get to the patients.
Thank you very much indeed. So can we have a round of applause for Sir Nilesh? I know you may have to leave slightly early, but it's great to have you here. And when we talk about taking things to patients and for patient benefit, one of the things that digital health does is bridge the gap between the rural and the urban areas, and between the high-income countries and the low-income countries. And we're very glad to have Bill Gates Foundation as our academic partner, and very, very pleased to invite Dr. Heidi Chapman to give us flavor of leveraging AI for advanced health monitoring in low and middle income countries. Dr. Heidi Chapman.
Wonderful. Thank you to everyone, especially the organizers. This has been a really great conference to attend. It's my first time attending, and really enjoyed the talks yesterday, and it gave me some context as well to throw into my discussion here. So really appreciate the speakers that came before me. First, I want to give a brief introduction to the Gates Foundation and really what we focus on for those who aren't familiar with our mission. We're a philanthropic institution that is primarily focused on low and middle income countries, and to dig in a little bit more, the diseases that disproportionately affect people in low and middle income countries and lead to deaths in children under the age of 5. And we really work on the belief that everyone deserves the opportunity for a healthy and productive life regardless of where you were born. On the slide here, I have some of our areas of focus, and you can see that we cover a broad range of areas across not just global health, but community infrastructure as well. I'll be focusing on global health since that's where I sit within our foundation mission, but you can see here that we make investments across agricultural development, inclusive financial systems, water, sanitation, and hygiene, as well as nutrition as well. The numbers on these slides, I admit, will be a little outdated. We just announced our 2026 budget, which is at our cap of $9 billion in charitable support to really focus on these areas. In terms of how we operate as a foundation, we really see our role being within these 4 areas. The first being market incentives. You may have heard of things such as our volume guarantees. Spurring innovation is really core in what we do, and this is primarily done through our grants. And what we really try to do is step in and support the areas where the private sector doesn't typically work, because these are diseases that really are focused in low and middle income countries. So we try to fill that gap and really make sure that translation and innovation gets to those who need it the most. A big focus of us is strengthening collaboration, trying to build those bridges between the public sector and the private sector, as well as the philanthropic sectors, to make sure that these innovations don't just stop at the idea stage, but really get carried all the way through into a deployed product that's in the hands of people. And finally, we have a focus, really, everything is driven in making sure that the data is good, the data is high quality, and that we're always operating off of data that is true. I sit specifically in a team within the foundation that's called the Accelerator for Global Health. Within the Accelerator, we really focus on innovation as well as this high quality data. And then my portfolio specifically is non-invasive health monitoring in the community setting. I saw this iceberg a few times yesterday, and everyone has their own version of what it represents. But I like to talk about it in the context of symptomatic individuals and what we call our silent spreaders, or asymptomatic individuals. The top of the iceberg, what you see above the water, are people who are symptomatic. They're going to go to a hospital, they're going to go to a clinic, and they're going to go through the traditional workflows and be diagnosed in that system. But in this age, especially when we think of where digital health tools and AI can make a big difference, let's start tackling what's below the water. Let's look at those asymptomatic individuals who aren't being captured through the traditional system and try to prevent the spread before it happens. But what we need here is new tools. We need tools that are in the communities, in the public settings. These need to be portable, these need to be non-invasive, and they need to allow us to operate outside of our traditional hospital and clinic setting. My portfolio broadly is what I call human health beyond human perception. I'll dig into this a little bit more. On the left, we've heard a lot in the last day and even in our last session about where AI can be applied to the data that we have now. I won't touch on that as much. What I really want to focus is on the areas in the right, which is developing new technologies that will leverage digital health and AI, that will drive us outside of the clinic into these remote settings and allow us to get real-time dynamic feedback on health settings. And then can we use AI to add in additional context, such as geotagging, age, sex, to build a really robust clinical profile that allows us to act in a custom way for the people who need the interventions. I'll talk a little bit more about the innovations on the left in the next couple slides, but to tie it back to really making sure that these innovations are being brought to the low resource settings, I really want to make sure that we highlight on the right what we are anchored in all of our investments. I've mentioned non-invasive a few times. This is really important to us because things like blood, sputum, sample collections introduce two challenges for us. One is process delay, and two is additional cost. And also, if we're non-invasive, we can do what we call in vivo monitoring. You'll hear this a few times from me. And what that really means is monitoring in the context of the human body. Let's not take the sample out. Let's look at the analytes and the physiological measurements where they are in our bodies. Low cost is always going to be a priority for us. Can we drive this so that over the lifetime of device, the cost per test can get below $1? And again, with this being low cost, can we avoid consumables? Can we avoid samples? Real-time continuous monitoring is really important and is now possible in this age of AI and digital health. This allows us to have no latency in measurement. We can see what's happening actively in the body, and also allows us to rapidly screen through populations. And of course, it has to be portable. So going back to what I mean by human health beyond human perception, we have this ability now to pull out additional data that humans in the past just have not been able to perceive. I'll talk about two major groupings here, which is smell and sight. First, smell. I'm sure many people have seen the videos of dogs sniffing out diseases. We saw during the pandemic insects. The African pooch rat is very good at sniffing out TB, malaria, in low resource settings. But animals aren't scalable. So how can we take what the animals are doing and put it in a portable device? I wish I had more time to dig into this. I could do a whole 30-minute talk just on this portfolio. But just to highlight different ways that we're thinking about remote monitoring. And so can we isolate the proteins that are detecting these chemicals that the animals are leveraging and put it on a portable device? And in the age of AI, this is really becoming possible because what AI does is allows us to decipher this really complex signal and pull out the signal from the noise. And if we can put this in a portable device, all of a sudden this becomes a tool for us to detect infectious diseases that's non-invasive, is rapid, can we get results in under 5 minutes, it's low cost, and can be administered in community settings without additional training needed. Skipping now to sight. This is a portfolio that, there we go. I think is really exciting, especially hearing some of the things that I have in the last day at this conference. Again, on the left is what we've heard about over and over again, is leveraging AI to add in context in things like imaging results, the way that we looked at symptoms and vitals, combining with the physician training and the test results to get in the clinical setting what we expect to be the diagnosis. But how do we translate this into a remote setting? We don't have the physician, we don't have these imaging results. Where can we collect the data? So here represents 3 of our investment pillars. First is what we call our non-invasive imaging. This is where we partnered with Apollo Health, and they're acting as one of our very important clinical sites to test out some of our hyperspectral cameras, our 3D cameras, cell phone cameras, where can we push there to get additional data. Very exciting investments in things like speckle laser, which will allow us to get high quality blood pressure regardless of skin tone in a non-invasive manner. And we can use all of these tools, for example, to screen children for asymptomatic carriers of infectious disease. I'll go quickly through the next tool. We've heard a lot about wearables, but how can we drive wearables to be clinically actionable and provide health data that is really important when we're in a remote setting, beyond wellness, but into actually diagnostics. So can we get things like blood analytes, hemoglobin levels, glucose levels on a wearable device, as well as, once again, blood pressure that is actually accurate and actionable. This becomes very important for things like monitoring pregnant women who are at risk for preeclampsia, preterm birth, gestational diabetes. On the right, again, something I could talk about for many minutes, so please find me after if you'd like to discuss more, is what we call an in vivo CBC. Can we get a full blood panel without removing the blood from the body? And then in the future, will you see all of these things coming together in a way that as you start from birth, you're getting what we call your health fingerprint. This is your metabolic screen, your genome, date of birth, sex at birth. Throughout your lifetime, you have these continuous data collections and monitoring, which include wearables, these non-invasive imaging, and those build a profile for you that has continuous physiological readouts and alerts you if you have deviations in the system. And if a deviation occurs, which is suggesting that you have a change in your health state, can then reflex to these new devices, which allow us to, in the remote setting, before you have to go to the hospital and the clinic, get additional context, whether it's through chemosensing or a blood panel without a blood draw. And I think I'm out of time, so I'll stop there. Thank you.
Thank you very much, Dr. Chapman, for sharing those insights and also the vision and the expectation from society at large and from the scientists in terms of what Gates Foundation expects us to do. So there is a challenge for all of us, and I'm sure the center will be key partner in many of those solutions that you're seeking, and we'll seek your support in the coming days. Thank you very much indeed. In interest of time, I think we'll have the rest of the talks and have questions at the end. So may I now invite Dr. Rajendra Prasad. It's a real pleasure to invite him from Siemens Healthineers, another academic partner of the center. Dr. Prasad is going to talk to us about practical AI and quantitative ultrasound enabling liver care. Dr. Rajendra
Thank you,
Prasad.
sir. At the outset, I would like to thank the Apollo Hospital Group for inviting me to the conference. I am Dr. Rajendra Prasad. I am a non-invasive cardiologist and a collaboration manager at Siemens Healthineers, India. I look after the collaborations across various business units for the Software Development Center, India. So today, I'll be showcasing the work on quantitative ultrasound and AI for liver care, which we are doing jointly with the Apollo Hospital, Chennai. Before that, I would like to play an excerpt from our Director of Clinical Sciences Ultrasound Global Business, Dr. Aarti Gurung.
Siemens Healthineers and Apollo Hospitals bring together clinical and technical excellence to advance innovation in liver healthcare. Together, we strive to fight cancer and join forces to optimize the cancer care pathway through speed, precision, data, and AI solutions. At Siemens Healthineers, our imaging and therapy solutions span the entire cancer care continuum, from screening and prevention through diagnosis, therapy, and survivorship. We invest in innovations that drive greater efficiency and highly effective patient outcomes at every step of the patient journey, from the first appointment to treatment planning and delivery to follow-up care. We have research and partnership commitments with leading institutions such as Apollo Hospitals to yield a powerful perspective and help deliver comprehensive cancer care for our patients. A prime example is the latest partnership with Apollo Hospitals on the AI for liver fibrosis clinical solution, with advanced AI models with multimodal parameters integrated with our advanced multiparametric quantitative ultrasound biomarkers. Our preliminary data has shown increased measurement accuracy and reduced operator dependency, enabling more confident clinical decision-making. Together, we are working to close the critical gaps in disease management by advancing innovative solutions to ease the growing burden of liver disease in India and worldwide, with a clear focus on earlier and accurate detection, proactive management, and precise monitoring for better patient outcome.
And our unique capabilities are reflected in our broad and deep portfolio. We have on the one side the diagnosis portfolio, which includes imaging that covers multiple modalities. We have the laboratory diagnostics, and on the therapeutic side, we have the variant suite, which covers solutions for the cancer care treatment and advanced therapeutic solutions, which are basically used in the cath lab. And this is coupled with the digital health solution, imaging software, and IT. Our unique approach to AI development is to leveraging the robust internal capabilities. We have nearly 200 plus data collaboration partners, and we have created a global data pool, which has nearly 2 billion data sets. And we are open to the platforms. We are opening the platforms for partnership that benefit the customers, and the AI solutions that we offer would fit in seamlessly into the customer's workflow. And this is a glimpse of the global presence of our AI centers. And we have a global expertise with innovation history. We have more than 100 plus AI powered solutions, 2.2 billion curated images, reports, clinical and genomic data we can leverage for artificial intelligence solutions, and we adapt a sustainable, safe, and ethical AI development. Now, as far as our focus of artificial intelligence in ultrasound is concerned, we would like to optimize the workflow, reduce the exam time, increase throughput, and enable standardization of specific protocols, and try to have a simplified software maintenance that allows for better fleet management. And these are some of our ultrasound scanners, which are equipped with the robust AI capabilities. Now, we also focused on solving some of the big challenges. For example, in the chronic liver disease, we have an emphasis on metabolic associated steatohepatosis, which has a prevalence of nearly 30%. On the breast cancer, it's quite it's known that the new breast cancer cases account for more than 2 million annually. We are focused on that. As far as cardiovascular is concerned, we are focused on the commonly found diseases in the community, which includes the heart failure, structural heart disease, coronary heart disease, and arrhythmia. We have a one-touch solution that allows the radiologists to not only quantify the liver stiffness, but also estimate the fat content in seconds. Our solution, known as the UDFF with multi-sample automated point shaver elastography, is used for the diagnosis and staging of liver disease. And this research project is basically to address the gaps in the liver healthcare. We have 4 work streams. The first work stream is involved in evaluation of the comprehensive liver care pathway at different centers of Apollo Hospital Group. The second work stream mainly deals with the validation of the integration of the Siemens UDFF and PSWV with the Apollo created AI-LF algorithm or the application. The third work stream deals with the monitoring of the progression of the liver disease at different points of time. And final work stream deals with the validation of the multi-parameter and the multi-modality inflammatory biomarkers so that it's possible to predict metabolic associated steatohepatosis right at an early age. And for this, we are thankful to our principal investigator, Dr. Sudhakar from Apollo Chennai, and also Dr. Sujay Kar and his team from Apollo. And this is how a snapshot of the report looks like. We have the various blood parameters, the patient risk score is being displayed, along with the propensity of an individual to develop a liver fibrosis. We have some interim results out of this study, and my colleague, Dr. Ipshita, would be delving into it.
Hello, everyone. My name is Dr. Ipshita Gupta, and I'm the collaboration scientist for Siemens Healthineers Ultrasound for APJ. I'm based out of Singapore, and it's really a joy to meet with all of you. Talking about the results from our study that is happening in collaboration with Apollo Hospitals, we have some initial results already. As of now, we have about 698 subjects who have been recruited, of which we have analyzed 443 unique cases, but these cases have had about 920 encounters. That means they have come in to the hospital, to the OPD, and we've scanned them. So total we are looking at 920 scans. Now the accuracy for AILF as of now is 0.94 with a precision of 0.88, a recall of 0.75, and a specificity of 0.98. So these are all very impressive results indeed. Overall, if you look at the tables here, in green we have our KPA values, that is the liver stiffness values from the Siemens ultrasound machine Sequoia in KPA, where we have the low risk, that's less than 7, moderate risk 7 to 9.5, high risk 9.5 to 14, and very high risk is more than 14 kPa for elastography. And in black, we have the categorization based on AILF, where we have 3 categories: low risk, moderate risk, and high risk. And if you look at the match, it's quite a good match. We are able to have 372 low risk out of 386. It's 44 moderate risk, and the rest are all high risk. So as of now, the results look very promising, and AILF is definitely doing a good job at risk categorization and risk prediction for liver fibrosis. Here we are looking at the results where we are seeing a good correlation, moderately strong correlation between, again, our shear wave elastography in KPA and GGT. We are seeing a correlation of 0.65. Now, GGT is a marker for hepatobiliary stress, and we have seen there is evidence in scientific journals where we are seeing an independent association between higher GGT levels and elevated liver stiffness. And this is even when sometimes the liver aminotransferases are normal. So this is good convincing correlation that is building confidence in the study. These are still preliminary studies and results, but we hope to have a lot more done in the near future and present very soon. Thank you.
So to conclude, I would like to thank Dr. Sujay, Dr. Sudhakar, Dr. Triyanka, Divya, Bharat, and the support team at Apollo Hospital. Thank you very much.
Thank you very much, Dr. Rajendra Prasad. So we'll have the questions in the end, if time permits. Thank you for sharing brilliant work that's ongoing in the area of liver care. We move from liver care to cancer or detection of cancer. And I'd like to invite our next speaker, Mr. Matthew Prime, who is from International Business Leader for CDS and Algorithms at Roche. So another academic partner of the center. AI-enabled early detection of cancer. All yours. Thank you.
Thank you very much, and thanks very much for the invitation to speak today. So I'm going to talk about how AI can be used to enable early detection of cancer, and I'm going to focus on colorectal cancer. But before I do that, if we go to the next slide, I'm going to introduce you to the Navify algorithm suite, which is on the next slide. Me, I have to do that. Okay, so this is a one-stop shop cloud-based platform that's used to enable Roche and trusted partner algorithms. The algorithms are clustered into disease panels, and then they're embedded into the clinical workflow. Now, when we say trusted partner algorithms, that means that the algorithm has been evaluated. It's a regulated product, so it's been registered by the appropriate jurisdictions, and then it has ongoing post-market monitoring. So we're focusing at the moment with the algorithms that we work on in three major areas. Chronic diseases, thinking about how we can optimize disease pathways from very early detection to end-stage disease. We're thinking there specifically around liver disease and chronic kidney disease, but with an ambition to expand into other cardiovascular, renal, metabolic areas. We're focusing on emergency care, where we look specifically at acute chest pain. And we're also doing some work in sepsis. And we're starting now to think more and more about early detection of diseases, both in oncology and cardiovascular. And that's really taking some of the algorithms on those disease pathways and really focusing in the early stages. So let me talk to you about early detection around cancer. So cancer is a huge challenge for the world and for healthcare providers and societies. It's the second highest killer, and cancers like lung, colon, stomach, and prostate contribute disproportionately to the death toll there. Many countries have introduced screening programs to try and identify patients sooner, although very often those screening programs have low adherence, and they're very costly for systems to introduce. And we know that the sooner you find cancer, the better for patients. So our solutions are very much focused on supporting early detection, also helping systems to increase their screening adherence, and also in that way helping them manage their resources. So if I focus now on colorectal cancer, we know that in a country like the United States, screening rates are around 60–65%. We know in Japan it's around 40%, and we know across Europe it varies widely from 6 up to 70%. That still means that if you take even the US at 65%, that 35% of the population is not being appropriately screened. We also know that if you find cancer in earlier stages, that it's dramatically cheaper for health systems. So there's a real imperative for health systems to find cancer earlier. And we know that that translates to improved overall survival. So I'm going to introduce you to the algorithm. This is Navify algorithm LGI flag, so lower gastrointestinal flag. It has fairly simple known input parameters, so complete blood count and the kind of all the parameters that come within that, and historical complete blood count, and age and gender. And actually, as I was thinking about some of the other presentations, whilst this doesn't look like exciting and lots of input parameters, it's something to bear in mind for academics, that the more input parameters you add in, the harder it is to get approval from a regulator, and the harder it is to implement at scale. So LGI flag is a computational software tool to identify individuals at risk of lower GI disorders, and this has been extensively studied. It's been tested, developed, and validated on more than 5 million patients to date. So we see this very much in the risk stratification space, so really helping to streamline screening programs, and it doesn't replace traditional diagnostics. That will still require pathology and various other modalities. So maybe to talk a little bit about the impact that an algorithm like this can have. So this is an example from the Geisinger Health System. This is a reasonably large health system in the United States, has 10 hospital campuses, 128 clinical sites, and more than 1,700 employed physicians. And they have a nationally recognized AI team that's looking at ways to implement AI into their clinical practice. So the challenge that they face is that the way the screening guidelines are set in the US is that a group called the US Preventive Services Task Force establishes what the guidelines should be, and then the insurers pick that up and they put it into their contracts with their network hospital providers. And if you meet your thresholds, it releases financial incentives. So for the hospitals, it's really important that they kind of get up to these screening rates, not just for the obvious clinical benefit, but also because it's economically beneficial for them. And again, this is something to think about when you develop algorithms, is how does it fit in the system and how will it be adopted, because it's a big economic component to healthcare. So here, the team were able to successfully implement the LGI flag, and they used it to engage those patients that are non-compliant. So for those patients who have not had an up-to-date stool sample or not had an up-to-date colonoscopy, they run the algorithm, and if it flags up, they ring those patients and they say, look, there's something here, you really need to come in and see us. That led to, so for the more than 70% of patients that they rang came in for a colonoscopy, and of those 70% of them had some finding at colonoscopy. Now, that isn't always a cancer. It's very often an inflammatory bowel condition or polyps. But if it's polyps in the US, that changes your screening protocol. So again, it's had impacts beyond just finding colorectal cancer. But for cancer, it led to 8 times more colorectal cancers being detected. So I think this is an illustration not just of what can happen at a pilot level, but how it can create widespread system transformation. So just as a teaser, this year we're going to bring to market something similar for lung cancer. And this is currently we're planning pilots across the United States. So just some final reflections. I had a lovely statement a couple of days ago when we were with the Apollo team about it's better to be an optimist who's half right than a pessimist who's completely right. And I think that one of the things I reflect on here is that AI-enabled algorithms really do offer opportunities to detect cancer and, for that matter, many other acute and chronic diseases. They offer the opportunity to detect these things earlier using identifying novel patterns in biomarkers and then appropriately risk stratifying patients. And this enables providers to intervene sooner. But I think we now need to move beyond the era of pilots and really think about how these algorithms can be embedded into systems so that they can create the transformation that we desire. And I was telling Sujoy yesterday that, you know, the NHS, the UK health system, the NHS, it's fairly famous for doing pilots. And in fact, the joke is that the NHS has more pilots than British Airways. So I think this is something we need to move beyond, and we need to start implementing these tools into healthcare at scale. But in order to do that, algorithms must be rigorously evaluated. They need to be appropriately regulated. And it's not just about achieving regulatory approval. They then need to be actively monitored with appropriate post-market surveillance. These algorithms are subject to drift, and that's something we need to be really mindful of. Secondly, manufacturers need to work very closely with providers, and another invitation for the center is to work with manufacturers and industry, because we can explain some of the challenges that are going to happen when tools are implemented at scale. And then finally, this is a plea to healthcare system leaders, insurers, payers. We need to find sustainable mechanisms to fund these tools. You know, for companies like Siemens and Roche, we can make those investments. But if we really want to kind of create a flourishing startup scene, they will need to have sustainable funding for these types of tools. So that's me done. Thank you very much, and excited to see where this journey takes us all.
Thank you indeed, Dr. Prime. Especially sharing those final thoughts. I'm sure they will lead to some discussion at the end of the session. And I'm really pleased now to invite Dr. Aarti Gokhale to talk to us about Archer and genomic AI pathways. Dr. Gokhale is Sales Director, South Asia, and Senior Manager of Gene Reading API-C Integrated DNA Technologies. Dr. Gokhale.
Thank you so much. Good morning, everybody, and I would like to first thank Apollo Healthcare and specifically Dr. Carr for giving us this opportunity to share the work that IDT has been doing in precision medicine. And I really hope I can leave you guys today with the advances that we have seen in precision medicine in the last 20 years or so, and the meaningful impact that some of these tools are driving.
So IDT has been providing tools for life sciences research as well as for diagnostic kit manufacturing for 30 plus years. And we've rapidly expanded our presence ex-US into Europe and the Asia Pacific market, because these are the markets, or these are countries that are really pioneering at the moment the adoption of genomics and precision medicine into healthcare. And at the core of everything that IDT has to offer is oligonucleotides, and these are really basic small DNA or RNA sequences, but these are really the powerhouses of some of the most cutting-edge tools and technologies that are currently available, not just for diagnostics, for biomarker discovery, but also increasingly for therapeutics. And this really spans across, so there's a depth and breadth to the tools that are available, either in the form of very simple techniques like PCR, all the way up to next generation sequencing, which has gone from being the new kid on the block in 2007 to increasingly being embedded as part of healthcare systems. And it's becoming more and more apparent that this is one of those tools that can have meaningful impact on patient care and even identifying the right management pathways for patients, and also driving the therapy selection more and more towards genomic medicine, away from the traditional one-pill-fits-all approach that has really sustained the healthcare system for the last decades. And next generation sequencing, like I said, has really gone from being a research tool to more embedded in healthcare for precision medicine, for oncology particularly, where there is a very, very clear association between genetic mutations or genetic abnormalities and how cancer either progresses or how a patient reacts and responds to the therapeutic interventions that are implemented. But outside of cancer, there are also several more common disorders like diabetes, for instance, or cardiovascular risk, or liver disorders, where underlying genetic predisposition can have a completely different outcome for the patient, both in terms of the onset of these disorders and how these individuals are to be managed. More importantly, because genetic information is inherited, it not only has implications for the individual that's diagnosed or has the phenotype, but for the broader family. So we've heard from the panelists repeatedly the importance of screening, and one of the primary screening tools that is available today is screening for genomic predisposition markers that really can help you manage everybody's health far better than we have done in the past. And as a result of which, we are moving more from treatment to preventive, right? How can we catch some of these things early so that we are able to prevent from the onset of these disease, or at least have a far better idea on how to manage some of these conditions. And there are some biomarkers, and we've heard about biomarkers. Dr. Reddy has mentioned biomarkers earlier in her talk. And there are several key biomarkers specifically for cancer that are very important in identifying the progression of the cancer, but also in managing the patient and identifying the right treatment for that patient. And gene fusions tend to be a very important biomarker, and there are several tools that are available. This continues to be a field of discovery and evolution. So today we might know a handful of fusions that are key biomarkers for cancer, but this knowledge base keeps increasing, right? And the option or the choices that a practicing clinician or a researcher has is, do I want to limit myself to only the known information, or do I want to make sure that I'm going to capture everything that will have an impact on how I care for this particular individual? So NTRK is one of the key genes in which there are fusions. There is a fair number of known fusions which are clinically important, but just as many unknown or rare fusions that aren't necessarily captured in some of the more commonly used tools. And what we do at IDT is work very closely with our collaborators or with the clinicians to make sure that we are making available to them the right tools that will help them identify some of these rarer phenomena in an individual or in a patient. This is just an example of how you can use some of the tools like Archer, which is available from IDT, to capture every possible fusion that is going to be clinically relevant. And this is a study that was recently done using some of the assays that we have to show that traditional methods might miss some very, very clinically important biomarkers that can drive how a patient is managed by a clinician. The second, and this is also something that was touched upon, is early cancer detection, but also minimal residual disease. Because cancer is a very dynamic disorder, right? It's just because a patient has gone in remission doesn't mean they may not have a recurrence or a relapse. And one of the emerging technologies to really monitor this closely is to track how the patient is responding to a therapy, but also how the cancer might be evolving or changing. And this is something that's captured in how you want to detect these ultra-low frequency variants. And there are a few methods or technologies that are used. There are companies like Natera, Guardant Health, that offer these assays that use a combination of having prior knowledge of the patient's cancer, but also in an agnostic manner, how do we identify these risks of recurrence and relapse, or even non-responding, right? So after a point, a patient might stop responding to a drug that they are on, and the clinician then needs to find an alternate to manage their cancer. So these are some of these tools that are available that you can use in combination to identify the right set of tests that you want to use to monitor the patient throughout their treatment journey. I've not really talked about AI specifically, but at IDT, we are incorporating AI in all the parts of how we are supporting some of these tools, right? So right from R&D, in tool development, but also in the analytics, because in cancer, what you detect is just as important as what you don't miss, or vice versa, right? So these sensitivity, specificity metrics are extremely important, and more AI-based analytics is powering some of these tools that are available. There are, again, cancer is a very complex disorder, so very, very highly complex mutations or regions wherein these mutations are detected or known to be present. So really being able to detect some of these things reliably and reproducibility is a key. And also the continuum that I talked about, right? How this cancer is evolving. So really having the tools to monitor this transformation or evolution across the spectrum is important. I wanted to pivot a little bit, and rather than talking about the diagnostics, I wanted to talk about the therapeutics side of things. Just a couple of slides on CAR-T therapy. So one of the emerging therapeutic options that's available for cancer today is personalizing your own immune system to fight cancer. And all of the tools and technologies that I've briefly talked about support this entire workflow, right from identifying what might be driving the cancer, all the way up to how do we modify the immune system to actually help treat this. And lastly, two more slides about a very, very recent example where IDT participated in treating a child that was diagnosed with UCD. This is a very rare genetic disorder, but something that has very severe impact on how the lifestyle of that individual. And there are traditional treatments, but what the field is moving more towards is how do you cure this, right? How do you edit out some of these genetic abnormalities and transform this individual's life from having a lifelong chronic management to really curing this as early as you possibly can. And for this particular patient, IDT worked very closely with the clinicians and with some of the other stakeholders to develop a very personalized treatment in less than 6 months. The patient was dosed in Feb 2025, and this is something that got a lot of media attention because this child, as of date, is symptom-free and really cured from the disorder that they have. But this is just one patient, right? How do we make sure we are actually making this available broadly? So IDT is partnering with the Chan Zuckerberg Initiative and some of our other partners to make some of these technologies available to broad set of genetic disorders beyond cancer. And we are looking forward to working with Apollo to drive some of these things and bring these technologies into the Apollo healthcare system. Thank you so much, everybody, for your time today.
Thank you, Dr. Aarti, for a wonderful talk. Ladies and gentlemen, can I have a round of applause for all our speakers? We have seen how the digital transformation is happening, and what we've seen is that being in action with all your support. And what we have on our panel is combination of academia, industry, funders, and thought leaders. And we've got 4 or 5 minutes for discussion. So are there any burning comments, questions in the audience? Do I see a hand going up? Yes, please. Could we pass on the mic? Could you please introduce yourself for the benefit of everybody else, and then
faculty of AIMS. From there, I founded National Institute of Immunology. Now, I'm 99 years old. I have my own little setup. Let me first tell you that I'm impressed because these are exactly the things that interest me. I'm working on cancers and on drugs-resistant cancers. I have a sort of toxin, immunotoxin, which can detect and kill such cancers in culture, because the cancers is a complex issue. But there are cancers which are drug resistant. They also express HCG ectopically. So my strategy is to make a immunovaccine or immunodiagnostic where one part recognizes such cancers by virtue of the HCG present on such cancers, and the other part, which is sarcine, toxin, kills it. So it selects the cancer wherever it is, and then it kills it. The work so far is in culture, and I do not know where to take it further. But it is very promising. I mean, in a whole lot of cancers which are drug resistant, totally drug resistant, they don't last anywhere. Anywhere in the world, they die very early. And so here is an approach which is available, and I need partnership with industry to take it further.
Thank you very much, Dr. Talwar. So I'm sure our members of panel here will reach out to you, after this session, and see what can be done. And Sujoy, who's sitting at the back, maybe Sujoy, Dr. Talwar, we could have a conversation, see how we can take that forward. Thank you for sharing that thought. Thank you very much. We got 3 minutes. So I think it'll be worth asking panel, because we've got, representation from academia, funders, as well as industry. And in the audience, we got similar mix of people. So it'll be worth getting your thoughts, a one-liner on if your life was to be made easier, what one thing would you ask society at large, which is mixture of doctors, clinicians, patients, as well as industry. So we might have 5 bullet points to take home after this. So if life could be made easier, what one thing would you want? Sir Nilesh.
A philosophical question, so I'll answer philosophically as well. I think what we learned from this conference is people need to embrace change. So I think the issue here is, I think it was mentioned yesterday as well, and other people have mentioned it around, and the guru who came here to talk to us yesterday also mentioned this around how you combine spirituality with science. And I think embrace change for the right reason, which is around patient care, is my mind.
Yeah, really great question. I'll add 2 tidbits. The first is going back to our mission, digital health gives us the opportunity to act without boundaries and really embracing that. I think we have a really nice diversity of both applications and techniques on the panel here, and how can we leverage the vast amount of information that will be coming out of AI, these new tools, the tools that already exist, but how we're looking at them differently and making sure that we're collaborating across borders, across application spaces to drive these to impact as fast as possible. And then my last piece that I always like to add is context matters. If we take data out of context, we lose a lot of information, so make sure we maintain context.
To be short, since this is on AI, I would like to have more of a structured data being captured at every point of time so that the data is curated and leveraged to the optimal capability. And also the AI solutions that we need to be developed should be governed by ethical standards, high level of ethical standards and data privacy. Thanks.
Thanks very much. So I think I would advocate for partnership across boundaries, across countries, and across industry, academia, and providers. I think that's how we're going to make this opportunity realized.
I think we are living in one of the most exciting times there is for healthcare, right? The level of data that's available, the AI tools that are available, and I really hope that the clinician community will leverage and utilize these tools that are available to make sure that they are really driving patient care in the best possible manner.
Thank you very much, panel, for that. So I think 5 bullet points take home are embrace change, and for that we need to bust all the boundaries, whether they are national, international, whether they are to do with academia or different communities. Structured data and ethics around it, very, very important. And final comment we had, we need clinicians at the center of it, driving it, embracing it, and taking it forward, because that's the vehicle through which average human being, average patient will benefit. Ladies and gentlemen, that concludes the session. May I ask for another round of applause for brilliant panel that we had. Thank you all for sticking to time, and thank you all for your thoughts in the end. Thank you indeed. Thank you.
Thank you so much. Request you all to kindly come ahead for the photograph, please. Healthcare intelligence is no longer the future, it is here. Please, once again, give a round of applause. With that, we now move to a very special segment, a leader whose journey spans global healthcare, technology, and corporate leadership. Please welcome Mr. Omar Ishraq, former chairman and CEO of Medtronic and former chairman of Intel Corporation. Please put your hands together. He will now deliver his keynote titled From Innovation to Impact, Leadership Lessons for Improving Healthcare Outcomes at Scale. Mr. Ishraq, the stage is yours.
Yeah. Well, it's a pleasure to be here. And let me just give it a few minutes before they clear this up, and then we'll start. Okay, well, I'm really delighted to be here. And the session that I just heard in itself was very impressive. And I don't know how much more I have to add, but I'm going to focus at a higher level in the context of healthcare. Okay? And give you a perspective. And then after that, you know, Sangeeta Reddy is going to be here, and we'll have a little discussion about it, and I'll welcome some questions as well. So let me tell you about my learnings and some of the basic facts and principles that I've learned and I try to follow. You know, the first one is this. There's two big unknowns in the world which will not change for a very long time. One is our knowledge of the human body. I mean, there's lots of physicians here, there are lots of medical practitioners, and I'm sure you'll all agree with me that our knowledge of the human body is somewhat limited. We know a lot, and we've learned a lot over centuries, but we have to learn a lot more. Our understanding of how the neural system works, our understanding of how the nervous system works, how treatment is provided, how the body changes over time, there's no end of learning. So it's something that we got to always remember when we talk about healthcare, is that the human body is something that we will continue to learn about and develop our thought process. The second other fact that I always resonate with is that technologies is also going to change. And I don't need to tell you, but you know, you'll all agree that 20 years ago, what we thought was computational power was modern. Today, that's considered obsolete, maybe even 5 years ago. The journey from the mainframe computer to a cell phone, which is, I don't know, 1,000 times powerful than this big machine 30, 40 years ago, is a trend that will not stop. I mean, it's difficult for me to imagine. I mean, there's all kinds of theories and projections about what the world will be like with AI, with generative AI, with agentic AI in the future, and other things that we don't know about that will come up. So these two basic principles are very important, and I think as we talk about healthcare, we should always remember that. There are know-how of healthcare, of the human body, and the journey through technology are things that will constantly change. And I've tried to apply those principles in everything that we do. The second important point, and this one I want to really make strongly, because there's a lot of healthcare professionals here, and this is a healthcare institution, but you know, improving outcomes, expanding access, and optimizing costs are three big things. And improving outcomes is a goal that we all have, which we heard a lot about. In addition to that, connecting it with accessible improvement in outcomes is a big challenge. What we have available today in one country is not available in another country, which may be much larger with a much more needy population, and it's still not available. So how you scale things is important. And equally, like I said before, you have to always remember that our know-how of healthcare will always increase, and so outcomes will continue to improve. So the speed with which we can scale that know-how is extremely important. But the third, and perhaps the most important point, is that as we do that, we can optimize the cost and efficiency through which we deliver healthcare. So 3 big points. Outcomes get better, access should always be increased, and cost, through by its very definition, through scale, will actually come down, which really takes me to the next point, which is what value-based healthcare is. And value-based healthcare, in a simple definition, is that the health outcomes that are achieved that matter to patients relative to the cost of achieving those outcomes. And the value that is created is the outcome improvement over the change in cost in delivering that value. So in other words, you can create value by improving outcomes at the same cost, or by keeping the same outcome and simply lowering cost. Both of those generate value. But what this means is that as you introduce technology, the cost of healthcare over time should go down, not up. So I recognize the increase in healthcare costs all around the world. That's a fundamental flaw in our system. If healthcare costs are going up all the time, and outcomes are also improving, why is that the case? Because if outcomes are improving, patients should need less care, not more care, over time. Then why is cost going up? So it means that there's a high degree of inefficiency which has to be addressed. Now that's very easy to say, it's very difficult to do. We can talk about value-based healthcare in general, but that doesn't really mean anything. So my learning from value-based healthcare is that it has to be precise, it has to be granular, and very, very granular. And the 2 big sort of rules that I've learned in this process. The first is that the clinical outcome has to be precise if you're going to pay for it. And that precision is going to vary depending on the specific cohort that you select. The same treatment for a 70-year-old may have a different outcome than a 40-year-old. And you have to be precise about that. So the cohorts have to be very specific and identified. So you cannot talk about value-based healthcare in generic terms. You have to talk about it in precise terms, which you then scale. So that's number 1. Clinical outcomes have to be linked to specific cohorts. The second is, well, who are the stakeholders? Because to achieve an outcome, sometimes just giving a drug does it. But typically it requires a behavior change. It requires just accuracy in providing the treatment. Did the pharmacy get the dosage right, the drug right? Was the patient given the right instructions? Was there enough follow-up with the patient? I mean, I can come through a whole series of other things. But essentially, for achieve a given outcome, one has to almost list who are the stakeholders involved in achieving that outcome. And some kind of accountability has to be created for each of those stakeholders. Now, this is much easier said than done. The approach that I took, specifically with Medtronic and in my general thinking, is that try to find places where the cohorts are very well defined and the number of stakeholders required to achieve that benefit is relatively small. Then you can create a model like that. But that's an example where you show it. If you want to do it across in a large scale, you have to engage all the stakeholders. So this is a tough problem. And you know, for a healthcare system to flip suddenly to this is not easy. But I think countries where healthcare systems are less established, you have a bigger opportunity. And I'd really encourage countries who are developing healthcare not simply to copy what's available in the Western world, because they've not done this. And therefore, costs go up, when outcomes get better, which is a fundamental flaw. So that's the one big point I want to make here, is that the cost of healthcare should go down over time. Budgets should not be a problem rather than a problem. And I understand that's a philosophical statement. It's difficult to implement, but let's not forget that. And in our thinking, let's try to use that. So that's what I think about value-based healthcare. The other thing that we heard a lot about is the use of AI, and at a high level, I think of AI with three different sort of buckets, if you like. One is for personalized patient care, because every individual is different. Even if there are narrow cohorts, within the cohort, an individual is different, and I'll talk a little more about that. And then from an administrative part, it reduces the administrative burden. The amount of write-ups you have to do, the amount of documentation you have to do can be done through generative AI, through agentic AI. You can connect those. There's different things you can do there. And then, of course, in the diagnostic part and the procedure part, you can use AI to do the diagnosis more efficiently, more accurately. But in healthcare, you really have to have an oversight over that because, again, every individual is different. AI is built on data that has been collected, and the future can be different from what has been collected, and you have to be very aware of that. So a checkup on that is extremely important. Let me actually talk about two things that interest me personally. And I'll give you examples of where this can go. And I'll conclude with that, and then maybe I can have a discussion and answer any questions. The first is what I call NF1 and customized treatment. We heard quite a bit about that earlier, but when I think about NF1, I think of it as the improvement of a patient's health over time, because a patient's behavior changes, a patient gets older, lots of things change. And can we customize the treatment for a patient and optimize the best therapy that's unique to that patient at that very moment? And I'll talk more about that. The second is an area that's close to my interest. Ultrasound imaging is an area that I've worked on for decades, and I've never lost technical interest, and I've seen a lot of sort of progress there and really revolutionary things going on there, which I'll talk about for a few minutes. First, the customized treatment, and we heard a lot about this already. So in summary, look, they're wearable biosensors. But think of that as one category. And then there's a description of the patient background. Separate the two. One is real-time data. The other is specific data on the patient that is taken at one time. Their other disease states, their condition, their age, other complications, all of that is a one-off thing. A biosensor gives you real-time, constant data. And the third thing is what is the context and the overall background of that patient. Using these three things, you can make a therapy recommendation that's dynamic. And I think we'll get to the stage where dynamic means every hour, which seems crazy right now, but think of the future. With AI, with the data coming in, with the speed of the data, with the amount of biosensors, why can I not adjust the dosage for, say, blood pressure medication every day, every hour, depending on what the need is, as opposed to a treatment that is given based on every 3-month checkup of blood pressure, which is highly undersampled. So can you give continuous treatment is the thing that I'm talking about here, and therefore optimize that treatment and medication real time or as frequently as possible. And in some disease states it'll be more important than others. Chronic management will be more important. Maybe in cancer it won't. Maybe the frequency will be less often. And sometimes you do have one-time cures, but in general you don't. I'll give you an example of that in a very simple area, which is weight loss, which is very popular right now, and people think a lot about it, but they all think about taking a drug. But the dosage of the drug is important, actually, and depending on the patient's behavior, that can be changed. And obesity is something that certainly can be impacted by patient behavior. So here's an example where a patient gets an app, a scale, which is very simple, and then there's a generative AI coach for that patient. Based on the behavior of that patient, patients get coaching. And we did do, I was associated with an organization who did this, and through all these things on the left, food and nutrition choices, customized, linkage to the patient's progress, real-time data from the wearables being used there, and continuous monitoring of the metabolic profile. Through that, and through AI-led, sort of generative AI-led coaching of the patient, the weight goes down. But the nature of the coaching changes over time, and generative AI can help you do that. So all I'm saying here is that the effectiveness of the treatment can be changed on a regular basis. And the last thing I'll talk about is something that I'm very interested in, and something that's a long-term, not that long-term, but not ready right now, but in the next few years will probably start to take off, is the use of AI and ultrasound in a much more dominant way. Ultrasound technology is evolving in a way that instead of just picking up data for one slice, you can pick up data from a volume of data. And then from that volume, automatically select the slice. And if you do that, then the user dependence of ultrasound goes away. And if you can now put a patch through which the heart is constantly monitored, you can do many things. Treatment can be changed, the way in which you deliver things can be changed, but I do think ultrasound is going to go to a space where it'll be much more generic and much more powerful. Slice selection will be automatic, and there'll be much less user dependence. That's really all I have to say. I was hoping to have a conversation and answer any questions, and I think we can take it from there. But I thought I'd share at least my thoughts with you. They were fairly high level, but thank you all very much for your attention.
Thank you, Mr. Ishraq, for that deeply insightful address. We now continue with a fireside chat on leadership and healthcare transformation. Please put your hands together while we welcome Mr. Russ Branzel, CEO and President, Chime USA, and Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospitals Group. Please put your hands together.
Good afternoon, everybody. Thank you so much for being such a fabulous audience, but I think we need to give Omar Ishraq a bigger applause. We're so glad he's here. We've been talking about AI for the last 2 days in every third sentence. The AI won't happen unless people like him had created the chips. So as the chairman of Intel and then went on to become the chairman of Medtronics, I don't think there's anyone in this room or in this whole convention center who is so uniquely appropriate for this conference, because you have healthcare knowledge on one side and IT on the other. So I'm super happy that he could make it here. He diverted a trip to come and spend time with us. And I also realized that I needed to have more intellectual power to speak to him, and that's why I requested Russ Branzel to join me on stage. So we're going to have a really freewheeling conversation, just, sharing thoughts. And we have only 15 minutes, so we're going to do real quick, almost like fireside, or rapid fire type questions. And then I'm going to leave the last 5 minutes for the audience. So 3 people in the audience, please be ready with your questions. I'll jump in, straight. Omar, the presentation was fabulous. I saw some of your thoughts in Riyadh. He spoke and presented something similar to this to 67 CEOs of hospitals across the world. And everybody is looking at this next phase of healthcare. So Omar, in this thing, what do you think people in the room, people like us, what are the top 2 things we need to do now to ride this new wave? Is it the weight loss app? Is it the AI? It is the digital, anything that you think are our top 2 priorities?
Well, look, I mean, there are so many different applications, it's difficult for me to choose. I'll only choose ones that I know, so that's not right, and I shared two of them.
Right.
But I think the thing that I really want to emphasize, which I repeated many times, is that remember, better outcomes, lower cost. So don't ask for more money all the time. Okay, that's something that...
Now this is a problem. I just did an NDTV interview. They said, what do you want from the budget? I said, more allocation for healthcare.
That's fine. That's fine. Then healthcare should get better equivalently. So have a return on investment for the investment that's made.
We agree. We agree.
So that's a basic principle, that improved outcomes lowers cost. And if it's not lowering cost, there's something wrong. Either it's inefficient or the outcome isn't really getting better, or you're not scaling it. So that philosophy, I think, which in principle is called value-based healthcare, but people haven't really adopted it, they just talk about it. But if you really adopt it, costs will go down, not up in healthcare. Now look, I know there's inflation, I know you want to project things in the future, and at least lower the rate of rise. Okay?
But actually, Omar, I think I agree with you, and many Indian operators in this audience will agree. And one of the things which drives that is when you're directly in touch with the patient. Exactly. India has the highest out-of-pocket expenditure compared to many other countries, and also the lowest cost of healthcare delivery per episode because of this direct connect. So it's a very, very interesting time in the evolution of care, and I truly believe that we are bringing down the costs.
Yeah, and I think on that point, I'll just make one more point on that same subject. I mentioned two things. And this is, it sounds like a controversial statement to a hospital system, but you're more than a hospital system, as you've heard. You're a population health system, and so it's very relevant. Remember the phrase, hospitalization is a failure of medicine. Okay?
It's superb. Please capture this one.
Hospitalization is a failure of medicine.
Failure of medicine.
So your goal should be to prevent hospitalization. That's when you've got successful healthcare. And hopefully the hospitals can treat patients, focus on patients who otherwise would be dead.
Which is exactly what I said in the other hall just 1 hour ago, which is the focus on proactive, preventive healthcare.
Exactly.
Build health systems which are picking up problems early. I don't feel heroic anymore when we do a 5-vessel bypass surgery, even if it's minimally invasive. Because the question is, where was that person when his first vessel was getting blocked?
Exactly.
When you find a person in stage 4 cancer, you're going to operate, you're going to treat, you're going to use proton. But could I have found him when he was in stage 1?
Exactly.
These are the type of critical paradigm shift questions that all of us have to be asking ourselves. So both of us are uniquely on the same page, but we have lots of CIOs in the room. And the cost of cloud is high. The cost of apps is going up. The ability to interconnect all these things is getting tougher. And I know Russ wants to ask a question.
Wonderful to be on stage with you, and a big fan of all the companies you've led. I've owned a lot of the stocks, so thank you for creating a little wealth in life. But we've never had a greater opportunity to make a difference with technology, not just in healthcare, but really in any form of the economy. All while now there is an absolute fear and trepidation out there about AI that we're going to lose the essence of what being a human is. So there's this weird balance of taking the maximum opportunity to use technology to make a difference, access to care, quality, wellness, all these things. At the exact same time, there's a fear of this relatively new technology. How would you suggest we balance that and maximize the opportunity?
Well, first, don't walk away from it. Okay, that's obviously going to be a problem. But you got to remember, AI is built on existing data and the human mind. Look, we talk a lot about how smart these chips are. We talk a lot about that. And the human mind is orders of magnitude more sophisticated than anything that anyone has done. And the human mind continues to evolve and get smarter and smarter. And as AI techniques come up, I think you'll learn how to use them as opposed to get dominated by them. I just think that'll happen. Look, I know there's a lot of debate about this stuff, and one wonders about that. But if you just look at history, the way, and we talk about jobs going away and all of that, new jobs will come. You know, horse cart drivers went away, cars came. That's how life goes. This is just happening at a higher speed with things that are more difficult to imagine, but it'll happen. And so in my view, remember that AI is built with existing data. Just remember that. You cannot forget that. It's built with existing data. Now, there's more and more data. Data is increasing over time, but it's still existing data. And the mind is smarter than that. That uses the existing data to change the future. They'll change the data. So I think thinking about it in those terms is important. And again, I know there's lots of operators here, and I'm talking philosophically, and it's easy to talk philosophically. To convert this into action requires granular focus, but you can't forget the philosophy at the same time.
Maybe a little follow-up to that. As you get to see stuff that we don't even get to see in the field, what as you see maybe the application of, or maybe new technology coming that's going to make as big an impact as possible to exactly what Sangeeta is talking about giving us opportunities to proactively treat things?
Well, actually, you know, the two things I kind of mentioned are things that are very close to me. And again, I mean, I can only say from my experience, and others have other experience, and there may be other things that are bigger. But from my experience, the ability, the sensor technology will grow over time. And you'll get, even from a single sensor, you'll get more kinds of data, and you'll get other kinds of sensors, and you can see that happening. But what's happening in the world today, the way industry is organized, the sensor company thinks they build a sensor and they're done. And actually, that's the beginning. You've got to learn how to use the sensor. And using the sensor with the data to customize behavior change is a big thing that's going to happen. And I think that is very important, and recognize that these sensors will give you more and more information. I think blood pressure is one that I really think about a lot because I've seen people who've had serious issues because essentially they've been over-medicated because of, you suddenly fall, collapse to your head, you can get problems. And I've seen that, and so, and that's not quite there yet, but continuous monitoring of blood pressure will come at one time. Learn how to use that. So that's one example. The other one, actually, which I talked about briefly, but I'm very close to, is I think the usage of ultrasound will change dramatically in the next 5 to 10 years, dramatically. And the basic things I'm talking about here is that, today ultrasound imaging is operator dependent. I used to talk about this when I was, decades ago, that in CT and MR, the patient goes to the diagnosis. In ultrasound, the ultrasound goes to the patient. Okay, there's a big difference. That makes it user dependent. And the way this is progressing and what I'm seeing happening is that semiconductor technology is going there, and you're going to get systems which are far more powerful, a lot cheaper, and a lot smaller. The entire system one day will just be a single chip. And with using AI with automated image selection, it can become a monitoring device. So pay attention to ultrasound, is all I'll say.
I completely agree, and I'm so happy you said this. One of our projects is that we're doing AI embedded in the ultrasound probe for early detection of NAFLD. 40% of the Indian adult population is at risk for NAFLD, non-alcoholic fatty liver disease. And it's very easy to miss. You need a skilled technician to pick it up. So we're putting those image capture against this so that you can message from your ultrasound probe into the machine and do faster, smarter diagnostics. And there are hundreds of such opportunities.
Yeah, well, we should talk about that because what you're saying today, you still have to use a probe and then get the data. In the sorts of technologies that's happening, just put a patch on there and it'll collect it by itself.
Even ultrasound?
Yes. In the future.
Okay, in the future.
But not that far. Within the next 5 years. So it's not like a decade from now. Within the next 5 years, you're going to see things like that, and we should.
But think about what you just said. This is important because think about it wasn't that long ago that we got electronic thermometers in every home.
Right.
And think about this. Every mom, because we know moms really take care of kids, not dads. Every mom in the world is going to have their own ultrasound at home before long. It's going to be a commodity that everyone just has in their home, and it's their way to electronically connect to you for the eventual diagnosis, but they're going to do their own ultrasounds at home.
I love it. It will happen.
It's going to take some time. I mean, it's not going to happen tomorrow, so let's not going to, but it'll happen.
And we have to make it happen at scale and cheap so that everyone can afford it, and it's not just elite moms who have it. We need every mom to have it. But that's perfect.
Look, I do think, Sangeeta, that India, I'm visiting India for the first time in 4 or 5 years, and there's just a tremendous amount of progress. I mean, I'm really impressed. But, there's an opportunity in this country. The opportunity is that you've got good healthcare at a certain level, very good. You've got access to technology, and you've got a large population, and you don't have an existing healthcare system that people are stuck with. You don't have, payment mechanisms and things that are driven by a thought process of old.
You're right.
You have an opportunity here to revolutionize, you really do,
So
at scale.
this is the flywheel we're trying to build. Large data, cost effectiveness, new technologies, prevention. Put this into a positive flywheel and elevate the standard of care and the proactiveness of care so you reduce the burden of disease. That's really the model that we would love. We promised the audience questions. So fastest hand first. Very quickly. This up there, back there, please stand up quick, get him a mic. We don't have time. Or get her a mic, lovely. Go ahead.
So this is a very value-based question because since Dr. Umar was also talking about it and Dr. Sangeeta is also saying that we have mixed audience, that is healthcare and IT both. So the question is, what one valuable or one improvement you can give to the IT company so that we can improve and help and support the healthcare industry? I'm sure this valuable thing will all the IT persons will relate to, and they will take this lesson as to improve more.
Okay, Omar.
The question is, what advice do I give to the
One
IT?
advice to IT companies
Yeah.
to work in healthcare better?
Yeah, I think, remember, there's a difference between a platform and a product.
Right.
IT companies think of platforms. Link the platform to the product. And that means, although you're building a platform, make it granular. And depending on the disease state, it can be more or less, the commonality will differ. So connect. So the platform to the patient, connect. And I really encourage IT leaders to think that way. Don't think your single platform is going to solve everything. It's not. And it's going to solve things differently. So get granular.
This is deep wisdom. Thank you.
Thank you so much, sir. Thank you.
One more question over there. Go ahead.
Thank you so much, ma'am, for having this, and Omar. Excellent insights. I'm an IT person, so what would be one advice to the regulators and policymakers to really realize the vision which you called out?
Omar, we're recording this answer. Please go ahead.
Well, look, I think you've got to respect the people who make policies. I mean, they're accountable to make sure that there's no error through which people will die. And you don't need too many deaths, only one, for it to become a real problem. So that's why they're careful. Now, at the same time, if you don't change anything, you won't get anywhere. So my advice to the policymakers is the same principle that I'm talking about is walk through, what is the, be a little more granular about the extreme negative impact and try to kind of dictate the policy that in some places you can take a shot. I mean, the worst case.
For example, ultrasound.
Yeah.
What you said, ultrasound doesn't go to the patient in India.
Well,
because there's a limit on the number of ultrasounds, it has to be licensed against a location. So you're right. So let there be granularity in policy so that you look at customer impact rather than wide sweepingly controlled.
Exactly. That's exactly what I'm saying. And be very granular about that. And I think policymakers try to make a one thing, and everyone's different.
Right.
And so you can't do that. So I'm repeating it over and over again, but granularity in healthcare is important because every person is different.
Perfect. Thank you so much. We're going to one last question over there.
Thank you, the three of you, for an amazing conversation. I'm Dr. Sai with Apollo Hospitals. The two numbers strike us always. 28, India's average median age, and 4.5 billion humans do not have access to essential health services. What would you suggest as a way to fix that in the next 5 years?
So he says there's a significant number of elderly and significant number of people not getting access to care. What would you suggest to fix it? He obviously has some answer in mind. Let's hear what you have to say.
Well, look, I think you've got to reach out. I mean, start.
Omar.
Yeah. And I'll just keep repeating myself here, but the linkage between platform and patient has to always be there. And so what I suggest is, you know, when you put technology somewhere, make sure there's doctors there, okay? Make sure that you've got access to the patient. Don't just put technology everywhere, and you don't have doctors in half the places. You're wasting money. Train the doctors. So this linkage between availability of technology and usage of technology has to be granular. And I think just keep doing that, back and forth. You can build the world's greatest system for that. Look, I give the example, I can take a bunch of pacemakers, the latest version of pacemakers, and I give it for free to a village clinic in India, in an Indian village. They'll put that in the trash can. They won't even know what it is. You know? So you've got to put it in a place where people are trained to use it, to understand it, who can value it.
So Omar, you'll be very happy to hear that we have 10,000 Garmin watches in the village looking at lifestyle modification, behavior, signaling, and then trying to build the apps, the messaging, the doctor training around that ecosystem so that we can scale. So you're absolutely right. Sai has a remote care platform in mind. So Sai, your platform needs to connect to your doctor and your patient.
Yes, absolutely.
You got the answer.
Yeah. Thank you so much.
Omar, thank you so much. I cannot say with mere words what a great pleasure it is to have you here and what a message it is to everybody. For me, the message is that the work that all of you do counts. Because what you do counts so much, because this moment in time is so critical for the betterment of the world, Omar came here. So thank you.
Thank you so much, Sangeeta.
And Russ, thank you.
Thank you so much for a truly inspiring conversation. Ladies and gentlemen, another round of applause, please. We now move to a spotlight on AI-driven digital healthcare powered by co-pilot technologies, featuring Mr. Rajneesh Kinney, Chief Operating Officer, New Realm. Please put your hands together as we welcome him. Mr. Rahul Vinod Upputuri, Chief Technology Officer, Apollo Health Access. Mr. Gangadhar Godandaram, Consulting Sales Director, Microsoft. And lastly, Mr. Balaji Uppeli, Chief Business Officer, New Realm, India.
Morning, ladies and gentlemen. Thank you very much for this opportunity. As you can see, my name is Balaji, part of New Realm. We will quickly get into what we are here for and what we are going to share with you. Let me quickly introduce you to the key people who will actually be along with me on the stage, participating in the conversation. Rajneesh Kinney, the Chief Operating Officer for New Realm. He will actually carry out a quick demo of how we have used Copilot and AI technologies to do the transformation of building new products and platforms in the healthcare space. We have Rahul from Apollo Health Access. He is actually helping us collaborate in finding out what is the right approach in bringing transformation into healthcare and specific use cases. And Microsoft is another third participant here as a partner. We have Gangadhar, who is the Director of Consulting Services, who's actually going to help us understand how Copilot and Microsoft are continuously innovating using AI technologies. Ladies and gentlemen, very briefly, all of us have seen the advent of AI. All of us have seen how AI is coming central stage into our lives. We're trying to figure out how AI can be used in building new platforms, in transforming existing platforms and making it digital, and more importantly, helping the platforms and the products to scale for the future. In doing so, and especially in healthcare, how do we bring in AI? How do we bring in the various tools and platforms available to make this transformation quicker, faster, and more importantly, available to everybody in few minutes, few seconds, few months? That's the intent. With that said, I'm going to request Rahul to please share his wisdom and why this transformation and how this transformation is actually going to be helping in the healthcare space. Rahul?
Hey, good morning, everyone. I think, so everyone thinks of hospital systems which are very, very modern, seamless patient experience, extraordinary operational excellence. Everyone wants a state-of-the-art system which is driven by AI, futuristic, but it is always not the reality, especially in large-scale systems. We tend to carry a lot of legacy, lot of transformation that is always happening at every stage. And the reality of the systems is that, especially in healthcare, a deceptively simple system of billing, for example, which we have demonstrated with New Realm, is, while from a user experience it is very, very simple, behind the scenes there are more than 150 different odd workflows, whether it is discounts, packages, approvals, availability, scheduling, all of them have to come together, approvals from clinician, approvals from capability of the payments in terms of insurance availability, etc. All of them have to come together in the single workflow to enable that small billing payment for the user. Now, with the reality of the system that is existing, these are evolving systems. As and when we learn that there is a new process, new workflow, they are usually digitized, then they get improved based on the feedback, based on the new regulations, policies that are coming in, new service lines that are coming in, new contracts that we do with the insurance companies, etc. All of these workflows are essentially a living behemoth that are living in the system. But for us to transform them from the current state to an AI agentic driven state, it takes enormous amounts of effort. And I think with the technology that I think Balaji will explain, we are able to do the transformation, number one, at a much, much faster pace. Number two, the knowledge that comes as part of the transformation is not just going to be helpful in the scale today, but also going to be a living knowledge base for the new transformation that is needed tomorrow. So how do we ensure the saving of those knowledge as reports into the process of the transformation itself? I think that is something Neural has shown real value in. Lots of different approaches to solve this for, but the experience of building transformation projects, executing them at scale, and saving those knowledge bases not for the current teams, but also for the future teams who are coming in, future innovation that is coming in. That's the secret sauce I think the teams have cracked. Super happy to listen to the other speakers.
Thank you, Rahul. From Microsoft perspective, Microsoft continues to push the boundaries of what's possible by challenging ourselves to drive efficiencies in everything what we do with our customers. And second thing is on strengthening the platform and accelerate meaningful transformation for our customers and for our users. With Copilot in specific, we are constantly discovering new opportunities to simplify the complex processes, scale with confidence, and elevate user experience that was not achievable before. The demo which you will see today in the next few moments will bring this vision to life by showcasing how engineering excellence, product innovation, and business insights come together, powered by AI. By partnering with Apollo and Neural, we are combining best of all worlds to deliver a future-ready, intelligent, and seemingly scalable platform to drive transformation and thereby to bring efficiencies at scale to our large customers. I'll now call upon Rajneesh to talk about the demo and also run us through the demo. Thank you.
Thank you, Ganga. Thank you, Rahul, for setting the context, and good afternoon, everyone. So we're talking about NewGain as a platform that we built to bring in much more AI-led approach to software development, agentic run-ops, as well as on the data journey for our customers. We launched this sometime in October, and it has various aspects of integration with the Microsoft technologies, including Copilot, Fabric, and many other components to bring it together and make it much more sophisticated for our customers. Let us look at how it works in this particular scenario. We have about 7-8 minutes of demo. So NewGain has 4 major pillars that we are talking about here, right? It can look at application modernization, business logic extraction, and it can look at migration of data, and finally it can also look at the reports that are existing in this environment, right? These are the 4 layers. Today, considering the time we have, I'm going to spend much more time on the business logic extraction, which is the most complex part of this, right? Where you have to actually identify the legacy business logic and migrate that into a new platform. And as Rahul mentioned, we are talking about a complex hospital information management system here with about 10,000 stored procedures. And as we know, these systems are like a heart of a hospital. And in this case, these 10,000 plus stored procedures were really blocking the arteries, right, in terms of speed, in terms of executing on the ground, and also making changes to the application was becoming very, very difficult for the hospital. We are migrating this into a .NET-based microservices architecture so that the deployment speed, change management becomes much more faster. Let's log into the product here, to the platform, NewGain platform. The 5 stages of NewGain platform from discovery, planning, future state topology, migration, testing, and validation is what we will go through right now in little more detail. The first stage is all about discovery and analysis. We have to understand the business logic in the existing system, plan for its migration to a new platform, look at what will be the future stage architecture, and take it to the migration and testing for final stage. In the discovery and analysis phase, we are doing a deep code analysis to understand, reverse engineer what is there in the code right now, right? It's not just about reverse engineering, but also applying the right risk assessment, right migration strategy, understanding the technical risks, all of that. We start with a workflow here. The first stage is to point to the repository of the old application, which is the hospital information system here, and then we take the data from there. As I said, about 10,000 stored procedures drive the business logic in this application. We are going to pick one of the stored procedures, Postgres-based stored procedures, to drive this process. This can be done in a much more automated way. For this demo purpose, we are manually picking at one of the store procedures, but in a real scenario, this will happen one after another in an agentic approach, one after another. So first step is analysis. We are doing the analysis of the existing store procedures. The discovery and analysis phase is going to lead us to a business requirements document automatically generated with 12 sections in it. It identifies the complexity of the entire store procedure, comes up with the existing architecture, comes up with the data mapping, data schema, looks at the technical architecture of what it is doing, what is the front end that will look like, or the UI part of it as well. Looks at the data mapping, data flow existing inside the application or the store procedure here. Also looks at the performance as well as the business requirements, because it's important to make sure you maintain the business requirements parity, functional parity, as well as improved functional productivity. The next stage is strategy and planning, where we look at the migration strategy and define a migration strategy, whether you go big bang or coexistence kind of an approach. So strategy and planning session, again, you pick up the same store procedure, but define the target as a .NET based architecture and go through the planning section. Again, what you're seeing here is a much more accelerated demo considering the time. It takes a little more time for AI to analyze and come up with this strategy in reality. So the migration strategy document automatically gets prepared, right, with an approach for analyzing whether coexistence is the right strategy or big bang is the strategy, defines the data conversions, data mapping, all that is required. The schema that is in the source system as well as in the target system, what are the additional change requirements that you need to build in? Also defines a well-structured migration roadmap with timelines, right, with details in it. It needs further fine-tuning by the next phases as well as human intervention, but it defines the comprehensive rollback plan, risk assessment and mitigation plan, which is all helpful for this migration, right, because if something goes wrong at the right stage, you need to be able to roll back. It defines what is the success criteria, what should be the code review, etc., in this stage. The third stage is the future state topology definition, right? Here you define how should the target architecture look like, microservices-based architecture, data flow for that, ER diagrams, and also a little more detailed implementation roadmap, also including security now. Data security is very important because you're dealing with patient data. So we are moving to the third stage and executing this now. So as I said, it takes some more time, but again, accelerated way. These are the ER diagrams and data analysis that gets generated. Clearly shows the source side as well as the target side mapping, data flow. I hope I think this screen is probably much more clearer than what I see there, but I hope all of you are able to see it. The transformation involves much more complex migration as I move to the next stage, but here it gives you the complete impact analysis, what should be taken care, what should be the detailed optimization, refactoring that needs to be done, etc., right? So it's well documented at this stage. Moving to the fourth stage where the heavy lifting happens, right? The entire store procedure business logic now needs to be converted into .NET files with the microservices-based architecture, service, endpoint contracts, well-defined, 3-level data security or privacy mapping to make sure the data privacy is maintained. We move into the fourth stage now to start the migration. Output of this migration is the entire source code that is required for the .NET-based architecture, right? The first stage of this will come up with a migration summary, migration report, which will define, we are talking about 14 files getting created here, right? And the initial stage you have the summary showing that we are at a particular stage of migration. Now we need to iterate this through multiple cycles, again, like an agentic approach to make sure the feedback from the testing, code review gets fed back into the system. And the iteration 1 report that you see here will show you that the accuracy of migration is about 60%, right? So we have not got it to 100% yet. Each stage needs some human intervention, some updates to take it from 60% to 100%, right? But it shows you clearly what is missing in this iteration, what are the security issues, what is the missing business logic, and it shows a partially complete status for the initial migration. We iterate it through LLM-based inputs, right? Again, we use a JEDGE LLM-based testing methodology so that we know what is wrong, go through iteration 2. Here you see that success is about 92%, with 90% of business logic, 88% of data mapping, and 85% of error handling completed. This is approximately where you get at best, and then more and more human intervention is required. The source code needs to be taken up by a developer to validate, fix some of the things that needs to be taken up from there. But this is how the source code comes out from the system. The platform delivers you a source code which is well structured and can be updated further for the last 10%, right? In our experience, it started from about 60%. We were able to about 90% of accuracy with the platform, and the last 10% is where further developer intervention happens. There is a testing and validation phase that iterates with the previous stage, right? You migrate, test and validate, and iterate that. As I said, 60% accuracy in the initial evaluation report, which gets remediated through the test cases that are generated. And let's look at some of the test scenarios, test cases that are generated by the system as well, right? It's a well comprehensive test suite that gets generated, which can be iterated through the multiple iterations. Maybe 1 to 3 iterations is what we typically do, and then human intervention takes it to the final 100% stage. So with this, the original Postgres store procedure based source code or the application has got migrated into new stage. And let's look at how it appears in the new stage. These are the two systems. They're very similar, but you see a much more modular approach on the right side, which is the migrated application. But the screen does not tell you the entire story. Behind the stage, you have a well-structured microservices-based architecture, which reduces the cost of operation, cost of change, speed with which you can implement new enhancements. All of that is built in with a record speed, right? And the migration is now much more less complex, and you don't miss out anything in this migration. To summarize, this delivers more than 50% faster time to market, right? We were able to do it much more faster than what will be otherwise done manually. Improved quality and efficiency, making sure 100% business function parity, improved performance for the new application, etc. As well as you can see less dependency on the source code from the legacy systems. The skill-wise, you don't have to depend on what was the old system. This automatically gets you to the new stage. So with that, I think we have come to an end here. But what you saw here is a very well-governed approach with an AI-led system. Therefore, developers can now contribute in between rather than deciding when to use AI, right? So AI drives the process and developers come in between to do a 50% faster migration from legacy system to a well-structured microservices-based target system. Thank you. Balaji, back to you.
Thank you all for a patient hearing. Thank you, Rajneesh, Rahul, and Ganga. And thank you very much. We need more elaborate discussions. Please visit us at booth number 107 and 108, and we'll be happy to elaborate and share more details with you. Thank you once again for a patient hearing. Thank you very much.
Thank you so much. May I request you all to kindly pose for the group photo. Our next session is Blueprints for the Digital Hospital. Chairing this session is Dr. Sandeep Wadhwa, Global Chief Medical Officer, Solventum Health Information Systems. Please put your hands together. With the chairperson we have, may I also invite the speakers, Professor Shakti Gupta. Please put your hands together. Dr. Bruce Murphy. And Dr. Eyal Simlikman. Kindly put your hands together, each bringing a real blueprint for the hospital of the future.
Good afternoon and greetings. I'm joining from Denver, Colorado. Dr. Sandeep Wadhwa, I'm the Global Chief Medical Officer for Solventum. Denver is exactly the opposite side of the world, 182 degrees longitude. So when you live in a mountain city like Denver, you're very aware of altitude. Today, I'm more aware of longitude. It's a great pleasure to introduce our speakers today. I'll make some opening remarks and then pass the mic. Now we get to hear from the hospitals themselves about their journey. So much of the past 2 days have been about technology. Now we get to hear how that's being applied. And for me, this is a very exciting time in healthcare. We're entering a phase of digitization and AI application that has the ability to transform this sector of the economy. And we've experienced these types of transformations before. Looking at the agricultural sector, we saw the change from beginning with almost all human labor to tools to machines, and now reaching a phase in agriculture where the work is human supervised, but very much relying on automation. And we see a similar process going on in our manufacturing sector with, again, similar use of hand tools, machining, and now a phase of supervision. And again, now we get to healthcare and looking at the possibilities of bringing healthcare into a similar phase where particularly those tasks that are administrative may be very much powered by automation with human supervision. But I think the landscape of technology in healthcare is littered with failed attempts where oftentimes there's this sense of, oh, I can bring my technology into healthcare and not leverage the human nature of the field, the clinical nature of the field. And this, I think, is exacerbated with error-prone AI. And we just heard about the AI is as good as the data we put into it. But really, I think we're now entering this phase where the AI is informed by clinicians, by healthcare experts. The tools are much more accessible for the user base. And so this concept of expert-guided AI, I think, is very powerful. And this notion, this concept I want to bring together of braiding together these two great powers, clinical content and expertise and advanced technology, and bringing them together. And this is our view of particularly some of the administrative population health quality work where we think there can be a transformation through digitization, through AI, along a continuum of care that recognizes the critical role of both of these professions. So let me turn it over to our first speaker. I think I think Professor Shakti, would you please come to the podium? Please join me in welcoming Professor Shakti. Thank you, Ji.
Good afternoon, everybody. So I'm representing All India Institute of Medical Sciences, Jammu. It is a new institute which has been established only 3.5 years back with about 43 towers spread over 227 acres of land. And it started its hospital operations only 18 months back. And just I want to share this IT transformation in AIMS Jammu. So that is a digital transformation at AIMS Jammu. So this is our campus, which is spread over in 2 areas. Our OPD started on 1st August 2024 with 34 departments, both specialty and super specialty departments. We have about 34 OPDs running daily. And we keep on getting the patient feedback. About 98% of the patient, they have rated satisfied to highly satisfied hospital services. Then there is, as far as digital transformation is concerned, we have actually seamless integration of healthcare ecosystem, which is the philosophy is digital health ecosystem, which is basically actually that you get all the information about the patient, their records, anywhere, anytime. Then we have the outcome-based care, which is usually focused that our patient should be satisfied after going through the processes. Then digital integration also actually. So we are actually one patient, one ID, and one record. We are focusing on that. And the real-time analytics. And then empowered. Ultimately, what we want to get from the hospital services is the empowered patient. So we actually divided our all digitization process. That is into 4 milestones. The first, second, and third milestone has already been completed. We are now actually in the 4 milestone actually, which includes application of artificial intelligence, health metrics, wearable devices, patient experiences, and predictive medicine. So this is in progress. Now actually we have, AIMS Jammu has got a Swasth app available, Google Play Store and iOS. Patient can book and reschedule the appointments through AIMS Jammu app. Then indoor patient navigation system, which is very unique in AIMS Jammu, first institute in the country which has got a indoor navigation system, which we have implemented in collaboration with IIT Delhi. It will function like a GPS for indoor patients with real precision. Then actually we have actually hospital management information system and AI system modules ready at AIMS Jammu, which are all functional. Then actually we have a patient-centric services at AIMS Jammu, which focus on different aspects of the digital transformation. Then we keep on doing through the dashboard that what are different OPDs, what are the top 10 OPDs which are there on day-to-day basis. Then actually what are the different inpatient areas where the patient we are getting, top 10 actually departmental prescription counts, how many departments are generating. State-wise OPD census is also available, and I am happy to share that we are getting the patient from 28 states in the country, though it is only 18 months old institute. Then actually this is lab tests which are done till date, which is also total automated. And then machines fully integrated with the HIMS in e-Sushrita at AIMS Jammu. Then actually we have already got the online patient feedback system. Ayushman Bharat digital mission has been implemented. Teleconsultation at AIMS, it's already been sorted. Then 100% implementation of e-office at AIMS Jammu. Then actually, when we talk of digital information, so these are the different components which has already been implemented, like the hospital management information system, then interaction, lab interaction. Okay. Then actually, as far as Ayushman Bharat, which is very important for us to implement, that has already been implemented over there. Actually, we get details how many patients are being treated under the National Ayushman Bharat digital mission. Then actually, these are the modern lecture theaters which are there, actually, most modern. Then we have got a very unique digital library. We have worked with the IIM Jammu, and we have the most modern digital library, both in IIM Jammu and AIMS Jammu. None of the institute in the country having that digital library. So you can have a look over the digital library which is there in AIM Jammu. And these are the children corner which has been specially created so that we motivate the staff and the faculty to bring their children above 3 years of age to bring them to the library and develop a habit of using libraries. So these are new arrival sections, these are discussion rooms, and these are library resources which are available at AIMS Jammu. And every faculty and student, they get a smart card and the password, and they can utilize the resources in the library sitting at home also actually. So we are very active on the social media. We have established a media center at AIMS Jammu, and we are active on Facebook, X, then Instagram, then Facebook, and WhatsApp groups are also there actually. Our main philosophy of this media center is that connecting healthcare to the communities actually. We have got the most modern, we have established an advanced center for the genomics and precision medicine, and it is working as a reference center in the country, getting samples not from the country, but also the neighboring countries also. We have also established the most modern dry smart lab, which is called a green lab, which is using a waterless technology, and it can process 1,000 samples in 1 hour. With 3 ml of blood, it can process about 800 parameters actually, and the reports are available within 1 hour actually. So these are the latest technology which we are incorporating, and the training sessions have also been conducted so that actually on a regular basis, and so that actually, and ultimately our target is that in a short span of 3 to 4 months, we want to make AIM Jammu a paperless hospital. So this is in short about the AIMS Jammu. Thank you so much. Thank you.
Thank you, Professor. Please join me in welcoming Dr. Bruce Murphy from nearby Arkansas to the podium. Thank you.
Thank you very much. I have been asked to introduce technology that I see as a vision for the ingredients of a hospital of the future. So this is one person's vision. And I would start off by saying that Western medicine has been founded on the macroscopic use of anatomy and physiology to effect diagnosis and effect cures. It's only been very recently that we have had the introduction of Newtonian physics and quantum mechanics to actually let us know what is happening on a cellular level to say an insulin receptor when it is in blue light versus an insulin receptor when it's in red light. And so we have been operating kind of in an imperfect, primitive way for many, many years. That same is true with our computing ability, and recently our machines have gotten so fast and so clever that we now have the integration and the overlap of these two great things, which is the better understanding of anatomy, physiology, and Newtonian physics and quantum mechanics, all overlapped with very fast machines. So I'd like to introduce a few of sayings and quotations from some really famous guys that seem to know what they were doing. Albert Einstein said, "The greatest illusion in the world is the illusion of separation." We're all together. We're not separated. We're all part of the same processes. We're all connected. Nikola Tesla. If you wish to understand the universe, think of energy, frequency, and vibration. What did he leave out? He left out matter. It's energy, frequency, vibration. And Leonardo da Vinci learned how to see. Everything is connected to everything else. So I think it doesn't take a lot of insight to say that all three of these gentlemen have said the same thing. There may be 500 years between them saying the same thing, but they're saying the same thing. We're all interconnected. And now we come along with some audacious quotation. And this quotation occurred on January 6th of this year. And Elon Musk said, in 3 years, his robot will be a better surgeon than any human on Earth at scale, with extreme precision. So what we're trying to do now, I think, is to integrate Western science and Eastern wisdom. So if we look at what are the ingredients to the hospital of the future, I'm going to talk very briefly about three different things. What the building might look like, what the contents of the hospital might be, and what the services might be that the hospital is going to deliver. Here is one artist's demonstration of what he thinks a hospital of the future might be. It's pretty short, 4 stories. It has ceiling to floor to ceiling windows. Every room has a window, and it emits and enters a lot of natural light. Here's another rendition of a hospital of the future that, again, is 3 stories, but the other thing is it's not very big. Remember, in the future, it's going to be a failure to put somebody in the hospital. So with these things inside our hospital, about 5 years ago, we opened a hospital that we thought was a hospital of the future in Little Rock, Arkansas, and it looks something like this. And it's small. It's only a 50-bed hospital. Again, is made in a way in which patients should be attracted to come, even though hopefully they're sick when they get there. We can make them better in a pleasant fashion, in which we actually want to delight them with, in a way in which many ways it would be something like going to a 5-star hotel, but at the same time we have lots of open spaces, we have lots of natural light, and we have a garden area on the floor that on the roof that actually delights the patients. So you can be very sick, but also in the middle of a garden. Now we've got to have all of the regular things that a normal hospital would have to have, which is technology, etc. But this might be the hospital of the future as well. Small, lots of natural light, and the contents of the hospital I'm going to go over right now, which I think we have an example that was published this last year in China, in which they have an agent hospital. This agent hospital has 14 AI doctors and 4 AI nurses that have since been expanded to 42 AI doctors and across 21 clinical departments. They've published the results of their first efficiencies. They won't show us what their AI doctors look like. This is only an artist demonstration of what they may look like. But basically, the AI doctors are taking care of the patients from triage to registration to examination to diagnosis to convalescence as an outpatient. They are treating along many lines of subspecialties, including endocrinology, gastroenterology, cardiology, dentistry, etc. The number of patients that they're seeing is enormous. In one of their examples, they saw 8,000 patients in 2 days, which would take the same number of human physicians about 2 years. They quoting their achievement of an accuracy rate of diagnosis at 93%, passing the U.S. medical examinations at 93%, and they are incredibly efficient. The benefits are pretty easy. The benefits are a huge relief to understaffed system, faster and more consistent diagnosis, and the rest of them are easy to see. The downsides, I think we all can see too, is where are the human beings? Where is the empathy? Where is that component that is required to get well? And certainly they'll be utilizing microscopic robots as well for releasing their robot, releasing a microscopic robot to attack the cause. So what are the services that you could see in a potential hospital of the future? The first question is, where did we fail? And we have a company, it's called 101 Plus, and we're looking at about 50 physical biomarkers and about 500 internal and blood biomarkers in which we want to be able to predict and we think, 2 to 3 decades ahead of actually the chronic disease occurring. And if we can do that, then the first thing we should do when somebody's admitted to the hospital is, where did we screw up? When should we have intervened? When should we have actually go back in time and learn from our mistake? Let's go back if you can. Here, maybe, yeah. So the other services that the hospital of the future, I think, will have to do with organ transplantation, stem cell expansion, and gene augmentation. I think all of that will happen inside small, nimble hospitals. So again, let's go to our audacious guy to quote. He says, everyone will have access to medical care that is better than the President of the United States receives right now. Well, sometimes I wonder about how good that is, but in any event, it is potentially there. He also said, he's asked, do we need to go to medical school? No, you don't. It's pointless, absolutely pointless. We've got an AI robot that can do that for you. And so I would tell you that if you look at what I really think may well happen, you have to understand the Yamanaka factors. Yamanaka is a Japanese scientist who won the Nobel Prize in 2008 for discovering that you could take a senescent cell and make it go back in time and reach its pluripotency. So it could go back in time, and now it could be redifferentiated into any cell. And here we see basically the differentiation of a cell that's a stem cell, a pluripotent stem cell, into ectoderm, mesoderm, and endoderm. And we've gotten this far, but we need to get just a little bit farther, and what the hospital of the future will very likely have is be able to take the person's senescent cell and make that cell now go down the pathway to develop your own set of a new pancreas, intestines, lungs. You need a set of new kidneys. We'll give you a set of new kidneys, but they're going to be your kidneys. They're not going to be kidneys that are going to be rejected. We don't have to worry about rejection because we've taken this pluripotent cell, put it on a scaffold, and made an organ out of it. And so I think that when we end up with a lot of hospitalizations that will be based on chronic disease that has ended up in organ failure, this will be one of the mechanisms in which the hospital of the future will evolve its service. Thank you very much.
Maybe there'll be a gene that can make my hair black again, Dr. Murphy. Let me thank you, Dr. Murphy. Let me invite Dr. Zimlichman to the stage and hear about his perspective on digitalization with an equity lens, please.
Thank you very much. Yesterday morning, I started the day speaking about our innovation program called ARC, coming out of Sheba Medical Center, the Global Innovation Program, with 9 sites around the world focusing on transforming healthcare. Today I want to focus a little bit more on Sheba and some of our programs around specifically how do we promote medicine without boundaries. How can we reach out anywhere around the world to provide the best care possible through the use of digital technology. So starting with a couple of words about Sheba Medical Center. Sheba is actually one large campus based in Israel with 7 hospitals, of course an acute care hospital, a children's hospital, a cancer hospital, a rehabilitation, and so on, but also a virtual hospital. One of our hospitals, which we just opened maybe 5 years ago, emerging out of the first wave of COVID, was a virtual hospital, a hospital that's intended to provide only virtual services. And that's part of what we'll be reviewing here today and explaining some of the services that the virtual hospital is providing. Within those 7 hospitals, a couple of numbers you see here without going through this, seeing about 2 million clinical visits a year, about 11,000 staff, 2,000 beds, which positions us by far as the largest hospital in Israel, largest in the Middle East, and one of the largest hospitals in the world. And again, we won't go through all these numbers, as you could see them here, including 11,000 babies delivered annually, which for the Western world is considered a lot. Also, not just the size of the hospital, but also the quality as being, of course, ranked by Newsweek as one of the top 10 hospitals in the world ever since Newsweek started the ranking about 7 years ago. On the last ranking, we came up number 8, as you see here, and also one of the top 10 smart hospitals in the world in terms of the digital infrastructure that exists at Sheba. Of course, I won't have time to review everything we're doing on the digital side, but again, a glimpse on, we'll focus on some of our telemedicine programs. Well, we know globally that healthcare is at a crisis point. We like to envision a brick wall. And I give this analogy quite a bit. You know, if we're on this train heading towards a brick wall and we're just sitting there, we know the brick wall is ahead of us. We know we're going to reach it. That brick wall could be financial sustainability. It could be workforce crisis, where we all lack doctors and nurses in most of the developed world. We know that there's a huge issue with quality and patient safety. Patient safety is a big topic for this weekend as well here. This is all our brick wall. We've not been able to make progress on providing more sustainable care financially, on providing care that is of high quality in patient safety. We've been struggling with this over the last couple of decades without really seeing substantial advancement. And this is that brick wall. And from our perspective, the ability to avert the brick wall is transformation. Transformation, in short, means we need to change the railway. We need to move away from where the train is heading if we're going to avert that brick wall ahead of us. And that is, of course, the challenge that all healthcare systems around the world are facing. When we work with our partners around the world, one thing is common everywhere. Public healthcare systems lose money, period. They cannot provide high level of services at a sustainable financial way. It's just almost impossible with the current methodologies of healthcare. And that's why we need to transform, and that's exactly what Sheba and ARC is all about. So with that in mind, we worked for about 3 years at Sheba, from 2017 to 2019, to develop a platform that will do exactly that. The platform is called ARC, intended for 2 goals. One is to have innovation drive large-scale transformation. Again, changing that railway to avert the brick wall that's ahead of us. Basically providing care in a different way. And you'll see some examples. And the second is having innovation serve as an economic engine of growth. And I spoke quite a bit about this yesterday morning and showed some numbers of the economic growth that ARC was able to provide for Sheba Medical Center, including revenues totaling up to about $100 million a year from revenues from innovation that are going back into healthcare, creating 3,500 jobs for the high-tech industry in the vicinity of Sheba Medical Center as, again, as evidence for that economic growth that we're able to establish. And through that, of course, the focus has been these 5 pillars, or what we call high-impact transformation tools, from improving decision-making process to redesigning professional disciplines, thinking about the doctors and nurses of the future, not in the way maybe that Elon Musk is thinking about those, but in a different way. How can AI agents help doctors and nurses do a much better job? I don't know what's going to happen 100 years down the road, but at least in the next century, this is what we're likely to be seeing. Then providing care without an address or with no barriers, where geography plays no challenge anymore, and we'll see some examples on that. Precision medicine, prediction, prevention, and patient empowerment. These are the frameworks that we've been focusing on our transformation. And a couple of examples in the short time I have. One has to do, or the first two have to do with what we call hybrid care. So we've developed over the last 6 years 2 programs that basically have taken the hospital to where it needs to be. And this is a hybrid model where most of the hospitalizations take care at home. We transition to a home environment that's actually a health environment through many, many different abilities. What you see here is our medicine hospital at home program, heavily dependent on technology, where the hospital takes charge of patients at home. And for that specific medicine unit, if that medicine unit has 36 beds, for example, some of those beds are physical metal beds in the hospital, just like we know from hospitals today. But the others are virtual beds at home. But the same staff from the hospital takes full responsibility over those virtual beds. So what we see is a hospital, basically the perfect example of how we've been caring for acute care patients for the last 200 years, now transitioning to a new model where it's a hybrid model where some of those patients actually need to be at the hospital, but most of those patients are taken care of at home. We published this work in one of the advanced journals called PLOS ONE that have shown actually reduction in mortality. Of course, the hardest outcome we can think of, the reduction in mortality compared to traditional hospitalizations for patients hospitalized in this model. Again, utilizing technology that allows us to take responsibility of our patients at home from the hospital. Another example where we use quite a bit of technology is high-risk pregnancy, where we have women who are pregnant at high risk. Typically today, as you know, they might spend weeks and weeks in the hospital until they give labor, but these are young women. They want to be at home. They sometimes, many times, have other children at home they need to care for. They are working. They want to continue to work, and they can do that from home, from their own environment. So we have utilized technology, including fetal monitoring at home, including ultrasound at home, including laboratory testing and so on, to allow us to care for those patients at home from the hospital. And we utilize advanced artificial intelligence to identify the risk of early delivery. And as long as that risk is below a certain threshold, we continue to care for those patients at home. Once the risk rises above the threshold, we bring them back to the hospital, and then we could bring them back home if the risk again drops. And in this hybrid fashion, again, we try to keep those patients out of the hospital as much as possible, but again, the clinicians in the hospital who are better suited to care for those patients, they continue to care for the patients even if they are home using this advanced technology. The third example, and last one I'll share with you this today, is in mental health specifically. We know mental health is a huge issue. Millions of undiagnosed and undertreated around the world, maybe billions even. It's a huge, huge pandemic in all of our countries. Of course, we wanted to see how can innovation transform care delivery for mental health disorders. And one of the clearest problems we have is to diagnose and to triage mental health conditions, so we can define who needs to see the human therapist today versus who can wait a couple of weeks, sometimes months, because that's what happens today. You know, there's obviously overwhelming need and not enough human treatment. So what we've devised is an avatar that we developed together with Microsoft, one of our partners. It's an AI, generative AI avatar, where you could choose what the avatar looks like. It could be a woman, a man, whatever you feel more comfortable with. You could choose the language, obviously, and you have a conversation with the avatar. And let me tell you, after about 5 minutes, you forget it's not human, because the conversation is completely human, as you could imagine. I don't know if the team here can actually click the video. There's a short video there on screen.
I'm Liv, your digital wellness ally. What brings you to us today?
Hi, I've been having some trouble sleeping at night. Even when I do fall asleep, I wake up pretty shortly afterwards, and I have a hard time getting back to sleep, causing me to be very tired in the morning.
I'm sorry to hear that you're having trouble with your sleep, Grace. It sounds like worries and thoughts are keeping you awake, which must be really hard. Can you share more about these worries?
Here. But that's an example. This conversation on average would take 20 to 30 minutes. And after that time frame, the AI would diagnose the mental health condition and the severity. So we can decide when that individual needs to see the human therapist. Again, can we wait a few weeks because, again, we don't have enough therapists, or it's an emergency, they need to see the therapist today. And that's a huge, huge impact, especially because of the huge shortage in workforce that we have in this area. And finally, Sheba and Sheba Global, specifically our global operations, provides different services, both on the technology side, but as well as education, healthcare services, comprehensive healthcare solutions, and of course, partnerships internationally. We're continuously on the lookout for partners around the world to roll out some of these technologies and work together to transform healthcare globally through ARC and through the Sheba Global Services. And we'll be very happy, of course, to elaborate and meet to promote those collaborations moving forward. Thank you very much.
Please join me in thanking again. We've heard from Jammu to Israel to Arkansas. We spanned half of the globe in the past hour, and now is the time for us to go take a refreshment and have our lunch. So join me again on thanking our panelists and wish them the best in their journeys home. Thank you.
Thank you so much. May I request to kindly stand for the photograph, please? Ladies and gentlemen, it is now time for lunch and networking at exhibition halls 4, 5, and 6. Enjoy your break and please return by 2:15 p.m. Further, we'll have exciting sessions. Thank you. See you then.
say you, please?
Yes, speaking.
Number is 6325289. He
here is with. Yeah.
Ladies and gentlemen, may I request the ones who are sitting at the back to kindly come in the forward, please. We'll start another 5 minutes. Thank you. Welcome back, ladies and gentlemen. Coming forward, we have 2 rapid-fire spotlight sessions now. I would like to call upon Mr. Arvind Raman from Microsoft. Kindly put your hands together as we address him on the stage.
Good afternoon, everyone. Thank you. Okay. Arvind Raman here, and I play a role of an AI specialist focusing on the healthcare domain at Microsoft. Over the next 5 to 8 minutes, I'm going to showcase and talk about some of the recent innovations in the healthcare space, particularly in the context of large language models and, of course, AI. As this is the first session after lunch, just want to kind of get a sense of how many of you are actually awake. So, great. So thanks for your enthusiasm. Super enthused by it. So a quick show of hands in terms of who all have heard about the term AGI, Artificial General Intelligence. Great. Good to see that. Artificial General Intelligence essentially refers to a phase wherein AI is as good as humans. The next question is, how many of you have heard of the term medical superintelligence? Okay, just a handful. So, medical superintelligence primarily is a framework of AI services, wherein these AI services have the ability to orchestrate a multidisciplinary team of AI agents to execute a particular task. Just like in a hospital, you have a senior physician who has a multidisciplinary team to kind of come together and execute a particular task. Superintelligence primarily refers to these set of technologies. And yes, we've had the initial set of medical superintelligence agents being deployed. 2 weeks back was I would say, landmark week from an AI perspective, wherein Anthropic, one of the leading AI players, spoke about its healthcare-specific LLM, which understood clinical protocols, which had credible knowledge, which was HIPAA compliant, could connect with your EMRs, and much more. With the first set of, I would say, clinical models, we are going to see a significant change in the way organizations go ahead and build these solutions. So let's put this to work and look at a particular scenario. Imagine a scenario wherein in a remote village, you have a person who has suddenly been comes to a local clinic and is diagnosed with multiple, I would say, symptoms and is extremely critical. What does a junior doctor do out there? I mean, he may specialize in one particular domain. He picks up his phone and says, hey, AI agent, I need a pulmonologist. I need a radiologist. I need a cardiac. I kind of summon multiple agents on his phone. He speaks to these bots in a language that he understands the best, possibly in his native language. And the tool then says, okay, these are the 4 doctors you need. These are the 4 specialties you need. Let me get them out. And suddenly you have a virtual team of 4 doctors who come in. And what they do, they discuss amongst themselves. They debate amongst themselves. They question each other's hypotheses. So you have one orchestrator who kind of coordinates all of this on a real-time basis so that you get an appropriate response in a matter of seconds. Yes, in a village with practically, I would say, very limited medical help, one has the ability to spawn together this virtual team of specialist doctors, debate, argue, go through the checklist, and finally make a call in which all of them agree. And these agents primarily have been trained on your data, on data specific to the land, which is credible. So this is the era of, I would say, medical superintelligence, and in the coming weeks, we will see a significant explosion of these agents, I would say, getting on into every device, into possibly every EMR and other applications. Microsoft is working with multiple, I would say, players like Epic, like Cerner, in terms of building in these specific intelligence within their applications. So let's go ahead and look at a particular scenario wherein I have a conversation with a particular agent regarding a particular diagnosis. Based on my limited knowledge, I have formed together a particular reasoning. However, the AI agent in this particular case debates internally and comes back with a response that goes against what I know. I trust these agents to a great extent and then go ahead and agree with their conclusion. So let's hear this dialogue between me and an agent in terms of the appropriate approach or intervention to be taken in a particular scenario.
I have this patient, Sham Thakur, in the emergency ward. His UHID number is 6325289. He has an acute shortness of breath and mild chest tightness. The initial assessment suggests a respiratory issue, and we've started bronchodilators and oxygen. Can you please look into the EMR details, run a risk score, and help me if there is anything else I should reconsider?
From the EMR and risk score, this might be a pulmonary embolism rather than a simple respiratory issue. I'd recommend a D-dimer and CT pulmonary angiogram. If confirmed, we'll reassess treatment based on bleeding risks. Let's confirm quickly.
Okay. We've done the blood work and the CT angiogram and can confirm a large bilateral pulmonary embolism. We are considering to proceed with systemic thrombolysis. Can you once again run the risk score and help us with the outcome?
Reassessing the risk, given his condition and recent history, systemic thrombolysis poses significant bleeding risk. A safer route would be catheter-directed thrombectomy. Let's prioritize that to reduce complication.
Could you hear that clearly? Okay. So to just sum it up, a patient comes in, has breathing issues, respiratory issues. The physician thinks it's asthma and tries to do the oxygen work. The AI looks into his EMR, looks into the intelligence, runs the risk scores and says, it's not just a simple asthma, it's pulmonary embolism. You need to take a particular, you need to do possibly a CT angiography. The doctor says, great, let me do that. Then a pulmonary embolism is confirmed. He decides to go ahead with a particular course of treatment. The AI agent again comes back and says, no, the risk scores are different and you need to go for another intervention. So in this case, I have a tool, an assistant that has the ability to look into my EMR systems, to look into the different medical protocols, run the risk scores, and then come back with a particular, I would say, intervention. So that was a quick snapshot of what it is. Moving ahead from a Microsoft perspective, we have started building in these specific advancements as a part of our portfolio of services. And this is what we call as the Microsoft Healthcare suite of agents, wherein you have an agent that could be deployed anywhere. It could be deployed on your phone, it could be interconnected with your EMR systems, it could be accessed via a WhatsApp chat, or it could be on your Ask Apollo website or any other application. It is compliant with all the possible clinical protocols. It has well-defined templates, well-defined guardrails, and adheres to the data residency and other protocols that one needs to adhere to. Not just this, we are never saying AI is going to be intelligent or smart enough than humans. And in this particular case, if the agent has the slightest doubt that it may not be sure of an answer, if the confidence score is less than a particular threshold, it would then kind of hand it back to a human who would take it. The point is, while agents have this intelligence, we are never letting them do or respond by themselves. They are always, I would say, there is a human always in the loop who looks into these responses and then goes ahead and does the appropriate course of treatment. So to sum it up, medical intelligence, super intelligence, I would say, is very much here, and the way doctors, physicians, payers, providers, and the larger ecosystem would work, would treat patients is never going to be the same. Thank you for your time.
Thank you so much, Mr. Arvind, for that wonderful insights. May I call upon Mr. Johan Anel, Strategic Partnership Leader from Sleep Cycle. Please put your hands together.
Yeah. Thank you. Amazing to be here. So, I just arrived and long flight, but I'd like to ask you, let's see, do we get the, well, we get my slides on, well, say more. We can start with what I'm going to talk about is sleep. I think we already made clear from our previous speaker that you are awake. But how did you sleep last night? Were you coughing? Were you talking in your sleep? Were you fighting with your partner? Was your partner just having very vivid dreams and imagining that you were snoring like a broken auto rickshaw stuck in traffic? Is that just a dream? Well, were you having potentially dangerous breathing interruptions during your sleep? If you're one of our over 3 million users who are leading up, you know based on sound from the cell phone a lot about your own sleep, how your sleep is developing over time, how your key markers are, what your different sleep stages. You can start to improve your lifestyle given this input from the very simple but powerful sensor that is a microphone. So we're a Swedish listed company. We have worked 15 years, since 2009, on this technology. And we processed over 3 billion nights of sleep, but it's far from enough. There's so much more to do in scaling up and making this core technology and this data available. So that's what we have decided to focus on, to make the insights you can get from sleep and respiratory analysis on any cell phone available for researchers, for public health, and for strategic partners. So what you see here is how we, based on anonymized user data, processed with privacy-preserving machine learning algorithms only on device, we can get some very powerful aggregated insights. This is a live demo, Cough Radar. You can also see it on our website, where you're down to really granular level for many major cities can track where are people coughing more than normal. So that's pretty interesting to know this one data point. There is just one of the many we see and get as we every night process millions of hours of sleep. During the pandemic, researchers were able to, with this kind of data set, predict about a week in advance when you were going to have a peak in hospitalizations due to COVID. It's one of many things you can do real time to make systems adapt to what's actually going on at the population level. We now also have research partnerships with Oxford, Cambridge, NTU in Singapore, many leading researchers using this to understand health trends in the population, the impact of pollution, and all else you can get when you see what are those key sound events that we can read from smartphones in the apps. This is obviously not easy to do. It's taken us 15 years and investing into this technology, training on all those nights to be able to reliably and accurately detect near the level of what the leading variables can do, how is actually your sleep and what's going on in it. So that's our core technology, advanced sound processing and advanced machine learning that is done on device and then can give aggregated insights and be applied for real-time applications. That's the core behind our leading consumer app. So we've started to partner with companies like Samsung, Ultrahuman, leading makers of devices for the bedroom, to make this technology much more impactful, going beyond those 3 billion nights to something much larger and much closer connected and actionable on health. So this is what we're now doing, letting our partners integrate our technology into their own hardware, their software, build services and innovate on top of this rich data set. The next thing where we see the big potential, as I mentioned with breathing, it's really key and something where most people don't know if they do have a problem. Globally, somewhere up to 1 billion people who have some degree of severity in sleep apnea, stopping to breathe frequently during the night. And really in most markets, the awareness is really low and treatment is even lower. It's quite some barrier to, if you even know that maybe it's an issue, go and do a full sleep study, possibly sleep with a CPAP machine. So a market that it's really underdiagnosed, but so closely related to cardiovascular problems, metabolic problems, cognitive decline, many really bad long-time effects. So every patient we can get screened a bit earlier, it's a huge value to the patient and to society. This is the breakthrough that we have made with clinical grade accuracy that we have in our algorithms, where we are now launching validation study with aim to get software as a medical device certification, initially in the US this year, and then rolling this out with actual medical grade screening for sleep apnea, with no variables, no hardware, no hassle, really just in our app or in a partner app, at the push of a button, the user is able to conveniently in their own home get the screening and start to take action against a serious health problem. So, in the morning, it was inspiring to hear the focus on prevention and health coming together, with every hospitalization being a failure of medicines, very quotable. For us, it's a really clear vision. As a technology provider, very experienced in the field of sleep, we can do so much more in partnerships with other leading players. So that's how we see the market, with more players specializing into technologies, many companies entering sleep in different ways, users having different preferences, and we are scaling up our impact by collaborating on the technology, giving much wider access to our selected partners on the data, both for research purposes and for being able to real-time make conclusions and adapt based on the kind of data we get when understanding sleep globally all across the world, and then getting into the screening to really be able to tell the users this is something you need to and can do something about with your health. So all of this in together, building engagement and understanding of sleep, that's a very worthy mission, something we're happy to engage with you in this room on. So feel free to reach out, and hope you have a great continued day today and a good sleep tonight. Thank you.
Thank you so much, Mr. Anil, for that lovely quote at the end. May I request the guests who are standing behind or who are sitting, kindly occupy the vacant seats, please. Thank you. The next session is about emerging technologies shaping tomorrow's healthcare, which will be chaired by Dr. Srinivasa Raju, Apollo Radiology International. May I call upon Dr. Srinivasa Raju on the stage, please? Please put your hands together. And Mr. Manpreet Singh, CEO, Apollo Health Access. Joining them, we have eminent speakers, Professor P.J. Narayanan. Please put your hands together while we welcome him on the stage. Professor Spyridon Bakas, Dr. Anirban Bhattacharya, and also it is my pleasure to call upon Padma Bhushan G.P. Talwar, a legend, teacher, and a mentor for generations, as he will approach 100 this coming 2nd October. Please put your hands together. And lastly, I would like to call upon Ms. Swati Kulkarni. Please put your hands together for the eminent speakers on the stage, please.
Good afternoon, everyone. Following up on after a session on sleep is always going to be hard, but we got a very interesting and substantive session coming up. This session is titled Emerging Technologies Shaping Tomorrow's Healthcare. We've got some really eminent experts that will be speaking in this session. And this session essentially brings together people who look at healthcare technology from different vantage points. The history and evolution of technology, the computation and development of algorithms, the clinical application, the regulation, and everything else that happened since AI has evolved. The first part of this session will focus on the evolution of technology itself. And few people are better placed to reflect on how computer vision has evolved than Professor Narayanan. He's seen multiple waves of enthusiasm and resurgence in application of healthcare technology. This talk will give us a historical context, which is essential if you want to understand whether today's AI moment is truly different. I now invite Professor Narayanan to deliver his talk. Thank you.
Good afternoon, and thank you. I thank the organizers for inviting me here. I'm really the joker in the pack, a mere computer scientist sitting among all these medical professionals who do real serious stuff. And the topic also is very broad, so I just give a very few, some comments on some observations on where computer vision and how computer vision differs from human vision or similar to human vision. So these are things that all of us know even from high school. Even you don't have to be big medical professionals to know how human vision works. You have a lens, you have an ocula, you have the retina from which the signals travel to the brain, the visual cortex at the back of your brain, and there are several regions that have been identified, named V1, V2, V3, V4, etc. In the end, it branches off into the dorsal and ventral pathways, and to understand what is in the scene and where it is, motion, these are all handled by the visual understanding scene. And if you look at our brain, 50% of the brain area, I'm told, is devoted to visual understanding, and probably 66% of the electrical energy. So it's very important to us, vision. And brain itself is, though it's only 2% of our body weight, it typically consumes 20% of the body energy and 25% of the glucose utilization. So brain is a hard-working organ, and of which computer vision or the visual cortex, visual pathways play a big role. Now coming to computer vision, it starts with a digital image today, which is, that picture doesn't look very different from the picture of an eye. In fact, this is also modeled after the eye as a pinhole camera. You have a lens, maybe a very complex lens system, and there is a detector. In early days, we are all used to films. Now there are CCD or some electronic way of sensing what is falling at the back of the camera, and that's the image. And typically there is some processing happening right on the camera. You're not getting the light that falls directly. There is some processing happening, which is sometimes good. It's very good because on our mobile phones, today's advanced mobile phones, it's difficult to take a bad picture because they do the processing and make sure picture is reasonably good. But there are applications where you don't want it to do any processing. You want to get the raw data so that you can do all the processing on top of it. And then actual processing happens outside of this camera in a computer vision system or a machine learning system. Typically today, everything is machine learning, everything is AI and deep learning. So the image that you get from a camera either is coming live from a video camera or a camera that you're processing after the image is captured. The processing system, which is a machine learning based software, and depending on what you want, you get different outputs. You train the system differently. So the human vision system has evolved for our survival. It's an evolved system. It's purpose-built so that we live well, or animals live well in their environment. Okay? And things are processed then and there. You don't store anything really. You may have memories, but you don't store anything. Whereas the computer vision system stores the image and processes it later. And it's an engineered system. You explicitly engineer how the processing happens. And processing happens on later and stored images. And the machine learning system, this is what everybody talks about today, AI and machine learning system. That's at the core of whatever you do with the computer. A machine learning system has basically two components. You represent what you see. You see images. The computer sees these images as just RGB values, red, green, blue values, typically between 0 and 255 or 0 and 1. These are just numbers. These numbers don't mean anything. I mean, these may be colors, it may be some other numbers from your spreadsheet. How does the computer process it? So you have to look at not just individual colors of individual pixels, but maybe groups of things together. Look at where there are edges, there are lines in the image, there are corners, there are some interesting patterns. These have to be discovered algorithmically. And first step usually in any AI system, including computer vision system, is to represent the input as in terms of what we call features. Features mean what are the most important aspects that are relevant for the later processing. Okay, you extract these features and then you replace this image or this X-ray or this optical image with this feature vector. Once the feature vector is formed, you forget, you don't even have to use the original image, you forget about it. You don't have access to it. Next step is, on this feature vector, you do a classification or a reasoning step, which gives you the answer. And this is the core machine learning step where which really involves fitting a function from whatever the feature vector to whatever output you want. Okay? And there are multiple forms. Today, the neural network form is extremely popular. And over the years, in the early years, computer vision, like all AI, thought you could just look at the image, go and ask a few radiologists or other doctors or people who process images manually, ask them, how do they do it? They will say, I see this kind of a corner, this kind of pattern, I think of something. And now you try to code it explicitly by hand using a program like a flowchart that is shown there. So you use some simple rules, you use representation which are simple. And so these are both the representation and the rules are kind of evolved or created by humans, okay, from experts. Then this didn't go too far in history. You cannot do too many things with this. So over the years, they learned what is called statistical machine learning, where again the representation is very similar. You represent using edges, corners, or some texture, frequencies, etc. But the second part, the reasoning will be done, it will be learned. There will be a machine learning system whose parameters are learned from large number of examples of input versus the correct output, and input versus wrong output. You give hundreds of examples or thousands of examples, and the system learns how to map the input feature vector to the output automatically using that machine learning model. Even this was not good enough. In the latest, for the last 10 to 15 years, what is called deep learning, where the network does everything. You don't do explicitly, you don't say corners are important or regions are important. Let the system figure it out by itself. You give the whole image to the left side of the network or input side of the network, and the output side of the network you say what you want it to give, and then train it. So this involves huge amount of training, what is called training, which is fitting the function, and requires huge amount of data, huge amount of compute. And that's where we are today. And in a modern deep learning system, deep neural network, DNN stands for that, is a network of this kind of, there are 80, 20 or 100 layers, and data processed from the left side is the input, output is on the right side, it goes from left to right, and then when you present one data item, it predicts some output, and you know what the correct output is. If the correct output doesn't match the predicted output, there is an error, and there is a way, there is a nice algorithm to send the error back in the network, adjust those weights, adjust the parameters at each level so that next time it will be slightly closer. And you do this again and again and again, and that's how you train this system. This is called training. So you can think of this as, in my old scale, initial layers do the feature extraction, and the last few layers do the classification. But training the system using labeled data. Now this is very important. You need thousands or even more labeled data. You need input and the correct output. So you can imagine this is a tedious task to get labeled data. If you are using medical image processing, you need, say, X-rays and the right output label, which is either regions or the diagnosis corresponding to that, and so on. So this is a difficult task. And even in computer vision, what happened is when we were all students, we were working on 10 images that everybody had, and we used to say that it works on those. And then as technology got better, people said, that's not enough, let's have some standards. And then in 2009, they created this huge data set called ImageNet. They use 1,000 classes of objects like cars, automobiles, plane, ship, etc. And each class will have 1,000 images. This is the set on which you train the system, and then you need to give a new image. It'll say if this has a car, it has a plane, it has a person, and so on. So this happened in 2009, and then the field really took off after that because people worked for that. As you see over the years, the error rate, what the bars you see are the error rate, that is not the accuracy, the reverse of it. The error rate came down very fast. And this also today, it's considered is better than human. Some of these functions, the computer does better than human. I think I'm running out of time. I had a couple of videos just to show what computer vision can do. I don't know if it works. This is just simply labeling. I mean, looking at the image, so many objects, it's able to automatically label what is there. It's a car or a pedestrian or an auto rickshaw or whatever. And this is happening live. So this is one of the steps that you can do with image, with computer vision. And on the right, you see another kind of application of computer vision, which is 3D modeling. Given a few images of that pyramid, it creates a 3D model that you can play with in a computer game. And this is another application. I mean, there are many other applications for it. I think let's go forward. I mean, now I just want to conclude. Should computer vision imitate human vision? This is a question we always ask. Yes, human vision is the best system that we have today, at least for our reference. And computer vision, many tasks are to imitate that. But there is no need, there is no reason computer vision can't go beyond. When, for instance, this 3D reconstruction that you saw, that is not something natural for us. Whereas computers can do it and it will be a useful step, why not do it? So the human vision system is an inspiration, but that need not be a limitation. Okay? So computers solve problems well. That is the motto of computer vision. And you can imagine any number of, your radiology. I mean, computer vision advanced so much that computer vision people or AI people started saying all radiologists are at risk. You will not have job in 5 years, 3 years. Nothing of the sort has happened. But I think computer vision can play as a major helper to the radiologists so that they don't miss things, so that their productivity increases, the speed at which they can diagnose or treat patients increases. So there is a lot of scope ahead, big challenge ahead for the future. Thank you very much for this opportunity again. Thank you.
Thank you, Professor Narayanan, for that excellent narrative of the evolution of computer vision. Now we're going to move from vision to algorithm. The next talk is going to be by Professor Bacchus, and the topic is advanced computational algorithms in medical imaging.
Good afternoon. My name is Spiros Bacchus, Associate Professor at Indiana University. I'm a formerly computer science by training. It's been very nice to see where I'm coming from, which is necessarily what Professor Narayanan just presented, trained on computer vision. I would like to thank Apollo Hospitals, in particular Dr. Sujoy Kar, for inviting me to talk here and present our work on moving from research to the clinic. So as a computer scientist, I've dedicated my career towards addressing clinical requirements. So I'm dually employed between Indiana University Health System and Indiana University, their actual university. In the health system, I've been working towards clinical service and operations on digitizing the Department of Pathology and Lab Medicine towards moving from glass slides to digital images. Whereas at this point, we're moving towards pushing all these images to the university side to facilitate research and education, where my research group develops AI biomarkers, or what currently is being called AI biomarkers, and also federated learning infrastructure, towards then putting these together and pushing them back to the health system towards translation and really reaching the patients. One might say that AI typically happens in this space. Well, what I see in my day job, I see AI everywhere there generating data. I see AI in the governance generation and de-identification of images, moving them from the health system to the university, but also in the optimization towards executing these AI models on less exotic equipment that exists in the health system when compared to the university side. So what is the ideal healthcare AI project lifecycle for us? It starts from a clinical need and concludes to improved care, with multiple steps in between. I would like to split them into 3 different categories. Number 1, starting with a model training and completing in technical validation, what colloquially we'll be talking about publishing a scientific manuscript. Then moving on to the clinical deployment on a single site, And then at the end, pushing towards the widespread deployment across multiple sites. Of course, every single step of these, they have different considerations. I'm going to spare the details here in favor of time. As you notice, AI is only mentioned in the model training stage. However, AI is really taking place in multiple steps of this process, everywhere from data collection all the way to continuous monitoring. So for the rest of this presentation, I'm going to focus on brain cancer in particular. And I'm going to start by just touching upon where is operational AI happening following a clinical cancer case. So a patient has been coming to the emergency room with some symptoms for brain cancer and has been referred to having a radiology scan. At this point, operational AI has been kicking in, all the way from image reconstruction to noise reduction, all the way to report generation, depending which hospital you're working for. And all this happens at the back scene, so without really you realizing that this takes place. At this point, the moment that they realize there is a tumor, then the patient has been referred to having a biopsy. Again, operational AI kicks in for patient scheduling, so on and so forth, for pathology and assessing the images of pathological, and this kind of defines only the space of diagnosis. From that, we're having the treatment space, all the way from planning to surgery to assigning to clinical trials, and at the end, even the monitoring. So you can see here multiple stages of operational AI that takes place throughout a clinical cancer case without us really completely involuntary. Of course, all these, the main idea is that we want to push and generate more AI algorithms towards prospective clinical studies. And to facilitate that, my group, in collaboration with Intel Labs, back a few years ago, kind of introduced federated learning in healthcare. And we established a senior international federated learning consortium involving 71 sites around 6 continents, the largest real-world federation in medicine that we know of to date. The first use case and the current use case has been on defining brain tumor boundaries in radiology scans, preoperative and postoperative scans. The database that we've generated is data from more than 12,000 cases. And all of these, while the data are always retained within each particular acquiring hospital. So for the rest, I'm going to just touch base and focus only in 2 specific ongoing prospective clinical studies, one focusing on prognostic AI and the other one on diagnostic AI, one in radiology and other in pathology that have shown high value demonstrated in big data. So for prognostic AI, I'm going to be talking about a prospective clinical trial where we started with a question, can we predict where the tumor will recur in scans acquired even before the first surgery? And at that point, when I reached to our neurosurgeon and I asked this question, he said, this is science fiction. You're a computer scientist. I can clearly see that. There is no need for you to progress on that. Well, ever since we've seen tremendous progress. Thankfully, it's not considered a science fiction anymore. We actually have a clinical trial that we've seen almost 2-fold increase in survival of patients. Here I have 2 example patients. We see their preoperative scans. We see heat maps of our predictions with red, the high area of where their tumor will recur. And here are 9 months and 7 months later, respectively, their scans indicating the tumor did recur exactly in the location that we predicted. So we applied that in an escalated radiation dose at a clinical trial at Penn a few years ago while I was still at Penn. And we saw about a 2-fold increase in median overall survival. Here is another example. Currently, we have an ongoing clinical trial that moving beyond the escalated radiation dose to really targeting neurosurgery, where our heat maps guide the neurosurgeons of what part of the brain they will excise. We're moving towards getting this from a single site to a multi-centric trial. So from that, I'm moving to a diagnostic AI. Currently, gliomas, adult diffuse gliomas, for their conclusive diagnosis, they require both histopathologic assessment and molecular profiling. Molecular profiling, most of you here know that takes time, takes weeks, but also expensive. And it's not possible to happen in every setting, always, particularly in community settings. So our senior analyst, Subha Minani, dedicated a year of his life on really developing a method that, given a histopathological slide, he can obviate the need for molecular profiling and still providing the same quality of conclusive diagnosis. I'm going to spare you the methodological details here in favor of time again. He trained the model on a diverse population from the US and Europe, but he validated it on independent holdout sets from an Austrian population and an Indian population cohort. The performance here was consistently over 96%, irrespective of which population we evaluated that on. So the current infrastructure, that's a short demo of how the tool works. You really input an image, you run the method, the model runs in the background, shows some more information for potential debugging, for potential showing how the algorithm works in case there is some sanity checks that you need to do. And at the end, it projects, again, the same histopathology image that you added as an input, together with a conclusive diagnosis. So some take-home messages here. AI is involved in more areas than we think it is, as former speakers also presented yesterday and today. AI makes healthcare jobs more efficient by producing faster, quantitative, and reproducible measurements, but also meets the growing demand and workforce challenges that we face in the health systems. Also, and importantly, brings experts, healthcare from large academic medical centers in settings where expertise does not exist. For clinically relevant AI biomarkers, we really need to set our priorities. That, in our opinion, is to set transparent, patient, or service-focused goals, have large training data to train our methods, but most importantly, have diverse testing data to assess the generalizability. On that note, success really requires multiple levels, involvement of administrative, clinical, and information security expertise. With that, I would like to thank our funders that put food on the table, my research team, and you for your attention. Thank you.
Thank you, Professor Bacchus, for that. I'm particularly interested in prediction of recurrence of glioblastoma on the preoperative scans. I think that will have a huge impact on management. I'll now pass on to my co-chair, Manpreet, who will take us through the rest of the session. Thank you.
So I think we are taking a shift from computer vision and the complex algorithms which go with it and provide all the productivity and the decision-making support that we get for clinicians. I think we'll take a slight shift now with Dr. Anirban Bhattacharya. Building capacity in a constrained and regulated environment.
Thank you, everyone. Thank you to the THIT and Health Dialogue for having me. I'm going to talk a little bit about the humans and how to build capacity of humans, particularly to the context of India. I'm from Mayo Clinic in Jacksonville, Florida. We do something called the Datathon there in collaboration with MIT. I've been to quite a few of them. So what's the situation currently in India? I think we have a lot of data. If you look at the population, the disease burden, the quantity of data is not the problem. It's really the ability for us to query that data and get insights from that data. Yet, it's quite a paradox that UPI has been able to make digital inroads into India. So if UPI did it, why can't we do it from the health perspective, right? So the traditional way where you had a clinician who would ask a question, that question would then get funded, that would allow us to get data. That data was then queried by a statistician. The findings were conveyed. And maybe once you achieve enough consensus from multiple studies, you would go back and change the evidence base, right? The speed at which this was achieved, this cannot be done anymore. And I think that has to change. And that's why we call this deconstructing the ivory tower. I think from evidence-based practice, I think we have to go to practice-based evidence, where we collectively take all the practice that we are doing and find out what's the evidence behind it. I think we have heard this quite a bit, right? AI is your friend, but it can also be your enemy. It's just like a mirror. If we stand in front of the mirror, and depending on what we show the AI algorithm, we are going to see the outputs similar to the quality of data we show. And there are some examples of it, right? Pulse oximetry that was published a while ago shows inaccuracies in people with darker pigments. Obviously, cardiovascular risk scores. Even for the MIMIC database that exists out of Beth Israel Deaconess Medical Center in US, that really represents a single center in US, and those findings may not be able to be extrapolated. Even for India, you have different kind of gaps in the data because of either caste, socioeconomic status, all of that. So I think if we are going to build an AI system for tomorrow or build capacity for tomorrow, that capacity has to address all these issues. Otherwise, any system that is already showing some problems, it will only be magnified with AI. So we want to introduce this concept called village of mentors. So think of people who come from different backgrounds, not just demographically, but in the way they ask questions, right? You want to have different areas of uncertainty in the human's brain so that they debate and they come at a consensus in a healthy way. So think of the doctors, data scientists, as well as systems thinking engineers and all of that who actually are able to bridge this gap. We're going to do a datathon in Mayo Clinic in April, and we also are working on including patients in that discussion. So what does it take to operationalize a datathon? Not much. I think traditionally institutions have been investing a lot in the computing hardware, but all this can be done over a cloud, and you can augment the cloud capacity just for the datathon itself, so OpEx over CapEx, right? Think of even task shifting as we are working on solutions for tomorrow. In a resource-abundant country like the US, AI may mean something very different, precision medical care. But in India, that has to be something different. If you get 10,000 X-rays an hour, how do I get AI to solve the problem of that number and only pass on the X-rays that matter the most to the clinician or the radiologist? The paradigm's a little different. Luckily, we live in an age where the government has understood some of these challenges. We have the Digital DPDPA 2023 Data Protection Act. Think of it as the guardrails, From this, the institutions can no longer say we cannot share data, but actually this provides guidance. The institutions rather become fiduciaries where they're able to give us the data in the way we need. If the DPDPA is the guardrail, there's also the Bureau of Indian Standards that tells us how we anonymize data for the Indian context. And then Ayushman Bharat, that lays the foundation. Think of it as the highway that follows in between these guardrails. You have a Abha ID as well as different entities in the health system that can act on each other. So this is the health AI stack. I've been thinking about this. This is the health AI stack that should work in a country like India. At the very bottom, you have the regulations that help you build trust. On top of it, you have the infrastructure layer. So things like Ayushman Bharat Digital Mission, even UPI, if payments are a part of it, right? On top of it, you have the data layer, how you anonymize the data. If data is scarce in a certain pathology, you can have ways to build synthetic data. At the very top layer is where all the excitement happens, which is the innovation, the village of mentors, the datathon, the training in a longitudinal fashion, right? What's the difference between a datathon and a hackathon? I get asked this question quite a bit. I think a hackathon, we've all been to it, really is building a product or an app. Whereas in datathon, it's really about the journey. It's about developing knowledge, developing understanding more about the process. So this is what it should look like. On the back end, we prepare the data using the infrastructure or the health stack that we talked about. And then obviously you have the teams, the village of mentors, and then they go into this exploratory data analysis, and they're able to then present some of the initial findings. Does it work? I think even from an Indian context, if you look at the MIT Health Datathon that happened over COVID,
that showed that distance or isolation is not a problem. Even Apollo, in this very conference, we have the solvathon that's going on, right? And then there's one hidden thing, it kind of breaks through all hierarchies. Our titles are left outside the door, and we work as a team to come up with solutions. So really coming to an end, what do we really want as an output, right? I think it is for us to understand how the data is collected as we are becoming consumers of that data. I think all of us will become consumers of AI, consumers of data, right? How is the data generated? It's really understanding the ecosystem about it, right? It's also creating evidence as you are, diving hands-on into this to learn. You're also creating evidence. We're increasing our fluency between the different disciplines that we interact with every day. And then obviously, at some point, we have to start thinking of implementation and long-term product life cycle. So with that, I think the key things I would say is bridge the gap, democratize the data, and then come up with a village of mentors. Thank you so much.
Thank you, Dr. Nirvan Bhattacharya. I think some of the other words that stuck to me were scarcity to strategy, OPEX over CAPEX, constraints as catalysts, and especially when anybody thinks about regulation, when anybody thinks about governance, they think of them as constraints, but thinking of them as catalysts, the health AI stack, and output not just being a product or an app, but really actionable knowledge. With that, it is my honor and privilege. The next session is building capacity, end-to-end mission-oriented research, technology deployed over 7 decades, a personal story, Padma Bhushan, GP Talwar, immunologist, India. So he's only 99 and would like to stand.
Well, first of all, I'm thankful to the organizers for inviting me to a meeting of this type, which I'm attending for the first time. Thank you. Well, realizing that it's more an industry people that I'm going to meet, let me tell you that like many scientists, when I joined the All India Institute of Medical Sciences in its founding year, there was nothing to do till 1965. And then you see one had the usual basic research on mechanism of action of growth, promoting and developmental hormones. Then in 1970, Dr. Howard Goodman, along with Elvin Cabot and Barry Bloom, met me and asked me to take up the headship of a WHO Research and Training Center in Immunology for India and entire Southeast Asia. This was the first time they were trying to establish this sort of institute and conference and research related. Obviously, I wasn't working in the area and I was very reluctant, but they informed me that India has the world's largest number of lepers. This ashamed me so much that I had no hesitation in signing the papers that he had brought. So that is how my attention came to a disease which I had never known what it is. So the first 2 years I spent along with 2 of my students in a leprosarium in Askain Pogri in Odisha, to learn what leprosy is. I knew nothing about it. After having known it, then the question was, can we do something for it? What could we do? Why India should have leprosy at all? I mean, you know, with all that sort of problems, I've thought of picking up leprosy as a sort of target to see whether we can prevent Indians to become victims of this disease. So question was to make a vaccine. And, well, I looked into all the available non-virulent mycobacteria in international stores and custodies. There were about 15 of them. And I asked for the strains to be given to me. I received about 15 such strains. And then working on various aspects, eventually I picked up a non-virulent mycobacteria which had no properties, known properties. So then we studied its entire properties and then thought that maybe this is the one which could serve the purpose we were after. So this is the mycobacteria, how it looks. It's a rather impressive mycobacteria, and you will see how wonderful it is. Next slide. Now, it of course could be only given in addition to the drugs which people were using for treatment of leprosy. So we did that. I mean, its trials in leprosy patients were along with the drugs that they usually received. But you know, to my surprise, and to everybody's surprise, the patients healed quicker than they did with the drugs. And what is again still more impressive is that after they were treated and became all right, please go to the previous slide. You know, there were no blemishes of the type that we usually see in leprosy patients. No drug known for the present can achieve this sort of an end. You see each patient, after he's treated, he looks like a normal human being. None of those ugly blemishes and deformations which leprosy patients have. So this was a totally unexpected property of this mycobacteria, and that is, I think, one of its many good properties. Next slide. I mean, of course, we did everything else. Ultimately, after it had been successful in all trials, it was approved by the Drug Controller of India and also by the US FDA. By the way, this is the only vaccine for leprosy approved in the whole world, and it just comes from India. And then in order to reach the people, it had to be given to a company. So the owners of Cadila came to me to say, why not give to us? Of course, I had no one else, and I gave to them. Eventually, I must tell you that though they make this vaccine, but they are following the agreement to charge a limited sum of money for the drug. But you see, they use it for many other purposes, and they sell it at much higher prices for those purposes. That is why the availability of the vaccine from Cadila is not very healthy. And I would plead with the industrialists that if anybody gets interested in it, please take it up because of its numerous good properties, and you will not regret it at all. So you are invited to be another company to make this vaccine. Next slide. Now, another totally unforeseen property of it was seen when I was approached that they have a category of tuberculosis patients, patients who are category 2, difficult to treat with drugs. So they said, well, can we use your vaccine? I had no objection. By the way, at that time it was MW used with it wasn't given any name. And so this vaccine given to such patients along cured much better than all the drugs that they had could do. So not only the percentage was higher, but next slide would say that even the relapse rate, next slide please, next slide, the relapse time for tuberculosis treated with the usual drugs was much higher, nearly 50% of patients get back to tuberculosis of this category. On the other hand, those which receive the same treatment along with this drug in this vaccine had hardly any, which became victims of relapse, and their, they came back in much more limited period to again being useful for the drugs. Next slide, please. So therefore, see, two major diseases of the country. India has had the largest number of lepers, but still it has whatever are remaining are still the largest number in the world. But in addition to that, tuberculosis, which is a widespread disease, well, this could also be very useful for treatment of tuberculosis, even the ordinary tuberculosis, why only category 2. Next slide. Now, no, please, this slide I haven't read. Please go back to the previous slide. What is amazing is that this vaccine made for leprosy and also active for tuberculosis also heals ugly anogenital warts. At Ames, you see one of my colleagues, surgeon, he had very ugly patients suffering from anogenital warts, and it was very difficult to treat them. So he asked, can I use your vaccine? I said, okay. Next slide will show you. See how the anogenital warts ugly get healed with this vaccine, which is, how could one imagine that it will even work here? Next slide. See, this is again his many patients, and he had no drug which could act in this case. Next slide. Completely normal foot from a very ugly foot that he had earlier. Next slide. So to sum up then, I would say that it's a marvelous vaccine. It is active on all cultivable mycobacteria, pathogen or non-pathogen. and its gene sequence is now determined. It has been named as Mycobacterium indicus prani. Mycobacterium indicus from India. Pran is my first name, and NII is the institute from where the trials were conducted, National Institute of Immunology. It expedites bacterial clearance, granulomas, upgrades CMI responses of BLLL patients. Next slide. And there are no blemishes which are completely removed, which no drug does or achieves. And then it is also active in tuberculosis patients who are otherwise drugs resistant and difficult to treat. So therefore, it's a very useful vaccine with many properties. Next slide. And let me tell you, I am even using it for other things which I won't discuss now because those works are under carrying out. So these are my colleagues and co-workers who participated in some aspects of this work. Thank you very much, and I am there to answer any question that you have.
With the permission of the chair and the co-chair, may I be permitted to talk for just 90 seconds. I fully understand that this particular topic is not directly relevant to transforming healthcare with information technology. But ladies and gentlemen, with the onset of AI, I belong to the old generation. I'm far younger than Dr. Talwar, but still, I belong to the old generation. I am worried and concerned that the millennials of today, how many of them at the age of 99.5 would come here, stand in front of a mic and do all these things when there was not a single computer in his laboratory in the 70s and 80s and the 90s. It is only in the last 30 years that he has had some exposure. He does not know about AI, and I think that is the reason why he has succeeded. I mean, I'm being flippant, but what I'm trying to tell you is, I first listened to him at a lecture at IIT Kanpur a few months ago. I'm 24 years younger than him. I was so inspired by him that I thought I must get him here. I misused my position as being involved in a scientific committee, but I really thought that listening to you, sir, I think should make as much importance as it has done for all of us listening to the fantastic lectures we heard in the last 10, 12 hours. And sir, once again, I honestly wish you could be cloned. Thank you, sir, for coming here at this age.
So, thank you so much, Dr. Talwar. It's really, you're a personal and a professional inspiration for a lot of us here. I think 70 years of, mission-based work, I would say, and a huge bridge between what I would say fundamental biochemistry and global public health deployment. So really, thank you so much. Let me take the opportunity to invite our next speaker, overcoming challenges in deploying femtech in healthcare in India, Swati Kulkarni, co-founder and CEO, Elda Health.
Hi, good afternoon, everyone. Sir, I would like to take, the privilege of thanking you personally. I'm very humbled to share stage with a guru like you. It's not just about the contribution, to science, but also the contribution to humanity. And for a disease like leprosy, which is not only dreadful, but it is also socially sort of so, stigmatizing. So thank you so much. And I'm honestly very humbled to go after you. I told the organizers, please don't keep me after him. I won't be able to do justice. But here I am. So thank you so much. Good afternoon, ladies and gentlemen, who I hope after my session will all speak for women's health and advocacy of femtech. I will skim through my slides. The first 5 of them talk about our challenges with femtech in India. Most of us already know but I will just take you all through the journey. But I'll spend some time on the next 6-7 slides, which actually talk about how we can solve for those. The first and foremost problem is femtech funding challenges. But at this stage, I would like to introduce myself and tell you why I am here and why probably Dr. Ganapathy thought that I could be relevant in adding a little knowledge to this really immense knowledgeable crowd. I have been the co-founder of 2 women's health companies, both which were venture funded, and like the joke is in the house, they feel that the mother builds companies based on her age. So 10 years ago, I built a company on period health. It is called Nua Woman. Many of you might be using products of Nua. Recently, 6 years ago, I co-founded Elda Health, which is a perimenopause and a menopause company. Many folks asked me, was it easy to raise funds? Today, I can say, yes, it was easy to raise funds. But honestly, we had to teach investors what periods mean. What it is to have a uterus. And like my dad, who's a gynecologist, always says, a woman is a woman from the womb to the tomb. And this is what we had to explain. So it's not a very easy thing to do. Now, why do I think I have the right to do something about femtech? Of course, I'm a woman. I come from a family of doctors. But I've also personally gone through so many health issues, as far as women's health is concerned, with no access to technology that could educate me other than my father and a bunch of doctors. So the challenge is, how do we actually improve that? The second question that I would like to ask all of us is the cultural barriers that we face. How many of us speak about periods at home? Can I have a show of hands, please? Very few hands. Can barely see men. My request is, talk about periods, PMS, postpartum depression, whenever you get a chance. How many of you have heard the word menopause? Can I have a show of hands, please? Wow. This is a really good group. How many women go through menopause? Can anyone tell me? Shout. What percentage of women go through menopause? Yes, please, can you yell? Yes, 100% women go through menopause. Pregnancy is a choice, but if you're born a woman, you will go through menopause. There's a lot of social taboo against all these topics. These are the concerns in India. There's a huge gender gap. What percentage of women actually have smartphones compared to the men? This is something for all of us to think. And this is my favorite topic, the research gap. Continuing my kids' joke, here I am, looked at periods, looked at menopause, but I looked at this research gap and I said I need to join a company that's doing market research in this space. So today I am the managing director of AI Insights company, Konovo. It looks at market research areas for topics that really need a lot of attention. The first being menopause. We recently did a study on menopause to see if we can launch HRT drugs in the US. And we realized that a lot of women want it, but there's not enough education even in the US to say, hey, you know what, we're confident we can get this. We all know about PCOS. Almost 60–70% of the women in this room are probably suffering with PCOS. Endometriosis, it's a pain. Now, broadly summarizing the issues, urban market focus, most of the companies are trying to build for urban markets. There's an economic barrier in femtech. People are not willing to pay for it. People want women to endure the pain. Language barriers. How many of the Indians actually speak English? But all the apps we create, all the products we create are basically for English-speaking people. I mean, guys, we're not looking at the 1 million, 10 million, we're looking at the 100 million women here. Regulatory framework gaps. I think Dr. Anirban spoke about data, the gaps in data in India. I think that's a huge problem. There's also a regulatory framework. If we could have a UPI for fintech, then where's the UPI for healthcare? And where is the UPI for femtech? We are centuries away from a UPI for femtech. Data privacy issues, challenges in the, is this the, okay. I will behave myself and go big. Is this working? Okay. Can you guys hear me? All right, so now I'd like to spend some time, and it clearly says 3.5 minutes, on overcoming silence, which is actually building trust in health. Trust in femtech is earned emotionally. I can talk about the AI we use in Femtech. I can also talk about the immense data we have of close to 500 million women across, but we really need to start with basics. And here I'd like to quote my mother, who's been a high school teacher for several decades. She says, if you can explain a topic with ease, as if you're explaining to a 5-year-old, then you've done your job. So I'm going to try to do that in the rest of the session. The first area where I feel we can improve Femtech penetration in India is building trust through normalization. Have more emotional conversations. Remove stigma. How do you do that? Create apps with different languages. Ask people to speak to you. Launch some of these agentic AIs where you're actually able to communicate with folks in a way that they feel comfortable. Create education before diagnosis. Have empathetic, non-clinical language when you're speaking to the customers, but the work behind has to be core clinical. This becomes really important because today, Femtech and our doctors community is actually very disjoint. And in the companies I have built, I have worked for, the doctor has been central to what we've created. So bringing doctors into the mix is super critical. Femtech scales only when doctors see it as care enablement and not disruption. So you marry these two things together and then democratize women's health to all women. Inclusive design and access, we've spoken about it a number of times. It's not just about how easy or simple you design it, but is it talking to the Bharatiya Nari in the country is something we really need to look at. Create very low-tech models, care for diverse population. So anyone who's trying to build Femtech for India will have to take care of this, and this should be top priority. Now, sustainable payment models. This is close to my heart. When we launched our menopause brand, Elda Health, everybody was interested because nobody was solving for menopause, 6 years ago. But nobody wanted to pay for it because they'd go back home, tell their spouses, their parents about the issues they had, and most people would say, endure it. The common thing used to be, मेरा पति समझता ही नहीं है, उसको लगता है मैं बस बना के बोल रही हूँ. So the fact that people think that this is not real, it is just made. It's a made-up phenomenon, I think has to be changed, which means that people have to know how to pay for it outside of the customers. Data and policy insights, Dr. Anirban, you spoke about it. I think there's a lot of, this quantum of data is high, especially in women's health. We've seen that there's very fragmented data. We're trying to figure out, which one is more relevant. But just creating a guidance or governance, around this is going to go a long way. Now, women don't need more apps, they actually need continuity. So summarizing what works in Femtech, building evidence. If you're able to prove with the outcomes you've created, sort of looking at both clinical and business objectives really goes a long way. Tracking healthcare outcomes, and then publishing those outcomes, so that you can democratize the thought that this needs to be done. Looking at real-world data, collaborating with other, clinicians, and then improving quality of life. Overcoming affordability. How do you make Femtech affordable to everyone? Care models, employer programs, work with organizations, bundled care, subscriptions which are affordable, strategic partnerships, and direct to consumers. Thank you so much for listening to me. Thank you.
Thank you so much, Ms. Kulkarni. I think what we saw was a passionate conversation here. When you get deep tech connecting with mindsets which have passion and a mission, I think we are not just looking at the vision for tomorrow's healthcare, but we are actually creating the vision and making it into reality every day. So I would like to thank the esteemed panel here today. Thank you so much today.
Thank you so much, Mr. Manpreet. May I request the guest on the stage to kindly come together for the picture, please? We now move on to the next segment. The session is on AI in Action, Virtual Assistant, Digital Twins, and Global Transformation. Please welcome our chairperson, Dr. Sai Praveen, Senior Vice President, Medical and Strategy, Apollo Health Access. Please put your hands together.
Hey, good afternoon, everybody. Really appreciate most of you staying back here. I'm sure your blood glucose is about, 40, 50 by now. There is tea and coffee outside if you want to perk up, because the next session is a marathon session. And like all marathons, you will need some endurance, but you will enjoy it. There's a bunch of speakers who are going to be coming up and discussing some very interesting topics on this theme. But before that, like everything else in this conference, we do want to announce the Solvathon winners. I will invite Ms. Ishita, Head of Apollo Research and Innovation, to please share that information. Ishita, can you kindly tell the audience what Solvathon is all about, how it came about? Thank you.
Thank you, Dr. Sai. Good evening, everyone. Solvathon is Apollo's internal annual innovation challenge. This is the third year that we have conducted Solvathon. The idea is to find real solutions to some of the real problems that are faced on ground across our hospitals. This year, we have partnered with IIIT Hyderabad, who has helped us throughout this journey. So the process of Solvathon actually started almost 4 months back. We reached out across the Apollo ecosystem, asking doctors, nurses, technicians, administrators, issues that they were facing on ground. We got over 35 problems, and of these, we selected 12 problem statements that we felt could be solved with the help of technology. Now, this I'm very happy to say that our problem statements have come from across the country. We have doctors from Lucknow, from Bangalore, from Delhi. We have problem statements from our own businesses, from ProHealth, from 247, even the nursing college. So our Solvathon seems to be definitely growing in the last 3 years. With the help of our partners from IIIT, we then put out these 12 problem statements to anyone who could come forward and help us create a solution. We got 150 solutions to these 12 problems. After that started the huge work of actually picking up the top 12 solutions out of these 150. We've been working with these 12 teams over the last 1 month. Each problem statement has an owner who becomes the clinical mentor for this problem statement, and they have been working with the teams over the last month to guide them, to mentor them, to create a solution. And all of this has culminated into 36 hours of, well, a real-life hackathon right here at THIT. We've been on the second floor for the last 2 days, and the teams have been working, sitting across the table with their mentors, with their guides to create their solutions. And this morning we had a judging, and well, I guess it's time to announce the winners. Dr. Sai, would you do the honors? So as second runner-up, we have Codex, problem statement 3 with mentor Dr. Zia. Please come on stage. Can I ask the team to stay there, please? As first runner-up, we have SyncMed, problem statement 7 from Apollo ProHealth. finally, the winners. Chikit Singh, problem statement 8. Dr. Sai, that's your problem.
There was no match fixing, I promise. There was no match fixing. Oh, great. Good job, guys. Great. Excellent. I'm going to give you guys 30 seconds to tell the audience what your solution was.
Good evening, everyone. We are Team Chikit Singh. We, first of all, thank you, Apollo Hospital, for the opportunity. We have built an AI-based drug interaction checker, which compares, analyzes, and interprets data from different medical systems, including Ayurvedic, Unani, and alternative medicine systems with allopathic.
As the benchmark for
yes.
it. So, thank you.
Please ask the 12 teams and their mentors to quickly come on stage for one group photo. Guys, come quickly.
So thank you very much to the teams for all the hard work. And our mission was not just to hack something, but to solve something. Hopefully this is the beginning of great ideas. We've been doing this for several years now and hope this continues. Ishita, thank you very much for your coordination and taking care of this problem. I would like to now quickly jump into the last session of this evening and this conference. And this will be, like I said, a lot of ideas being exchanged from around the world. The theme is AI in action, virtual assistants, digital twins, and global transformation. I'm going to invite our esteemed speakers up on stage. I would request Dr. Mohammed Al-Abaidil, from CEO and founder of Patients Know Best from Bahrain. Mr. Harmeet Chauhan, Chief Executive Officer of Neural. Mr. Mark Paradis, Principal and Founder of Siom Consulting from New York. Dr. Ashish Atreja, former Chief Information and Digital Health Officer at UC Davis and founder of Valid AI. Mr. Juha Vilenen, Head of B2B Partnerships at Garment, Emerging Markets and Middle East. Dr. Shivam Natarajan, Global Head of Healthcare Practice, Experian Technologies. Todd Wilkins, Chief Technology Officer, Premier. Mr. Uday Akaraju, CEO of Bond AI. Are they still here? Uday, you still here? Oh, there you are. Okay, perfect. Great. Thank you. Perfect. So without much ado, really quick, as you all know, this is a session where you're challenging the audience with their attention span. You're also challenging the clock for some of us who have to catch flights. So I'm going to recommend we have 10 minutes each, but if you can finish your talks in 8, it'll be amazing. And really, today, what we've been talking about in this session is AI in healthcare has really moved past pilots. It has moved past promises. The real questions now are where it belongs, how it can scale, who it truly serves. And I think as we listen today, three, filters really matter. Does it improve access? Does it build trust? Does it make care more human? And that's the lens for this session. I would urge all of you to do your best to pay attention, because this session might really change your perception of how healthcare operates, how transformation operates. And without much ado, I'm going to require Dr. Mohammed Al-Bayadil from Patients Know Best to take the stage. And we're hoping to hear from him. What do patients really want? How can we help them make better care decisions? Dr. Mohammed.
Hi, can you hear me at the back if I talk at this volume? So my name is Mohammed. I want to show you this photo. This is about the only time I made my mother cry. It's when I was 15 and I was refusing to take my medication. I have a rare disease, genetic immune deficiency. This photograph is from, I grew up in Yemen, and this is proof that I used to have hair. And in that environment, I had a genetic immune deficiency and kept on getting infections. And my mother spotted that early and began making sure I had boiled the water so I could not get the infections. Now, she kept me alive long enough to get to the right doctor, get the right treatment, and then she taught me how to always keep an eye on my test results, understand my health, and take those medications. So my interest has always been about how other people should get that opportunity. I've written a book about this when it's open access online, and if you want a copy in paper, come and see me afterwards. But the fundamental idea is that if a patient has their data, that's better for everyone, because fundamentally what's driving healthcare costs is complexity. So rare diseases are 1 in every 17 people. It's longevity. People with conditions live for a long time rather than dying now, thanks to advances in medicine. And distance. People travel long distances to get the right specialists. So these people need the data to move with them for the safety and efficiency of the healthcare system. Now, governments are going to be fundamental for building that infrastructure, but what my interest in my book is that they focus on government data sets and miss out on the citizens' data sets, which really are going to be the future of AI, as well as people being able to look after themselves. And if governments don't solve this, if they can't get the citizen to have agency to look after themselves, governments will not be able to afford having an economy, because healthcare takes up so much of spending. So this is a good report from Tony Blair Institute last year about using AI from a single patient record. It goes through a framework of 3 things. You need to integrate the data set, like India is doing. You need to automate with the AI systems, and then that drives the motivation for the citizen to look after themselves. So the integration in the past has always focused on maybe a hospital portal or a disease portal or a regional portal, and all of these ones miss out on what the citizen needs, which is a single system that receives data from anywhere and takes it to anywhere. That's the architecture of Patients Know Best, the company that I started in 2008. And a key part of that is data from the citizen always gets missed out by the clinicians and the governments, but it's critical for the future. This was proven in the 1980s. This is Omron, the blood pressure device manufacturer in Japan, and they began asking consumers to take blood pressure measurements. And what they proved was not only is that as good as the doctors, it's actually better. You avoid the white coat hypertension, but the most important variable in quality of data collection is quantity of data collection. The more blood pressure measurements are taken, the better the actual measurement. And who has the time for the most measurements? It's the patient at home. Today, of course, we have FDA-certified devices in a smartphone that take full vital signs. Again, much more frequently, therefore much more accurately than the professional's medical record system. But governments always miss out on that. They, for a variety of technical reasons and privacy reasons and clinical liability worries, they forget about the citizen's data in that single record for the citizen. So my focus has always been on personal health records. How do you do that as infrastructure? And if you look at different countries, you've got one extreme, which is the US, which has no system. It's completely, they say it's free market, I'd say it's chaos. And the other end is you have the Nordics who try and build the whole thing, but those systems become frozen. And so what you need is a dynamic market between the governments starting infrastructure and a marketplace of the private sector building consumer-specific applications. There's an example of what we do in England. The blue part on top is built by the government's National Health Service. That's the app that everybody wants to use, the brand they trust. But everything below the blue is built by Patients Know Best as a private technology company that knows how to release the advanced functionality. And that kind of approach of public and private partnership is scalable. We operate in 10 different countries in 10 different models, but it's the same idea that you take the government's governance and the brand that the government trusts, that the citizen trusts, and then you put in private sector innovation for the consumer to then bring in their data sets. And that operates at the level of 125,000 new patients registering every month, 22 million test results being released every month. Now, normally I'm very proud of these numbers, but I come to India, you guys are registering 400,000 people a day, and the volume of what you've built is enormous. It's that India is the most interesting market for personal health records in the world. They still haven't figured out how to finance this innovation, but it is supercharging that innovation. One blocker is the volume of data release. At the moment, it's still unstructured, uncoded, mostly because of competition between hospitals. But you can see this will be the market that proves things for the rest of the world. Next thing is, once you've got that data release, you can do automation. I want to show you one example from the Netherlands of using AI for blood cancers. The main thing I want to show you is the architecture is all the data is with the citizen. They get all the data from medical records in one place in the personal health record, but there's data from the citizen about day-to-day what's happening in that blood cancer, what medications are causing what problems, how to maximize compliance by the patient because you've titrated the side effects. And the interesting thing to me is if you take that disease-specific approach on top of a person-centric infrastructure, if you look at the user interface for that, no medical record system has that user interface because it's a generic medical record system, whereas this one is specified for how do you deal with a particular blood cancer, chronic myeloid leukemia. And you want 1,000 of these different apps for 1,000 different diseases, but they have to be built on the citizen infrastructure, which covers every single problem the patient faces. I'm going to finish on motivation. This is the annual survey. For the last 50 years, the English government calls the primary care physician a sample of their patients and asks them, do you have a favorite primary care physician and do you get to have an appointment with them? And you can see it's stable. Patients do have a preference for who's going to have that interaction with them, but they increasingly fail to meet with them. Continuity of care is no longer possible in medicine. And furthermore, the problems that patients face, increasingly long-term conditions, they require coaching, and clinicians haven't been trained in how to coach. So I'm just going to finish on this one. You've seen the news in the last month. It's become very dynamic in the USA with Google, OpenAI, and Anthropic putting AI user interfaces, large language models, on top of records that the citizen can retrieve. So on the one hand, that's really interesting. It's watching them have a business model where the consumer pays to understand their medical record and to be coached around their medical record. But on the other hand, it's the worst market in the world to start. They don't have a national identifier like Aadhaar ID that you have here. HIPAA is incomplete compared to your legislation, and the data sets they have are designed around locking the patient in rather than moving the data around. So again, I want to finish that India is the most interesting market for building the next data set of AIs. And if you want a copy of the book, it's free online. Thank you very much.
Thank you very much, Dr. Mohammed. That was really insightful. I think what I can recollect as a clinician is I have patients come in with paper records lasting 15 years. Some of the public sector units don't have all EMRs yet, but those paper records which have 40, 50 pages can give you a lifespan history of that patient, and sometimes that's all you need. But I think we really want a blend between something of that sort of a patient record as well as a digital one. It's my pleasure to invite Harmeet Chauhan, who's the CEO of Neurosurgery. He's going to talk about programmable care, and I think the question I would have for Harmeet, I'm hoping his talk will answer, is what part of care should we not program? I'm thinking everything should be, but glad to hear from you, Harmeet.
Good evening. It's truly an honor to be here in front of this esteemed audience and to be at THIT second year for me. And thank you, Dr. Sai, for orchestrating and including me in this panel. I'm here to talk about era of programmable care, but I'll take a minute to set a context. Who's NewRealm? NewRealm is a tech services company. We're all about making technology work for healthcare ecosystem. And it so happens we're living in the world of AI, and that's where you see AI in action. And you saw some of it today with some of my colleagues partnering with Apollo and Microsoft, showing as to how AI is helping modernize technology in context of Apollo as well. The era we live in, you have, every country has different workflows. Every country has different mechanisms to deliver an experience to a doctor, experience to a patient, experience to a clinical staff, and it is delivered through a common technology stack. Of course, it is packaged in different shape and form to different countries as to what is needed. Secondly, there are a lot of hospital systems and healthcare ecosystem which has there are brownfield infrastructure. So they have technology which is fragmented, has to be brought together and make it work. And then there is a lot of greenfield development where, example being India, where you have an opportunity to have a fresh start and deploy the latest and current technology stack. A lot of it has been touched upon today and yesterday in different topics and different discussions. And I will try and summarize in a pure technologist view, not a healthcare view, as to how it's already in action and some of it is going to get in action. And hopefully, in the end, I will answer Dr. Sai's question as to what care should not be programmable as well. So let's go to the next slide, please. The next slide, the simple message here is, as you see technology fragmentation, all the systems, all the technology infrastructure powering the hospitals, powering the healthcare system, it's not static anymore. It's all moving. It's all intelligent, and that's a big shift. And as a result, healthcare is moving to a lot more execution-oriented, a lot more action instantaneously. And as you will see in the next slide, next slide, please. There is a physical world, and there is a digital world. We, today morning, heard a session of consumer tech. If somebody's wearing an Aura device, somebody's using some other devices, and a lot of it is touching the human body, and that's where the sense is coming in. Now, as the physical world senses it, it learns. Now, you bring it to the digital world, and that's where the digital twins come in, and we heard about how digital twins are being used for biohacking. And then you act, and you saw many examples out there. So the challenge in front of us in the context of AI is how do you program the physical world and the digital world? And certain aspects, of course, will not be programmable because in every aspect you do, it's a human being, it's a doctor who's taking a decision. And as Mohammed touched upon, there are patients who have more data as well who are enabling this decision making. We touched upon the importance of data. There's a lot of static data every hospital has, every patient has. But there is a lot of real-time data being generated. We learned enough from different specialists between today and yesterday. And what we believe, this data is scaling at an exponential speed. So what does it? It also further substantiates the need that the systems cannot be static. Systems need to be intelligent. They need to continue to sense. They continue to learn. They continue to move into action. Now, to take this world into reality, we are seeing in front of us 3 pillars. 3 pillars is where the technology is coming together, the healthcare knowledge is coming together, the expertise is coming together. One is the physical AI. All of you have devices in your hand. We heard today about sleep as to how sleep data is being captured real time through your devices. So that's the aspect of physical AI which is in front of us, we're living every day. And then you have agentic workflows. We have seen enough examples as to how AI is becoming an assistant, a tool to doctors, how it is enabling billing, how it is enabling multiple facets of the care which you need. But to translate all of this, you need a technology infrastructure. You need the platform to really bring the physical and digital world together. And that's where we believe are the 3 aspects in terms of 3 pillars of a programmable paradigm. I'll just take 30 seconds here to give you an example of physical AI, and we heard some of it in the last 2 days. One is the operational twins. So a doctor walking in to do a surgery, can he or she set up and simulate the whole surgery using an operational twin technology? Can they take the biomarkers of a human body and translate, use digital twins to do a complete clinical aspect before it is done in real time in actual human body? So it is accelerating the learning. It is making it much more real from a diagnosis to care, from a human body perspective and medical care perspective. And all of it is happening in front of us today. If I look at the agentic workflows, we touched upon the agentic workflows. This is now putting AI and embedding AI into all aspects of workflow of healthcare delivery, whether it's touching the patient, whether it's touching the doctor or the clinician or the members of the ecosystem. And that's where you have multiple aspects bringing it together. Out here, one can decide which aspects of the workflows do not need to be programmable. There will be an oversight from a regulatory, governance, policy, and that is a decision a healthcare ecosystem can make for themselves. Now, you saw a demo of it today morning or today afternoon. This is where NeuRAM brings to bear. Now, you have to bring all the aspects of physical, the workflows together. You have to have a fragmented technology stack. It has to be brought together. And that's where we touched upon the platform architecture to make it happen. We today touched upon as to how it's not a product, it's a platform, it's continuous care. How do you go do that? How do you bring the aspects when multiple technologies are being brought to you to do different aspects of care? How do you bring them together? We learned about remote care in remote villages, which is happening. How do you ensure that remote care is powered by a platform which brings the best of technologies out there in the world and ensure you're able to give a much more efficient care, and that too at scale? And that's where the platform architecture plays a significant role, and the new GAIN is an example of that. And I touched upon it already, but these are 3 pillars which make it reality, the whole era of programmable care. Now, I'll try to answer before I sign off. As I said, the workflows, you decide which are not programmable based on the regulatory and governance. But the intent would be that as the journey travels, everything does become programmable. But how do you configure it, how do you organize in your context will vary from hospital to hospital, country to country. Thank you.
That was a really nice framework, Harmeet. Thank you so much. Mark Paradis, you're going to be talking on digital twins and virtual humans. And I'm curious, I'm hoping, are there any digital triplets? Are those coming down the line? I'm curious. And of course, I also would love to know, why do clinicians like myself sometimes resist virtual humans?
Thank you, everyone. Thank you for the intrepid few who are sticking through to the end here. I do have a fair number of slides, and it's a fairly large topic that I'm covering today. I will try and go through them very quickly, but should anyone be interested, there is much more detail behind each of these. So probably we've all seen this, we all know this, there's a scaling problem in healthcare. There are simply not enough humans relative to the demand and the need in healthcare, right? And so this creates what I call a scaling problem between what scales at the rate of carbon, which scales at the rate of people, versus what scales at the rate of silicon, that is computing. From the way that I see it, there have been 3 waves of health tech. The first wave was a digitization wave. That's really where we started the electronic health record. Second was machine learning and analytics. Third was generative AI. But the problem is, as we've applied each of these to the existing systems, and at least certainly in the US, which is the systems I'm most familiar with, we've just simply applied them as Band-Aids to the existing approaches to care. No one has looked at it from a systemic approach or a systemic standpoint. And that's really what I'm talking about when I talk about wave 4. And wave 4 is where things like digital twins, virtual humans come into play, as well as all of the preceding technologies. The principal difference about Wave 4 is that we're looking at it as a system, and we're thinking of it as a learning health system, and how does the technology not just exist as technology alone in isolation, but as part of a system that includes people, it includes regulation, it includes desires and wishes, cultural conditions, and all the rest. It's important that the learning in this context is continuous, and I think we've seen some slides from this earlier, I think in the previous session, where it shouldn't be about trials that are being run or static approaches to data, but that each and every patient, as they go through their journey, is in fact generating data, and we should be learning from that data at each and every moment. So to sort of help give a little bit of a metaphor or a mental model, one of the ways that I've been thinking about this is as a rail system, and it's a little bit ironic that I'm trying to talk about a Wave 4 futuristic AI tech-enabled with 19th century technology, but I think it does a reasonable job. And so I think we can think of the patient as the passenger in a rail system. The patient starts at a particular location, which is their health, their current health state, and they want to go to a particular location, right? And that's the health state that they want to get to. When we think of care pathways and clinical pathways, I don't literally mean sort of the individual steps that exist within the EHR, but the actual care journey itself. In many ways, that is the train that is taking that patient from one stop to the next, from one location to the next. The health system is the engine that really drives and pulls the patient and the train to those various destinations. We can think of the nation or the state as the rails. They're providing the guide rails, the regulatory regime, and the rest to limit where we can go and set locations there. And then finally, if you think of the rolling stock, which is the actual engines themselves, the cars themselves, those are allowed for industry to go and create those instantiations. One of the things that changes here in a very meaningful and significant way is what the unit of transformation actually is. And so in this case, it is those pathways themselves that we are trying to learn from and trying to draw these types of conclusions from. Whereas previously, everything was very episodic. Well, previously, it still is episodic, where we think of each encounter as a standalone encounter to some extent. It's a point in time. We sort of string them together, but there's no real sense of continuity in any of that. And it's really only looking at the patient and the journey from the various stops that the patient is making along the way, or from when the patient actually touches the healthcare system, rather than by meeting the patient where they are, and where 99.9% of our health occurs, which is not when we're in the health system, hopefully. And so when we're thinking about this, what this means is we begin to reconceptualize and apply these technologies. We're not simply adding digital features to healthcare. We're not simply putting Band-Aids on an already broken system. What we're actually doing is taking an opportunity to think about the technologies we have and to reimagine and to re-engineer those entire pathways and that entire system of care. One of the key components of this are what I call next generation data assets, and these are the data assets that are currently too large to go into the electronic health record. So it's things like streaming data from clinical consumer grade wearables, bedside monitors, it's things like ambient audio and video, not for scribing, but for diagnosis and interaction. It is things like multi-omics, not just genomics, but the entire spectrum of omics. And finally, it is also procedural video. And the fundamental difference with all of these next generation data assets is they are continuous. They are streaming. They are not episodic. They're not points in time. They're not snapshots. And what they represent then is telemetry, right? And off of telemetry, when you have that type of data, you can now make simulations. You can now create digital twins in many ways, right? Where you can actually, for each one of those patients, right, for each individual, for everyone in this room, we can be collecting these continuous data sets, these continuous data assets, feeding them into these digital twins, Monte Carloing those digital twins, trying out different scenarios, whether those are scenarios of care, drug A versus drug B, or whether those are scenarios of how you live your life, right? Should you have recipe A or recipe B for dinner tonight? Importantly, when we're looking at these next generation data assets, these are signals, not outcomes. The outcomes are derived from that. And in many ways, data is in fact, or is always the fuel of AI and technology, and it's no different here. I'm beginning to allude to this a little bit already. This is where this notion of big AI, virtual humans and digital twins comes into play. And again, one of the beauties of creating these digital twins, and the thing that really sort of sets apart a digital twin from just a simulation is, again, simulation, you enter the data and you let it run, and a digital twin, you enter the data, you let it run, but then you're continuously updating that with the data, and you're continuously checking your predictions in real time as you're moving forward, right? And you're learning from that system as a whole. One of the things that I define a little bit differently than other folks, virtual humans for me are not a digital twin that is a human. A virtual human for me is the interface. A virtual human for me is how you're interacting with the system, how you're providing data into that system, and it is interacting with you in return as well, versus the digital twin, which is doing the actual Monte Carloing and simulation. We can think of this then as creating a sort of a three-layered terrain where care happens in each of these different terrains. The first one is, will be an AI native terrain, and that's where that virtual human lives, and that's where it's integrated into our daily lives. And this is where population health begins, not at the level of populations, but at the level of individuals. If we optimize health for each individual, by definition, we will optimize health for the population. Now, this is a little bit of a different view of it, because usually we think of population health as a top-down exercise, but the top-down exercise almost always fails, whereas if we meet the patients where they are and we enable them to live the lives that they want to live, then we can end up working up to those. At some point in time, you do need to begin to interact with the healthcare system. You do need to triage particular events, and that is where a telehealth-first terrain comes into play. And we can actually interact with the patients that way. And then finally, at some point in time, you do need to touch the physical health system. But ideally, if we do this correctly, and we really are thinking about a prevention, wellness, maintenance, diagnosis standpoint, in this case, is most healthcare journeys should not end up in physical care. One of the things that becomes very important to this is we need to remember this is not AI taking over our lives. It's not AI making decisions for us. This is AI working in conjunction with us. It is AI enabling us to scale those parts of the system that can scale at the rate of silicon while allowing those parts that scale at the rate of carbon to have the maximum throughput and the maximum agency and control. So just sort of as a series of final thoughts, I think why this matters to India in many ways is, as we've seen in many of the previous talks as well, India has several very unique features. It has scale, diversity, also has a tremendously robust infrastructure that has been built, a digital infrastructure already, and there is an appetite and a hunger to really step up and become a leader in the world and develop these new models of care, which will not simply be India-specific. These will be the new models of care that we can apply worldwide, whether that's in the US or whether it's in Indonesia, whether it's Africa, Europe, wherever. And on that, I will stop. Thank you.
Thank you so much. We're almost on time. I really appreciate you speeding up through that like a train, but exactly. Dr. Ashish, all yours. And I think what we're going to hear from you, I believe, is about global AI transformation. People ask me, why do most AI pilots fail to scale? And I'm curious about also, what's more important? Is it accuracy or deployment at system level?
It's a pleasure to be here. This is my first time in THIT, and really kudos to the Apollo leadership for organizing this summit and bringing us all together. Special thank to Sangeeta ji and to Madhu for having me here. I want to talk about my life a little bit, and just goal is to demystify AI from the hands of a clinician. How do we use digital health and AI for real impact, for real use cases? So I'll share all those use cases, but throughout my journey, I call my journey as a half and half. Last month I turned 50, so 25 years in India and 25 years in US. And it's been just fascinating to have 5 career lives, I call it, starting as a physician, but doing public health and informatics. I spent 2 years programming and coding and really learning how technology works and can really help in clinical care. Then doing innovation and really building a digital health lab, which touched 90 million lives. And of late, really, as a CIO, doing transformation at scale in the enterprise deployment, what was said. And how do we take what we've done in one organization now, can we repeat it across different organizations at scale, globally? That's the next part of my journey. And you know, when we talk about AI or digital health, I think the first question we should ask is why? We don't ask that question a lot more often than we should. And the reason for why is, it was told yesterday by Dr. Zimlickman and today as well, we just do not have enough clinicians, enough physicians, nurses, other support people to take care of patients throughout their life. And I'll deconstruct it for you. And if we just take the medical lens, we see a patient, I do gastroenterology, I see patients with inflammatory bowel disease. I see them maybe 2-3 times a year, 20 minutes at a time. But 99.9% of their time they spend at home when I'm not there. We just believe by seeing them for 20 minutes or 30 minutes in a year, their entire health trajectory will change, right? And that doesn't happen. And that's where the biggest gap is. What we truly believe and measure in efficacy in clinical trial, like 95% patients' blood pressure can be controlled with modern medicine, and effectiveness, which is in the real world, where less than 1/3 of the patients are controlled with blood pressure. That's the biggest gap we see, and that's where I think technology can really help. When we start looking at technology lens, I think it's very important to see technology is not what it is today. Technology is what it can be tomorrow. And the reason is, all the medical school training we had is linear thinking, and the hospital operations as well. Hey, we have these many patients, we add one more doctor. But technology grows exponentially, not linearly. And what is the example of that? If you just take one rice grain and you take through all the squares and double it, by the end of 64 square, it is half the world's rice production, right? So what we see AI is nothing compared to what we'll see AI in 10 years. So we started defining digital health around 10 years ago. This is 2015. So we devised digital health, digital medicine, and digital therapeutics. But how do we take these concepts and really bring it into patient care? So we started building platform when I was at Mount Sinai, where doctors for the first time not only could prescribe medicine or surgery or a procedure, they could prescribe an AI bot or a digital health. And we ended up scaling to 90 million people across different service lines with amazing outcomes, right? As a GI, as a gastroenterologist, I may not see more than 10,000 people in my whole life. But here I was looking at 90 million lives being impacted because we changed the care from just being one-to-one. You have to be in the same space and the same time, a patient and a physician to deliver a care. Telemedicine unlocked the space dimension, but through digital health, we unlock the time dimension by really creating digital avatars of ourselves. And a good example of that is in the COVID time. I was in New York when we had 950 beds, patients with COVID out of a 1,000-bed hospital. We had 1 million calls waiting for us to be answered, but no one could answer them because half of our people who respond to the calls were sick. So we built a bot within 8 days that reached out to 1 million patients, and 55,000 people we guided without a single coordinator. If we had to have nurses doing it, it would have taken 100 nurses 1.5 years to do it, which we could have done in 8 days, right? So we truly believe the age of creating enormous care delivery has arrived. It arrived 5-10 years ago, but at that time it was rule-based AI. But now we have generative AI. It's such a big beast that no one can conquer it alone. So we started a consortium of 50 health systems partner called Valid AI, so we can learn the science of generative AI. And I look at AI, data science, very much I look at physiology, biochemistry. These are foundational building blocks which will take us to the next level of digital medicine. But there are important challenges we all face. We call it LLM jungle. There's just so much going on. No one can figure out which model to trust, what to bring. And if you do find the model, we also have to make sure it's valid, accurate, ethical, compliant in all regard. So most of the health systems do not have capacity to really bring it at scale. To your question, we really need to create a framework. So this is our AI Center of Excellence framework. And our thesis is every single modern organization anywhere in the world will need to have an AI Center of Excellence concept in some shape or the other. But we can't just stop as a framework. We really have to deliver. So we're now working on a framework where we can deliver platform at scale with multiple large language model that touches every single employee. And once the employees have full capability, because in the age of AI, we're betting on humans. Once they have full capability, then they can manage all these agents we talk about and really deliver outcomes. So very happy to say we launched the platform 3 months ago. It's now across US and India right now, delivering care, enabling employees from, I was just talking with Dr. Sanjay, we can bring it to Anganwadi worker, a primary healthcare person, and they can manage at the level of a specialist if we do it the right way. But we really can go beyond empowering employees to really empowering patients at scale. We can take the example of what we did in COVID and multiply it by 1000x now with agentic thing. So we just launched 2 weeks ago Genie, which is an agentic module which can automatically reach out to millions of patients, have a real conversation with them, counsel them, does the medication reconciliation, and bring it back to the humans. I wouldn't have time to go through it, but maybe you can just hear it briefly.
I help check in on how patients are doing and pass information to Dr. Clark's office. May I speak with Ashish Atreya, please?
Yes, speaking.
Thank you for confirming. Could you provide your date of birth and zip code for verifying purposes?
Yeah, it's August 15, 1995, 95616.
Yeah, I'm not that young, but just to show, you can have a full conversation any language, and that's happening real time right now. Not only for clinical care, but for research. We want to go beyond, but the real bigger transformation is not through technology. It's actually to humans like you. So very proud that we launched an AI Academy where we trained clinicians in all the specialty, and 10 of these clinicians have become national experts with grants in AI. So I think we have a bigger onus of not only to bring technology, but really to bet on the humans in the age of technology. And I often give this example of the dragon. If you've seen this movie, it sounds very scary when you see AI or a fire for the first time. But if you learn how to master it, it can take you to heights that we've never been before. We can create truly an age of care abundance that we've never seen in modern healthcare, but only if we do it together, only if we do it responsibly. So I'm sharing my email. Let's create an AI Center of Excellence globally, because truly the world is global, and that's what we need to do to learn from each other in the age of AI. Thank you very much.
By a show of hands, how many of you are still awake? Good. The rest of you have shoulder abduction problems, I'm guessing. A little standing up exercise would be good. We're halfway through. Most of you in school are waiting for the lunch bell. Well, this is really good stuff. This is really cool stuff. The next speaker works for a company that is not named after a fruit. He knows the value of time, and I would be my pleasure to invite my friend, Juha Villanen from Garmin. The question I have, Juha, are wearables ready for clinical grade? And all yours.
I have 8 minutes. Huh. The Apple Watch users had 10. Hi, my name is Juha Villanen from Garmin, and I know you are tired, I know, but let's do a little bit of a validation exercise here. How many of you have heard about Garmin? Okay, how many of you have a Garmin? Whoa. And how many of you are wearing an Apple Watch? Yeah, there are chargers on the sides then if you need them. So I have a little bit of, it's 7 minutes going, and it's not a problem, but I have a little bit of other approach to this session, AI. I'm happy to be here because quite a lot of what we do in the digital health area relates to AI, but we are on the source side of that. But I will go through, practically run you through the evolution of Garmin to be a player in the digital health ecosystem. But as you can see here, Garmin was actually founded as a satellite communication company 35 years ago. Gary Burrell and Dr. Min Kao, Gary and Min, founded the company for GPS navigators, late 80s. And here you can actually see the first Forerunner watch, 2003. So we've been producing wearable devices since 23 years now, so we are not a startup in that space. But actually, it was a bunch of engineers building a GPS navigation device called Fortrex, just a handheld navigation device. But as they were all runners, they taped it on the wrist and tested if it works while running. So that was the sort of the origins of our first Forerunner watch for runners. And that's quite a lot where we are known as also. So we are sponsoring, for instance, the Ironman India in Goa every year, and about 80% of the participants are Garmin users. So if it be triathlon, running, endurance sports, swimming, cycling, we are a dominant player in that space, and that's where we are known. We are not too known in other, let's say, more well-being lifestyle areas yet. But here's an example of the origins and sort of the principles of how we make our products. This guy here is an ultra runner or trail runner, and he needs the reliable data, and for instance, he needs a battery life. So this product here has a 36 days battery life, and more than 300 hours in GPS mode. You know, he can run for days without charging the device. But also, he's mainly interested in the sport features, VO2 max, running power, and so forth. But of course, all the health metrics like the heart rate, heart variability, stress, pulse ox, and this are important for his recovery. But on the other side, with the development of our biosensing technology and overall biosensing technologies, new features came along, and these all-day health metrics became relevant for me as an individual, my peers, but also for the digital health industry as such, because reliability and the meaningfulness of the health metrics increased. And today, this is quite often the source for many AI engines and apps at the moment. Here you can see, like, we go to the sort of wearable space. From our perspective, we are very different if you compare to Apple or Samsung or some Indian competitors. But you can have a look here. So the Forerunners, as mentioned, 2003 was the first one. And now we are in a Forerunner 970 is the latest one last year. That's our running space. Then we started to work on the outdoor space, which is, there are more navigational features in the watches, or satellite communication features in the watches. But then, as said, this all-day health relevance was growing, so our wellness lineup started. So basically, those were simple step trackers at the time. So that was basically the main reason for our products. Again, sensors developed, features developed, and the access to advanced health and biosensing data those are the most popular products at the moment. But also, then other form factors like scale, blood pressure monitor, or sleep tracker, which are not worn in the wrist, have now come to the market. So this is how we have entered from that running athlete performance side to be a rather big player in many fields of wearable devices and other devices as well. And I can assure you, watch this space this year, we will have other very interesting products in most of these categories as well. Relevant for the AI session here and the digital health in general is that, of course, while the variety of wearable devices for different purposes has been evolving, as you saw, but also the biosensing capability has been evolving. Accuracy of our sensors enable us to provide other health features that are again relevant for me as an individual or the digital health ecosystem as a whole. As said, it started with steps, now we're in skin temperature and respiration, so forth. And this is the development here is extremely quick. Saying that then, this running watch company, an athlete performance company, then suddenly speaking here is a surprise. But we are not the ones, we are not the experts in, anything that a medical doctor, physician would be discussing here. That's why we allow our partners to utilize have access to our biosensor data via different kinds of APIs and SDKs. And this is the source of innovation. So we combine your expertise, and in a certain sense, we get you access. We let you build algorithms and AI on our biosensor data or activity data, and that's the deal. We are not specialists in that one. And most of these are quite openly accessible APIs as such, and actually we have one company here from Hyderabad, Krishna Atmakure from ClearCals, founder, and they are using our wearables for their nutrition platform. Just an example of a startup company utilizing that access. Go to Krishna and say hi after he's wearing a Garmin watch also. Examples of the ecosystem. So this is a fancy one. I like this because this is Baylor College of Medicine and TRISH, which is basically a space research institution in the US. These astronauts are using our Garmin Fenix 8 watches, this one, because the battery life and accuracy is so great that they can do the whole space travel without charging. But the impact of space travel on human body is the goal here. So it's a very interesting project. And then I'm very proud here that we are also working with, Dr. Sanjita has been mentioning this a few times over the days. We are working with Apollo's Total Health and Total Health Axis in the rural area of India, where our rugged trackers are being distributed in the villagers, and the data is going to the Apollo platform. So we are very excited to see how this goes onwards. This is the last slide. I hope you woke up. But yeah, wearable evaluation, every bit counts, and it's for the athlete, for me as an individual, for the ecosystem and the AI. Wearable evolution, you have lots of different kinds of variation. It's available everywhere, off-the-shelf devices. Biosensing quality, it's required for the trust. If there's no trust, AI can't do anything on it. Battery life, you have to be able to use it more than just an hour. And the connected ecosystem, which is the key issue in creating innovation in healthcare. Thank you.
Thank you so much, Juha. That was really enlightening. I would invite Dr. Shivam Natarajan to kindly give us some information about population monitoring and what really do clinicians need to do to move from one patient to have a population view.
Thank you, Sai, and thank you all of you for enduring this session. I just, going back 27 years back, it was Apollo which made a surgeon out of me, and then from there it moved me to be a technologist. I founded Medvarsity 27 years back, and that inspired me because I was fed up as a surgeon doing one patient at a time. And what Medvarsity showed is I could make impact in thousands, hundreds of thousands, and now we are doing impact for millions across the world. And so first I should congratulate Apollo and Chairman and Sangeeta for doing this year on and year on, and it's an amazing. I still remember meeting with Dr. Ganapati in '98 when we were looking at the first telemedicine transmissions from Aragonda. So the same principle struck to me that even when I moved over to healthcare technology almost for 25 years there now, it's not one-to-one. I'm almost 80% or 90% of the talk in the last 2 days was how do you apply AI to that patient and how do we take care of that patient. But today I'm going to talk about how do I apply technology to the population. We were talking of scale. I think population health management by design is at scale. I'm not talking of AI for the individual. I'm talking of AI for the millions at a given time. So that's what my discussion will be on. I've summarized the 8 takeaway messages. I've got another 6.5 minutes to do that 8 messages, and let me see how fast I can do that. The first and foremost thing is traditionally population health management was just a retrospective exercise, and it was always based on data analytics, and people made grand dashboards. But today, population health management is not a data analytic issue, it is a data computational problem. We got data coming in from your garments, from your EMR, from the population, from the census, from the weather. So it's actually a major challenge today, not for analytics, but actually computational. There's competition for your data centers today, not to run each individual person's data, but actually the whole population. So this is something which we will be battling with. I think AI is not a challenge in terms of technology. I think AI ultimately is going to be a challenge of energy and power, and that's going to be a big problem for us to crack. So PHM is, it's now going into that space of complexity that we'll have to manage. The second sort of message I want to say is population health management was always, looked at in some sort of creating dashboards, getting insights, and then using that insights to drive some sort of intervention. And it usually was retrospective. Governments used to use it to come to just doing budgets possibly, and systems used to use it to come up with some sort of improvement exercise. But population health, PHM today, in the age of AI, is almost a living pipeline. It's not some once in a year exercise, and you start from data unification and taking it right up to orchestration of the data across the population and not a single individual. So AI's value lies in the predictive capability and not just analytical capability. We have to move away from just analyzing till death, but actually actioning on the predictive capability of AI. The next key thing for population health management is we don't take snapshots of data of the individual and then combine it to call it as PHM, but PHM itself should look at the longitudinality of the patient as well as the population. So it's not anymore the longitudinal health record, but it's actually the longitudinal population record that is going to determine how we intervene. So you don't need to intervene one patient at a time, but you intervene a whole population at a time. The main challenge, therefore, we have there is how do I link up data across the health ecosystem, not just hospitals. Much of our discussion were around hospital, but you will agree with me, much of healthcare happens in your home, in your community, in your cinema. It's almost everywhere. Apart from hospitals, actually, sometimes. So I think we have to start understanding that we need to have a data architecture that will bring the data from different environments and ecosystems where such data are generated. The fourth important thing, much of my life I've been advising governments across multiple countries, US, UK, Middle East, Europe. So I'll give 3 or 4 flavors of how this population health management is system specific. There's a bit of a challenge. If you do population health management in India, it's completely different from the way you approach it in UK, which is a socialized medicine, than when you approach it in the US, where it's completely insurance driven. So in the US sort of context, PHM has always been claims data driven, and therefore the whole question is, how do I reduce my claims, period. That's all I wanted to use population health management for. Kaiser Permanente, raising, you take any large system today has gone into a limited view of population health management. But what that gives us is that PHM is actually system specific, and therefore you have to tailor it for each system. I come from the UK. There it is primary care led model, and the entire system is now moving into integrated care boards, and therefore it's an integrated care system, and the PHM there looks at the entire continuum of the patient right outside the house, before coming to the hospital, in the hospital, primary care, secondary care, tertiary care, going back into the house, and the social care. So I think UK is, I'm not biased, but somewhere close towards coming to an integrated care model, but they have challenges in delivering that. The next sort of model from where I have learned is the Saudi Arabian market. And in Saudi Arabia, although there have been infants in this evolution of healthcare IT, They are rapidly progressing with their Vision 2030 program. I myself was a senior advisor to the Ministry of Health there. I drew up the National Digital Blueprint, and a key part of the National Digital Blueprint was population health management and value-based care approach. It's good for them. They are not living with too many legacies, so they are able to actually move forward rather than fight legacy systems. The most important thing that I was talking about is that longitudinal integrated population health management. It's not just the integrated record, but actually the integrated population health management across the whole population that we need to start working with. And AI is very, very important for that, particularly looking at how disease trajectory and disease modeling can be done. And it's not just causation, but causal interference. The next take-home message is the key thing about population health management is it's a place-based care. What you do in Bihar is going to be different from what you do in Chennai. It's going to be different from what you do in Kerala. And therefore, to have that approach to population health management based on geospatial requirement is important. Therefore, today's smart cities are not just smart cities for transportation or electrification, but it's smart cities where you build healthcare within that ecosystem. Then AI, we know, has actually amplified a lot of problems rather than just giving solutions. So one challenge we will have at a population health level is going to be how it's going to amplify bias and equity to access. The eighth message, I've got just 1 minute more I'll take. The future of population health management, as I said, is orchestration and not just risk scoring. Many of us, we thought population health management is just risk stratification, risk segmentation, and then you work on those who are having risk. No. Orchestration across the entire continuum of risk is where the role of population health management is. We've got a lot of challenges ahead. We are addressing right now one of the big problem called federated data management in the UK, where Palantir is doing a lot of exercise, but they have not managed to still figure out how to manage federated data. So just summarizing that 8 take-home messages, PHM is computationally complex. We should go from analytics to prediction. The data architecture is more important than just the algorithm. It is highly system-specific. Longitudinality is key. Geography is fundamental. We need to make sure it doesn't create new barriers in equity to access, and the future is in orchestration of data across the whole population. Thank you.
Thank you so much, Dr. Shivam. It's been amazing that despite some of these topics being somewhat esoteric to many of us, you've all converted it into some very practical advice. By a show of hands, how many of you want high-quality health care? How many of you want the highest quality health care? All of us, right? And Todd, Mr. Todd Wilkes from Premier, I think we're going to learn about how to get there. Thank you.
Good evening. Thank you. Thank you to Apollo Hospitals and New Realm for the opportunity to share some of our experiences. The green one? Perfect. Thank you. So real quick overview of Premier. We're a Charlotte, North Carolina-based organization in the United States. We work with 4,250 hospitals across the U.S. And from a performance management perspective, work with them on how to improve their healthcare delivery. And we also have a supply chain business that we help them manage their supply chain and work through that. And the work we do with them represents about $87 billion in supply chain purchases during the course of a year. We have solutions to help them both manage the supply chain and performance management across the full spectrum of the services they provide. These are just sampling of the types of products that we've built using AI for these different hospitals and health systems, from revenue optimization of streamlining HCC coding to streamlining the automation of procure to pay, the entire purchasing cycle for supply chain, working through workforce management processes, leveraging benchmarks from across the nation. We also look at ways of predicting supply chain disruption and how do you mitigate that and how do you replace different supplies with other supplies to stay ahead of that. From a clinical research, we work with life sciences companies and manage clinical trials with them, help them operate that, and also do patient identification. From a quality perspective, we're looking to optimize how we do care treatment using clinical decision support systems. Now, rather than going deep into each of these solutions, I was going to spend a few moments with a simplified blueprint of what it takes to develop these AI solutions. So really what we're looking to do is how can we move from can we do it, the sandbox and experimenting, to how do we scale and how do we govern it? And how can we do that without compromising safety and at the same time enhancing care? So are we improving for the patient or are we improving for the provider? Who is that persona? Do we have the data that we need to do this? Are we industry compliant? And do we have representative data? And then at the end, is there a human in the loop? Does a human have the final authority on what decisions are being made? Now, we want to really look at the reason why we're building it over the technology. Wow, look at what we did. So what problems are we solving? What are the real workflows that we can improve? And how can we move from AI projects to AI platforms? So we focus typically on the administrative AI. How can we give more time back to the caregivers in the organizations? So how can we automate those administrative type tasks? Some of them are looking for identification for sepsis earlier than would be notified earlier. But we want the AI to do more than notify. We want it to send the notification and tell us what we need to do next, and in some cases actually institute that action. By bringing these types of capabilities forward, we can re-engineer the clinical and administrative workflow around the AI capabilities. And in these cases, moving really from chatbots to AI agents. The data is the patient's story. We need to treat it with respect. Both data integrity and patient privacy are key. Diversity in the data is important. You can't have a small sample size. You're going to have a full representation of the data. You need to have qualified data, meaning you know what the sources and it's fresh and the clinical contact. Privacy, you're going to need to use synthetic data for your data modeling and data training. Provenance, you need to understand where the data came from and how it led to the answer that was generated.
Todd, do you mind just speaking a little closer to the microphone?
A little closer?
Yeah.
Oh, thank you.
Thank you.
Yeah, perfect. Thank you. Never been accused of being short before. That was good. So interoperability, you need to make sure that your data can talk to your different systems. Where is the data located and can you get to it? Interoperability is key, and it's also one of our biggest challenges. AI is the assistant. You have a human decision maker that's making the final decision. So the AI is going to make suggestions, but a doctor in this case would sign off. A doctor shouldn't follow just exactly what's being said. The AI must flag exactly what the risk is and explain why the activity is being raised. Humans in this case would need to be there to watch for hallucinations or errors that just don't make sense. But we also have to watch out for alert fatigue and just rubber stamping of what the AI is coming back. You need to spend time to ensure that what it's saying is accurate. AI is never done. Once you build it, there's the care and feeding that still goes into it. You have to continue to look at it. There's going to be algorithm drift. There's going to be improvements in methodologies, changing methodologies along the way. There's additional regulatory concerns to be addressed. You have to stay on top of that. Transparency, making sure folks know when AI is being used and how it's assisting in the care. You have equity audits. You need to ensure that the tool is performing well for all races, all genders, age. And in the near future, I would suggest some are doing this already today, a guardian agent, a special agent that's watching other agents to ensure that you're keeping in track and staying with integrity. And then the last piece is ensuring, are we ready to go? Are we ready from a safety perspective? Are we ensuring that this workflow is going to actually improve and save time and make their job easier to do? You need to have active AI governance, zero trust policies, audit readiness, and active metadata management. And last, active data governance. Is every piece of data industry compliant? Was the training data diverse and inclusive? And do you have a full line of sight to the lineage of the data? Thank you. I was going quick. Looks like I was successful.
Thank you so much.
Thank you very much.
Really appreciate you coming over. I guess you had some ice storms in your area before you left, but really appreciate you coming in. So last but not the least, we're going to hear from Uday Akaraju, a good friend of ours from the United States. He's going to talking about AI blue zones, and I'm just curious, Uday, how do you get to 99.5 as Professor Talwar? I don't think all of us are going to be able to create world-class vaccines. Are there other tricks that you would suggest?
I'll try to tell one of them. Dr. Sai, thank you. Thank you for giving me the privilege of doing the last session. This conference has been really, really good, so let us try to end it on a high. So I'll need your help. Let's make this interactive rather than a monologue from my side. So we've heard a lot about AI in the last 2 days, which is great information, absolutely. But for 1 second, maybe for my presentation, let's shift focus to a blue zone. How many of you actually know about blue zones here? A few hands here. Here, I'm here, yeah. So, Dr. Talwar, I think you'll know better about blue zones, but blue zones are places in the world where people live to 100 years. Do you guys know how many blue zones are there in the world? There are about 5 blue zones officially in the world, and they are in 5 different corners of the world. So there's one in Okinawa, Japan, there's one in Greece, then one in Italy, there's one in Costa Rica, and then there's one in the USA. So these 5 places, people are actually living close to 100 and more than 100 years. So if you guys don't know about blue zones, there's also a documentary on Netflix actually called Live to 100, The Secrets of the Blue Zone. But what is the secret, right? What is the secret of the blue zones? Why are people living at 100 there and not anywhere else in the world? That's the big question. So if you see this documentary, they say the secret to living 100 is about food habits, about sleep, about social circles, about all that stuff. But if you look at biologically, there is one thing in common of people who are living in all these blue zones. The secret to this, in living in blue zones is actually slower aging speeds. People who are living in these blue zones actually age slower. Why? Let's actually talk about it. Because when they age slowly, what's happening is they're not only kind of living longer, but actually they're avoiding a lot of chronic diseases which we have in this modern world. So on one side, you have the blue zones where people are living a long life, but there are all the other cities like Hong Kong, Singapore, Zurich, Tokyo, where people are also living a long life, not because of the great natural habitat they have in the blue zones, but it's actually access to wealth. Once you have access to wealth, you actually have access to good health care, and most importantly, the millionaires and billionaires have access to the longevity clinics, which we all hear about. So there are so many longevity clinics in the world. Actually, I've been to many of them. If you go to a longevity clinic, your basic diagnostic tests actually start from probably $20,000. How many of us can actually afford that? No, right? So it's a problem. On one side, people are living in the blue zones who are actually living longer. On the other side, people are living in wealthy environments and actually having longer lives. But the biggest problem here is there's a huge longevity gap. People living in cities like this, people like us, people living in other cities where we have a huge longevity gap where we don't have access to all those facilities or the environments in the blue zones or the wealthy cities. So how do we reduce the longevity gap? That's exactly when we started the Aging Speed Project, where this is probably the largest human study ever to find, slowing the aging speed of humanity and also find the root cause, how do we slow the aging speeds? When we started this, for us, I think 2 things were very, very important. One is make it very, very accessible to everybody who can access it anywhere, any place. And second, the cost. It should not be $20,000. It should be very, very cost effective. So what we did with this was, how do we start? How do we help people actually slow their aging speed? There are actually 2 steps. Let me go back. There are 2 steps. One is we have a face scan, okay? I'll show you this. I can't show you a demo here, but I can show you a demo off stage after this talk. But with just a face scan from your phones, we're able to detect about 50+ biomarkers. We're able to tell your aging speed instantly and what are the drivers actually driving your aging speed. Everyone's aging speed is different, and we are actually able to find out. So it's a simple scan like this. I was just scanning myself sitting in the speaker lounge. It takes about just 30 to 30, maybe 35 seconds. It scans. It gives you the vitals like blood pressure, your HRV, your heart rate, You name it, we get it. So once you scan this, I mean, like I said, it's a 30-second scan, you get your aging speed. So it says here you're aging 1.3x faster than your normal chronological aging speed, right? So you're actually aging faster. But it also gives you the peak signal, which you see on the top, that is the key signal where it is important for your aging speed. If your peak signal is slow, you're aging not good. It also gives you sleep quality, resilience, recovery, stress, and also vitals. Everything you get on an Apple Watch, everything you get on an Oura Ring, everything you get, everything everywhere, instead of buying the device. I'm not saying not to buy a Garmin, but I think let's keep that going. But we will, all that stuff which you are getting, actually we get in just this face scan. So the second step is once you find out your aging speed, we also tell you how do you find the root cause of aging speed, right? So you need to do a blood test. So we have in the US, this is actually live and kicking, and we have a lot of people doing this. We come to your house and do a very exclusive blood test to find the root cause. Once we do that, we can give you your aging speed in these 6 buckets, okay? At a cellular level, what is your aging speed? At your metabolic level, what is your aging speed? Musculoskeletal, cardiovascular, and inflammation and stress, how are they actually playing towards your aging speed? But this is also still a lot of data for people to understand, though it is very, very granular with about 150 to 200 biomarkers. We're actually doing this. So what we do next is going to be fascinating because all this is being converted into 24 aging drivers of your aging speed. And then this is where the AI comes into play. Okay, so we have tons and tons and tons of data from a lot of studies and a lot of patients. And the correlations this AI engine does is incredible. It's like 5 quintillion correlations a human doctor cannot process, right? So when you go to a doctor, they say, okay, if your vitamin D is low, take a vitamin D. If your cardiac system is not good, take a statin. But this is not what we are doing here. When we say the root cause might be completely different from a statin. So the root cause of aging speed is what we detect here. And I'll tell you a case study from a gentleman who was in the US who actually is one of our clients. 50 years, male, we actually were able to reduce his aging speed from 4.3x to 1.1x. He was on 22 medications before taking this program. Now he's on 2 medications. Actually, those not even medications, those are supplements. So across his cellular, cardiovascular, metabolic, muscular, everything improved, and his aging speed actually reduced because his root cause was his mitochondrial efficiency was critically low. All we had to do was increase the efficiency of his mitochondria, everything kind of set up. I'm not saying this is going to be the same for everybody, but that's where the AI comes into picture, and it actually is different for every man, every woman here. And to Ms. Kulkarni's point, when she was in her session, it's a completely different panel and a study and data for women, and it's a completely data panel for men. So it's also taking into account different geographies, different demographics as well. So when I said about the Aging Speed project, today we actually, in this study, we have more consumers than this, but in this study we already had 200 consumers, and we were able to reduce the aging speed by 2.2x. And this was done in a location called Arkansas in the USA, where that state is not particularly that healthy. So the idea was, if we can do it in Arkansas, we can do this anywhere in the world, including Hyderabad, right? So because the aging speed, I don't call aging speed, but the life expectancy in Telangana is 72, the health span is about 58, means people live only till 58 in a good lifestyle. But if you can reduce aging speed, it can probably be more than maybe 85 or 90 or even 101 plus. That's the core concept here. So in the US, we actually did this with a 5-star hospital called the Arkansas Heart Hospital. I think Dr. Murphy and his team is actually sitting right here. He actually spoke before. And that is the partnership I think we explored, and we did through a clinical partnership. We were able to do this successfully, and that's, I think, we will be launching this in India very soon in the next couple of months. And of course, if any hospital system wants to talk to us, we're open to that. But again, this is a completely different take on healthcare. It's a completely different care of a young generation expecting some convenience and cost and affordability. But again, can we design a blue zone? I think we're already doing it. So if you want one takeaway for next year's conference as a theme, try to slow your aging speed, and we are here to help. Thank you.
Thank you so much, Uday. I think I really appreciate the wonderful panel we've had. Really appreciate your patience staying on stage and sharing your wisdom with all of us, and thank the audience for an amazing, patient listening, and hopefully you've learned a lot. We've approached the end of this conference, and we should be having the next few minutes of just a real gratitude session, and then we'll quickly have a group photograph with this group, and then we should be good.
Thank you, Doctor, and thank you, guest on the stage. That was a truly global lineup to close the day. May I request the speakers to kindly be back to your seats. As we conclude THIT 2026, may I invite Dr. Sujay Kar for the closing remarks and vote of thanks. Please give a round of applause.
Fag end of the day. I just checked the mic whether it works. Ladies and gentlemen, please take your seats. We're not done yet. In fact, we're beginning for the journey between the two conferences. Dr. Sai, it has been an extreme pleasure for everyone at Apollo Ecosystem to bring our friends, colleagues, researchers, and, fantastic people, scientists and others into these two conferences that we have had. We have had over 100+ sponsors without whose help we would not have done this. So big round of applause for our sponsors for that incredible support that they have been doing this. But I'll not be right, rather, if I don't talk about the people behind the scenes, our volunteers, Professor Ganapathy sir, for the last 6 months, you have worked incredibly hard to actually, put this together. And not only this time, but over the years, and been the beacon of hope for all of us. Please give him a round of applause for the exceedingly good work or great work in bringing all of this together. I will go about in taking the names of my leaders, of all of the other people who have contributed in bringing this. But of course, my own leader, Dr. Sangeeta Reddy, for championing this. And you heard from her yesterday and today about how we go about in our mission. We also had people from 40+ countries, and which is the highest in any THIT conference so far. And we're represented by top thought leaders coming from academia, coming from industry, coming from medical device companies, coming from every nook and corner of digital health with one mission: how can we improve the world? How can we go about in going to the last mile, improving the transactions between our caregivers and our patients to benefit their outcome? My colleague with whom we possibly would start working, he was the last speaker of our conference. He talked about longevity. And that's one of the mantra that we are looking ahead, where we want to go about in doing this. But not without having the earth green. We have to look at all of these from a perspective where we see that there is a benefit for people, there is a benefit for the planet. And that's what we are looking at. I hope, Spiros, when you go back to US tomorrow, you don't fleet up with the cyclone bomb that you have there. You know, hopefully all of things would be good. So once again, thank you, one and everyone. If I have missed your names or if I have missed the contributions of yours to this conference, I'm sorry, but you have been an incredible part for this THIT. We will be back soon. I cannot name the city where we are going to be, but I have been told that there are beautiful sunset in that city. Now guess what, where we will be in the next version of this conference. Once again, thanking you everyone for this lovely conference. Hope you enjoyed, hope you had a lot of things to ponder upon between the two conferences. Thank you very much. Bidding adieu.
Thank you so much, Dr. Sujoy. That was a really wonderful closing line. Ladies and gentlemen, 2 days, hundreds of ideas, one shared mission, better healthcare for all. Thank you for being part of THIT 2026. Safe travels continued. Okay.
Can I have Ashish on the stage, please? No, come on. I missed out the Madhuri Dixit of this conference. Now, many of you who know Madhuri Dixit, you will know Ashish. Ashish, final words from you.
It's been very hectic, but without the team, there's nothing that is successful. So I really thank all the team, mentors, Dr. Ganpati, Vikram sir, Dr. Sujoy, Ashokan sir, Dr. Sai, for the tremendous amount of support provided to us and the guidance provided to us. The console team, yes, they have been doing a fabulous job, so they are part of my organizing team. Really amazing, and I hope everyone liked the entire program, the flow, and the experience was amazing. I would request all the volunteers, the organizing team, scientific committee team, please to come on stage for a group photo.
As I conclude, safe travels, continued collaborations, and we look forward to welcoming you next year. Good evening.